or cold tumor? So this question is actually universal, and the short answer is no. We actually don't know the patient is actually having a hot tumor or cold tumor, even until 2 days, right? So if you look at the main research question in here, I mean, okay, this is a bit old, I put 2025. So obviously this question is still there, I mean, not solved this year, right? Number one, we call ourselves precision medicine and personalized precision oncology era, right? So I myself chair the biomarker committee in SITC, the Immunotherapy Society. However, you know, like after 10 years, 15 years of our work, we still only have PD-L1. PD-L1 IHC staining is still the only gold standard for immunotherapy treatments, right? And then obviously we know MSI, TMB is actually not bad, but I'm sure that even in, you know, like US and UK and all these countries, there are TMB and MSI using it as a clinical routine practice is actually pretty rare. Yeah, so meaning that we have spent so much effort, billions of dollars in research and grant and all these things, the outcome that we are proposing, you know, the biomarker, you know, new drug target, or blah, 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 they are not going to go to clinical, right? Because they are a fundamental problem, right? We do not even know this tumor is hot or not. And do we not knowing how to do it? We know. If you, as a pathologist in the room, right, you know that looking at microscope, scoring TILs, right, tumor infiltrating lymphocyte, which is like take you like 3 minutes, right? But we are not doing it. Yeah, right, we are not reporting it usually, right? And also even staining CD3, CD8, IHC is actually very cheap. I would say the cost at most $100. We are not doing it as well. So meaning that any single new marker, new technology, new assays are not going to help our patient. So we believe that AI is actually the way to go to fill in the gap that potentially all these biomarkers can be helping our patient, right? So that is actually lead me to talk about the HE 2.0. I think if you listen to my talk a few times, this is actually a, I would say, old concept. I have talked about this since 2018, you know, like basically talking about HE, 100 years old technology in the new era of AI, cloud-based technology, digital health, and spatial technology. We will have a new version, and this new version will tell us many things. I will show you how to use it later on, right? So what is spatial technology, right? So this is to the benefit of some of the audience here. Basically, spatial technology is that, again, your tissue, and then you apply a technology on it, and then this tissue, every single cells on that tissue, you can profile their, you know, whole transcriptomic, which is 18,000 genes. At the protein level, probably about 100. And also, and then you also can put it into something like this. If you're interested, you can use your phone to scan a QR code. You can show this as well in your phone. And this is like helping you to visualize, manage the data, and also help you to automatically analyze the images a little bit. And this is important because all this new technology, for example, these images is actually 20 gigabyte. And we have some of the images, like one image is like 1 terabyte. If you do not have a spatial technology, like a platform like cloud-based technology on your computer, you have no way to actually even open that file. So that alone, you will actually gain benefit from those technology and data. Sorry. So as I say, you know, our group has been working on these spatial things for a long time. I would say even before there is this terminology. We focus on, obviously we publish a lot of paper, but we really focus on bringing the research outcome to the market, to the clinic, to the patient, right? So we have done it 4 times. And one of the before I talk about it, what is the thing that we really translate, come back to the question, right? So I asked the question in the very beginning that do we know whether our patient have a hot tumor before we give them immunotherapy? So, and then later on, I show you all the AI and also this spatial technology to show all the immune landscape, meaning that all this can be done, right? It can be done, right? It's not like you don't have this technology. We do have this technology. However, the problem is that you can't apply this technology to your patient because there are many, many problems, right? They are expensive, they need particular technology, machine, need particular talent. You have difficulty to retain the talent, especially in the public sector, public hospital. And all these things that I have been showing to the people is that, you know, when we as a scientific community, a lot of the time we forgot that the business mindset is very important. That's why, people like Hicham, he will be very, useful, in the community, because when you know the business mindset, a lot of things actually, you will look at it in the different angles, right? Because science is good, technology is good, but we can't use it, that is actually useless, right? So how do we have that mindset? So that is a terminology that we use a lot now. It's called appropriate and value-based healthcare, which is, yes, the technology and science is good, but how do we use it to benefit patients in a very cost-effective way? So that is the time that I introduced to you a concept called personalized medicine 2.0. So before talking about 2.0, let us look at the classical way of looking at personalized medicine. Personalized medicine, basically the key thing is that you have tissue or you have blood samples, and then you put into new technology, whatever, to actually test new biomarker, new technology, new assay, and some of these positive and some of the negative, right? And your oncologist, you are waiting for your oncologist colleague, amazingly, conclude all the data and result, and design a personalized management plan for this patient, right? This is basically the concept. I don't have a PowerPoint, I actually do, but it doesn't show here. So the plate of this testing is actually very full, even in the targeted therapy era, the molecular era, let alone the immunotherapy era. And now we are heading into ADC era, cell therapy era, and all these things, right? So this is very full in that plate. You actually have difficulty to have resources by all means, any resources to test more, right? And then also we ask another question. A lot of these tests, the negative results are actually redundant, right? Think about it. You need to know this patient is PD-L1 positive to treat this patient with immunotherapy. But you do not need to know this patient is negative to actually decide not to treat this patient immunotherapy, right? You do not need this negative evidence, right? So we would like to propose that we can actually skip the negative results. So if you use AI to do a triaging, so based on the samples, it could be blood, it can be H&E or whatever, to actually rank the test that you are offering to the patient, right? So you choose the best possible positive test to the patient, and you do the test first. And very likely, the first few tests that the AI selected for this patient already show you sufficient positive result for you to actually design a personalized medicine for this patient. So this is the 2.0 concept that I will show to you. It's basically a health economics kind of concept. So as I said, this is a concept, and how do we prove this concept really work? We need to apply back to our own domain expertise, right, which is in the H&E pathology setting. So again, you have a H&E, you predict multiple different biomarker, and you choose the best to actually validate it, confirm it, do a confirmatory kind of testing, right? And then you really use it for the patient. And you are not bypassing anything because you are still doing the test, right? So why are we doing all these things? Because we have found that long time ago, I think I would say this is 2017 or something, we have found that you can register all these images on one section. So the spatial, the multiplex immunofluorescence, and the HE are on the one section. So every single cells on this section, you can actually feed to the AI to learn, right? So this is in our AI terminology, we call it a perfect ground truth. It's really in the AI learning nowadays, the problem is not AI. The problem is that whether you can find a ground truth for the AI to learn. As long as you can do it, the AI will do amazing work. And we have found these things long time ago, so we actually talk about the H&E 2.0 is a concept that now is widely recognized, and also because you feed into the AI in single cell data, so the output is also single cell data, so it looks like an actual staining, so we call it virtual staining, and again, this is a widely recognized terminology now. This is actually everybody working on it, and because you can visualize them at a single cell level, it's actually become an explainable AI because you actually can apply your domain knowledge. Oh, this is PD-L1 expressing should be on tumor cell and myeloid immune cells, macrophages, dendritic cells, but not on T cells, right? So if the AI algorithm works for these particular images, then you feel confident and comfortable to use it for your patient or for your research, right? If not, sometimes it's happened to be not, right? Because, for example, our AI algorithm never seen any African sample. It could be wrong, right? And then, but if it's something wrong, you just, go back to your own practice, right? You just don't use it. So human is always in the loop of this AI decision making, and this is safe, just like how you use your GPS to drive, right? So H&E, again, like multiplex immunofluorescence, and then you can see that this is very similar to axial staining. And we even licensed this, some part of this technology to a Canadian company to actually market it out. So that is actually how we actually hit it to the market for some part of it. But I want to show it to you more part of it, because this is actually not, this is it's a concept, it's a technology that you can apply universally across multiple things. So our biggest, I would say biggest success of using this technology is in a clinical trial setting. So as you know that as a clinician, clinical trial is actually, the patient can find them difficulty to actually assess a right trial and in time. But honestly speaking, as a clinician, as a lead PI of the clinical trial, you have difficulty to recruit patients in time as well. And most of the time, clinical trial, even you already go into the clinical trial, we always call ourselves into the clinics, right? But you still have 90% of the chance fail, and this result in $9 billion USD loss every single year, right? And the major part of it is actually recruitment too slow. So we can look at it, let's say this biomarker is actually PD-L1. So if you close your eye, testing patient PD-L1, about 20% positivity, meaning that if you want to recruit PD-L1 positive patient, you need to just scan through like 100 patients, and then you get 20 patient positive to recruit into the clinical trial. And there are 80 of them, like wasted, right? The resources and all these things is one thing, but the time really is the money. So if you're losing the time, and then you fail the clinical trial very likely, right? So in here, using AI, you actually, only select the best possible positive patient to do the PD-L1. Very likely, the first 20 tests you already recruited enough, and then you can move on. This is number one. Number two is that because H&E, every patient have it, so there's no additional cost. And AI at the implementation stage, also there is no additional cost, right? So you actually can apply this triaging effort to 1,000 or even 10,000 patients. So the 20 that you actually recruited ultimately is likely to be a responder, and this is likely to be a successful trial. So we use this concept and technology to a drug that we actually developed by ourselves. It's called EBC. Okay, I actually not allowed to talk about the name now because it's embargo at the moment. If you know what does it mean. But this trial is actually again FDA fast track designation last year for PDAC, and is going to get a fast track designation this year for gastric and esophageal. And also, you won't hear from me, this is going to be a successful story. So as a pathologist by training, we developed the immunohistochemistry staining as a companion diagnostic assay. And we also have the AI version, the HE 2.0 version, like to complement this. So there are two versions of this to actually help this ADC drug to actually ultimately become approved. So let's pray for it, and then this is the clinical portion, and the research portion is that we published a Nature cover story last year in April 2025. I wouldn't go into the paper because it's already published like a year ago, but I just want to show you, these are all the cover story of Nature last year. Only one is biomedical. There's usually Nature feature, like black hole, or your spaceship to the moon or whatever, right? Safety of your fruits or whatever, or water pollution. So biomedical story is very small to them. But they feature us as an AI story because we actually have a way at that time, even in 2021, the majority of the work was done at the time. We have a way to actually, make sense of 162 trillion data points from there and make a sense of the clinical kind of like decision-making kind of AI in there. I won't go into details again. And this end of last year, Chinese government actually voted these particular works as their top 10 technology. And guess what? We are ranked number 4, and number 3 is DeepSeek, which is, I don't know, if I'm DeepSeek CEO, I totally drop from the chair, right? So, we cannot be similar, but again, this is how they work. So how do you use this kind of thing back to the story, right? All this looks good. Scientifically looks good. Technologically looks good. But how do we benefit our patient, right? Because obviously, the AI works, and also the Nature paper is talking about NK cell marker, blah, 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 right? So, and use a lot of this high-end technology and take a lot of time. How do we actually work in the real world is actually another problem, right? So come back to this story that we also developed this pathology MMR that we recently just concluded this study, and we are talking to Hicham to actually include some African samples as well. We have about 3,000 patients that we actually use. I mean, I'm sure that most of the people know MMR, basically just 3 staining, 4 staining, and then we actually concluded this is like already a cheaper version compared to MSI in some of the country, right? So we now want to use a H&E version to even, like has a surrogate for MMR. So you just use H&E to predict MMR, and because of this surrogate, and then you can also use MMR, the H&E version, H&E 2.0 version to predict immunotherapy response, which is at the moment is actually our own cohort is a AUC 0.8, which is amazing because your PDL1 is at most give you less than 0.5. So I think I have about 10 minutes left. So the next 10 minutes, I want to show you some of our new technology. It can be a bit fast, but like just to give you some sense of our lab. What are we working on it now, and what is the future that we are hitting? And feel free to discuss with me offline and all these things, right? So as you can see in here, we highlight every single technology more. Basically, AI, in the AI era, we are just doing this, right? You are using AI to actually gain more with less, right? So first of all, why do we do that? Because we actually getting less and less tissue in the next 5 years for cancer care. Don't you think that? First of all, most of our cancer management become, going through early detection. So when we have the patient surgical or whatever, the tumor is very small, right? Sometimes even smaller than 1 cm or 1.5 cm. This is number one. Number two is that, again, the cancer care moving to neoadjuvant, which is that actually you treat patient first before the surgery, right? So again, after your surgical remove the tumor, sometimes there is no tumor. Or sometimes, like the tumor bed is very, non-viable, very necrotic, It's very difficult for you to do anything. And also liquid biopsy is another thing, right? So we are getting less and less, but all of us are actually research in new technology, new marker, new assay to actually want to do more for the patient, which is like a paradox to me, right? You can't solve this paradox unless you use AI, right? So I'll skip this one. And then, so to gain the time, right? So to have something to really implement in the real world, you need to have a very fast turnaround time. So we actually use AI to do something called pseudo time. Basically, you can see that this is actually a AI-generated video to show you whether this particular single cell is actually a T cell moving in, becoming an activated, matured T cell rather than a naive T cells. And then this particular biological process in the real world is actually take you weeks, but we can show you in seconds, right? So this is not only using for histology, pathology, but also use it for drug testing and all this. I'll show you to the next slide, right? So we show you in tissue, but can we show you in a real single cell? This is real, right? This is not on tissue level. This is suspension cells, right? This can be applied for your peritoneal fluid, pleural fluid, urine, blood, whatever, right? Same concept. You have single cell at the raw images, which is the gray color images, and then you have the biomarker that give the AI the perfect ground truth to learn, right? So then ultimately, like this one slide, these images, the biggest images have millions of cells on it, and then you just put it into one of the scanner. I'm sure that most of the scanner in the vendor, in the partner, they can do this as well. This is not a rocket science. This is very simple. It's called DIC or phase contrast. So you just scan through, basically like a few minutes, like I would say less than 5 minutes, you scan through millions of cells, and even without staining. So the images will be like the gray color, the DIC, which is the raw images. So the raw images will tell you whether this is actually a tumor cell. In fact, there are 3 tumor cells among all the million cells, and then surrounded with 4 activated T cells, right? And the beauty of it is that you can still stain them. You have the images, you stain them, and then confirm this is really what you want to see. So there is a ad hoc on-site, immediate proof whether your AI is actually working or not. So now you know that there is, we can do the video as well. So this is AI-generated video from the single cell to show you that particular single cell is evolving into what kind of cells ultimately, the cell destiny of it, right? So now even more interesting, so for the benefit of most of the pathologists in the room, so if you can look at it, look at these HE images, tell me if there's something wrong in these images, right? I just show these images in a few other pathology society. Nobody can tell me whether this is something wrong. In fact, this HE is actually a simulated HE. It's not a real HE. It's actually from these raw images. And again, this is not rocket science. I'm sure that most of your vendor out there, outside in the sponsorship, they can achieve this, right? And then you use this to simulate the HE, and after simulated HE can be used for HE 2.0 to actually simulate your biomarker, like PD-L1, MMR, whatever, right? So this become like something like this, right? The raw images, HE, and the HE show you CD8 T cell. And then you look at it, it looks like, oh, that really looks like lymphocyte. It's making some sense, right? So then you can accept it and then move on. So now a test, okay? So tell me which one is real and which one is wrong. So the first pair, the left-hand side, the first left-hand side is real. Please raise your hand. Nobody raise your hand, meaning that you think that the second one is real. Okay, if you are getting wrong, Hicham is not going to give you dinner tonight. So the second pair, what do you think? Which one? The last one is the real or not? Raise your hand. Real. Okay? So most of the people are voting for the second one. So actually, most of you are wrong. The ground truth are at the left-hand side. So this is a study that we are doing now. So feel free to scan the QR code to join this survey. So we already have our first round of survey done, but please feel free to join. And then we are getting, I think, more than 100 pathologists around the world to actually do this survey. And also, at the moment, I think we have about 100 of people, if I'm not wrong, I think somewhere here. And then we are getting good signal. I hope that you are also give a good signal. I mean, we in here, it's actually not going to take you a lot of time. I think this is like, at most, take you 5 minutes of this survey. Okay, so scan the QR code if you're not yet. Okay, and then, okay, look for me as well if you are not, if you are interested. So why are we doing this, right? And then sometimes when I present this, people like come to me, you know, like, Joe, come on, HE is very cheap, very easy to do. Why are we skipping it, right? So there are a few scenarios that we can think of. And in fact, to be honest to you, we are not the one that came out with this idea. We have this technology for a while, but we never know, we never think that this is useful. But until one day, a private hospital come to talk to me. They said, this is actually interesting. We will gain a lot of time if we have this. So we can retain patients. But some of the patients, if you give them a little bit earlier information, they will stay in this hospital. So to them, it's important, and I believe this will be useful for global health impact as well, because if you imagine if this is validated and very stable, and you will skip the lab, right? You do not even need a lab. This is chemical-free pathology, right? For some of the very rural and remote area, and you can centralize all this actual staining in a real big city, and then you can actually triaging and also manage all these things a lot better, right? So these are all images we will see. We will have new photo this year. So just to close the loop of the global health setting, so me and Hicham has been working on ER project as well to predict, ER for rural and remote area kind of setting. At the moment, our data for Indonesia and Malaysia are actually quite good. We are still working on, the Moroccan kind of setting. We hope that we will get some better outcome, especially after these 2 days. I actually exchanged some new knowledge with Hicham on the problem. But also, I want to introduce you, we already talked about HE 3.0, but we actually have a 4.0, which is a 3D solution, and we are going to talk more in the AFSDP this year in June. So if you are there, and then, you're just looking forward and stay tuned, and then I'm just helping Norman to actually advertise a little bit with commission. So, so how do we apply to this blood? I think I have like 1-2 minutes, very fast. last part of the story is about aging and population. I won't talk about aging in Asia, why all these things. So skip to the point. So our group now working a lot more on aging and population health because I'm actually a clinical pathologist in our setting. So I deal with blood more than tissue actually. So I will tell you why we actually think this part of the work, actually blood is better. So we actually just published with a lot of global consortium on this particular paper in Nature Aging, talking about globally different population that age a little bit differently. And obviously this is like, everybody know, right? But we prove it and show it evidence and all these things. This is actually, again, widely covered by all the media. And basically the graph is the gist of it. So if you look at the Singapore compared to Italy, which in the paper we call it industrialized kind of societies, our aging pattern and gradients are very similar. However, if you compare Singapore to Malaysia, Orang Asli, which is an indigenous group, so we are kind of like spatially located the same place, but we age very differently, and how the Malaysia Orang Asli age is very similar to Bolivian indigenous, which is actually an Amazon tribe. So we are asking why, right? And I will skip this also. This is like a Singapore National Strategy cohort that I am lucky to be the PI of it. So it's actually a more than 20 years cohort that they are following these 10,000 patients, healthy subjects, like across the last 20 years. And then we're using all this technology to actually see whether the first blood that we drawn from them, like 20 years ago, 2003, can we use that blood to develop some technology, AI, and see we can predict their health trajectory of the next 20 years, right? So basically, this is a simple concept, and obviously applying back to our stronghold, which is the cancer setting. So we ask this question, right? Come back to the story that I told you. So the industrialized people compared to non-industrialized people, what is their key difference? You can hypothesize multiple different factors, but we wanted to try to focus at the first thing is actually exercise. Because exercise, you can design clinical trial to test them. And also, if we actually prove it, right? So we can influence the government to actually do this as a policy. So all these are, like doable, right? So we have designed 5 clinical trials to actually for exercise, and they are all completed, and we actually using the data. And basically, this is exercise clinical trial, meaning that they are really coming back to the community hospital to do a particular exercise program with us for 3 months or 5 months, something like that, right? So then we have their blood tested before and after, obviously in between. So cut the long story short, this is my last slide, I believe. So we found a blood signature that actually, this is not my last slide actually. So I have found a signature from the blood to actually know whether this patient is going to get to actually have cancer in the next 10 years, right? And this signature from the blood can be reversed by doing 3 months of exercise in our program. And this is something that we think is very interesting, and all these markers are new. But the key thing is that, again, come back to my first topic, health economy. How do you translate this and hit to the market and benefit your patient? So we take one step back. So we don't want new marker. We want to see the same patient, can we have something very basic to do this, the same thing. So we use their blood test result, the routine blood test, like full blood count, creatinine, albumin, the kind of thing. So we use AI to actually compute a scoring system. At the moment, we call it BioAge. And this BioAge is actually validated not only in Asia population, but also in US, UK Biobank, and also in Chianti, which is the Italian population. And if the BioAge is actually high for this subject, and actually the 10 years all-cause mortality is very high. So this would be my last slide, real last slide. And don't worry, if you happen to have high BioAge, there are a few ways to save you. You can do more exercise, you can eat more fish, you can eat more plant, and then you can drink more green tea, and cut down smoking, alcohol, and coffee. Thank you very much. And we have done the AI agent for it also. So if you are interested, please scan this QR code. You can test for yourself. So this is AI agentic. It's just like your ChatGPT. You can chat with this guy. They will tell you some health advice. But I have disclaimer. This is not from me. It's from him. Okay. So ready? QR code. And the beauty about it is that you see whether I show you this strain, right? You can test it almost, if you want, every month. Yeah. Okay, so I don't think I will, repeat and summarize what I told, but I think you probably walk out this room, remember a few key messages. Personalized medicine 2.0, the health economic concept is very important. And then I think HE 3.0, 4.0, I'm going to talk about in June in AFSDP. And then the aging and population health things, which is, to me, is actually our best interest now. And with that, I thank many people around the world. And of course, welcome any question. Thank you.
Thank you very much, Dr. Po. I think we can take some questions. Yeah? Do you have a question? No? Thank you for your excellent presentation. Okay. Yes, I have one question for you.
Yeah.
It's about our countries in Africa. In many African countries where medical resources are severely strained, though, how realistic is your AI trade model for us?
Yeah, actually that is the part that I was last year, the first AFSDP, after that, HR and I have a collaboration on the ER. And then I told him that we are going to present this data this year here, right? But unfortunately, it's a bit challenging. So because we will analyze this a little bit later on also, but I think the samples, it's a real world sample. So the samples come from everywhere in Morocco, and then obviously the fixing time, HE standing, and all these things may be a little bit different. So our model's not so working that well at the moment, but we are trying to work on it. So, and also now we are starting the MMR program also. I hope that the MMR, if we use MSI to replace the MMR, then it could be more stable, because you already have your MSI done, right? So then your MSI, from a genetic profiling point of view, you have a lot of QC and also like the sanity check, better than the IHC setting, I guess, and the HE. So I think if you use MSI as a surrogate for MMR, and we use AI to predict that, I would say maybe a stable. There are multiple ways we can solve it, but it's a good lesson learned for everybody that a lot of, but no surprise, because a lot of the things that, you look at US things, very, very good. For example, I just give you a very big thing. For example, one of the biggest algorithm in AI pathology is like GigaPath, right? So in fact, those are our friends also. So GigaPath and also a lot of these are like the MSKCC algorithm or these things. We have tested in the Asian population, it doesn't work as well. So so I think this is just, you need a little bit of global effort on this collaboration for a universally applied AI algorithm.
Thank you very much.
Thank you.
Is there any other questions? Thank you. So you continue the session. We continue the session with the presentation of Professor Greggy. She's a pathologist and friend. She's my friend from Casablanca. She's in the University Hospital of Ibn Rushd in Casablanca. She will present, can digital cytology and AI make thyroid more accurate? Thank you.
Thank you, Professor Abawi. Hello, everybody. So I am Professor Mariam Gagi, and I come from University of Hassan II in Casablanca, and working in the pathology lab in Ibn Rushd University Hospital. And just to be honest, we don't have all slides color. So yes, that's the daily life. And so I was pretty curious several months ago when Hisham asked me this question. Can digital cytology and AI make thyroid cytology more accurate? And that was really curious. I thought I need to search for that, especially that I deal a lot with cytopathological thyroid cases. And as you all know, ultrasound basically, it's just coming with more and more thyroid nodules. We are using ultrasound everywhere. And we moved from 5% of palpable nodule to 60% of adults having a thyroid nodule. As cytopathologists, we use the Bethesda system for reporting thyroid cytopathology, but in daily practice with conventional FNA, we deal with a lot of issues, especially when we have low quality smears with low cellularity, very hemorrhagic smears, with the variable staining or sample preparation according to the facility we work in. There is a huge inter-observer variability, and we have to deal with this indeterminate categories, the categories 3, 4, and 5, and we have an endocrinologist or an NT surgeon behind us that urges us to make a decision, call it benign or malignant, so that we can choose if we can get an active surveillance or we have to go for a surgery. So this is a pretty heavy responsibility. So, to the simple question, can digital cytology and AI make thyroid cytology more accurate? The obvious answer is yes. How? So, yes, we can use telepathology platforms, especially to get access to those remote areas and to get the diagnosis. As I told you, we see that we have a large and rapid growth of thyroid nodules that are diagnosed. We can use it as second opinions, as we can share cases with other cytopathologists through the world or through the country, and for educational purposes. Instead of training our small 5 or 6 residents in the facility, we can go and train maybe the whole country and get to share the experience. ROSE, Rapid Onset Evaluation of Thyroid Nodule, is pretty cool tool to assess the specimen adequacy. So we get less of category 1, non-diagnosis category, and we also get to have a preliminary cytological categorization, so that if we get an indeterminate category, we can have more sampling. We can do another sampling just right away and have some more cellular cells to get for ancillary molecular testing. So, digital pathology can be helpful in this setting. There are several options. We don't need really whole slide image scanning, but we can use a light microscopy with static image and sharing the screen. Dynamic telecytology with streaming live images, and when we can have it, we can do hybrid telecytology by using live streaming or acquiring whole slide images. And in this setting, we have to choose a whole slide image scanner that can process rapidly on time to get a rapid answer. So there is this study that evaluate digital pathology in a ROSE setting for thyroid FNA. It was based on, they had about 96 FNA, and they did ROSE, and 2 weeks later, the same pathologist reviewed the slide with light microscopy. For the average scanning time per slide, it was 5 minutes. It was pretty good, ranging from 1 to 23 minutes, depending on if we need the Z stack or not. And they found that, it led to it was a good there was a good concordance between results in ROSE and light microscopy 2 weeks later. So, what about AI? Certainly, AI can enhance diagnosis accuracy, helping in triage system, reducing uncertainty in indeterminate case, and spending the time spent on slide, especially those of low quality. Thyroid cytology can be really time-consuming for those who do thyroid cytopathology, especially if slides are of low quality. So yes, it can shorten time spent on slides. So we can use it as diagnose super tools. It can help us to prioritize case atypical or suspicious, with giving them an answer more rapidly than a benign case. It can help us flag atypical areas and give us a second opinion just to support our opinion in indeterminate categories. So, you go on PubMed and you just get to write artificial intelligence and thyroid cytopathology. You get a lot of studies. There are a lot of models and tools and AI tools that can be used in this setting and that show their efficiency. I choose to talk about this one because it was a robust one. It was a study performed in China. The AI model was trained in using more than 11,000 slides that were collected from more than 4,000 patients and then validated on more than 5,000 slides from 4 different hospitals, and then prospectively used on 400 people. And they saw that there was a lot of agreement between their tool and senior cytopathologists, and it was a helping tool to boost the accuracy of less experienced junior cytopathologists in their diagnosis. AI can also help to predict molecular alteration using some morphological clues. So the genotype BRAF muted or RAS muted has some particular morphological aspect that features that can be diagnosed by detected by AI. It is really interesting in low and I would say middle and low income countries because we don't use we in our country we still don't have molecular tests for indeterminate categories for thyroid cytology, and those indeterminate categories are really hard to manage. There is a certain clinical uncertainty, and to talk about numbers, we have something about 20 to 30% of indeterminate categories, and in those 20 to 30%, there are 10 to 40% that are really malignant. And we have really to choose those who are malignant to go on surgery. Thyroid surgery is not that harmless. It is a surgery, and it can be complicated by recurrent nerve paralysis, hypothyroidism, hypoparathyroidism. So there are a lot of issues in this surgery. So we really have to pick the right ones to undergo surgery. And in this setting, there was this study launched by Zone who proposed an integrative model that combined not only cytology, but also radiomics, ultrasounds, and clinical risk to assess the risk in these Bethesda 3 categories. And it shows that it has a really good accuracy, sensitivity, and precision in this setting to show which category 3 lesions are really malignant. So, how does it work in the routine? There are some modeling deep learning and architectural variables, so we can use CNN, MIL, or hybrid DL platforms. For the MILs, they are really useful in cytology. They lessen time and inter-observer variability with improving performance and interpretability by employing attention pool-based pooling. Really helpful in distinguish between benign and malignant. They are less useful in the indeterminate categories, and however, they need a large data set to be validated, and they are limited by the sampling play, especially in the indeterminate categories. So if we exclude the indeterminate categories, it works pretty well. But if we integrate them, that the model lessens. For CNA, it's leveraging subtle morphological variation and features to distinguish malignant from benign. Of course, we have to annotate the region of interest, and this can be quite time-consuming. It also requires large data sets to be validated, and it has the famous black box effect. So I was pretty jealous, to be honest, when I saw that the solution of AI, FDA approved in ultrasound, existed from some years ago. We still don't have that in cytology and in thyroid cytology. So I was wondering what was the problem? What is slowing us in thyroid cytology, and why can't we use these AI models, these multiple AI models that we see in the different studies in our daily practice. So there are some challenges that we need to overcome. First is the pre-analytical variability, second is the annotation bias, and the third is the domain shift. So in thyroid pathology, we use different stains. We can use DIF-Quick, we can use PAP, we can use HNA. In our facility, we use PAPs, but the others, there are a lot of stains that can be used. So it is a challenge for digital acquisition and downstream deep learning analysis. And with the same stain, I use the same stain, I use PAP, but with different protocols, such as changing the rinsing time or changing the pH, it can lead to some alteration of the shades and the alteration of the saturation and contrast, leading to some domain shifts in color space. So instead of learning the morphological feature, the deep learning system can learn the color artifacts. Well, there are some solutions to overcome this issue, such as using some classical stain algorithms. They are some way rapid and accessible, and they can harmonize the coloring, but they don't fully address the staining and the structural artifacts. Other solution is the deep learning-based normalization model. These ones are really interesting, but there are still not validation, and their computational load is huge. Another specificity of thyroid cytology, especially when using the smears, is that the slide is heterogeneous with areas of low cellularity and areas with high cellularity. Variable thickness due to the colloid and to the hemorrhage and potentially some debris. So in liquid-based cytology, yes, we have a thinner and cleaner layers of cell, but the problem is that we reduce the colloid visibility, and all the cytopathologists know that colloid is really, really important. Assessment of colloid is really important to predict if the nodule is benign or malignant. It can also disperse Hurter cells since these cells are fragile. Conventional smears have better preservation of colloid and cytoplasmic details, but there is a huge variability in cell, and sometimes there is a lot of overlaps between cells and background. So we can overcome that. We are using Z-stack scanning, multiple levels of scanning. It can lead us to a better visualization of papillary carcinoma features, such as nuclear grooves or pseudo-inclusion, but don't forget that it can increase the acquisition times and the file size and also the computational load. So the solution should be tailored dependent on the technique that we use in the facility and the nature of the preparation. So when we use a liquid-based cytology, we have to narrow the Z ranges within the deposition area. In conventional smear, we should use broader focal range to find colloid-rich regions, which means more benign regions, and to overlap the cellulate aggregates. Another issue that we are facing is the data quality and data sharing. When we exclude FNA with blood contamination, with thick colloid, or with poor fixation or low cellularity, that could generate models that would fail in our daily routine. And for most studies to improve the metrics, those slides that are chosen are generally excluded. When we also exclude indeterminate case and choose only the benign or the malignant, so we have a model with a low value. And then when a model is trained in a single institution, it could fail in another one. And most of the studies that exist till now are monocentric studies with one model used in one unique facility. Now let's talk about the annotation bias. So there is a lot of heterogeneity in cytological materials, and even among experts, there will be disagreement on which field is really interesting or representative for the diagnosis. And that really could influence the mode of performance and its generalizability. So what's the solution? The solution is to get some large data set with multiple expert labeling and hybrid annotation workflow where AI can pre-select a region to annotate and then validate later by experts on thyroid cytopathology. So, to sum up, we have great advances in AI in thyroid cytology, yes. It can improve the cytopathology workflows and accuracy, but we still face some challenges in standardization of the pre-analytic preparation and image quality, and data sets still are limited. We need more bigger data sets, including multiple institutions across all the worlds. So the best, I would say, the best tool is that's one which will integrate clinical risk, ultrasounds, and cytology to have a more accurate and precise diagnosis. And don't forget, we don't have to be limited in our setting. We can just adapt. There is two paths. We can adapt, or we can just wait and see that we get the whole slide scanner. We'd have to adapt in our settings. We have to come with novel models that can use only the limited resources that we have. It is possible. So just think about it. Thank you.
Thank you very much, Professor Greggy. Are there any questions in the floor? Okay, thank you very much for this brilliant presentation. And now let's move to the bladder field, the urothelial carcinoma. So we have now Dr. Camelia Mihalia Radulescu, who is uropathologist at the Institute Gustave Roussy in France. So what is the role of digital cytology and AI in this challenging field? Thank you.
Thank you. Thank you very much for this kind presentation, and thank you to the association to invited me and to present this interesting subject. And I'm so glad that urologist is in the room, because I think that it's a question that interests urologists also. Just let me tell you a bit of history, because urinary cytology was first sent in the manner of analog video-based telepathology in 1968, and was between Boston Logan Airport and Massachusetts General Hospital, and they sent the image of a blood smear and also a urine cytology. And after that, of course, everything became more complicated, and you know already we talk a lot on this subject, the difference between the histological slides and the cytological slides. Everything is more complicated on the cytological slides because this kind of three-dimensionality. In urine cytology, we have more often the liquid-based samples, and the problem is that we must deal with this three-dimensionality for getting a better image. We have the Z stacking, which is better for the quality of the image. We have also more recently the oblique scanning, the multiple camera. All of them try to get a better image and to get more information, more data in each image. And the question is, what do we expect from the AI in urinary cytology? And of course, there are the same expectation that we have for histology and for other subjects, but more specific for the urinary cytology is the screening. Don't forget, I don't know if there is a urocytologist in the room, but the negative for the category negative for the high-grade urinary carcinoma is represent between 70 and 90% of all the cases that we see in routine. The first expectation is the screening. What are the challenges in developing AI solution in urinary cytology? Like everywhere, there are elevated level of complexity because of the different sample preparation, hypercellularity, and all the other ones that we can see for the thyroid, my colleague just said. This reflects a large, considerable amount of time and work to do AI in cytology. Let's start with our Paris system, which is our Bible for those which are doing urinary cytology. And this system is the logical scheme which tell us how to do for classify the urinary cytology in negative, atypical, suspicious for high grade, and in favor for high grade urinary cytology. And as you can see there, the threshold of 0.7 was very mandatory for the classification in high-grade urinary carcinoma. And this NC ratio of 0.7 give us a lot of headaches because each time we were obliged to assess it by our own appreciation. There are a lot of heterogeneity in our appreciation. What about the pre-analytical steps in the slide preparation? As in the thyroid, we have a lot of kind of slide preparation, and the people was interested about how this can influence the results. And they saw that between SynPrep and cytospin, they didn't get every time the same results. And they find that in the cytospin method, they have smaller NC ratio, less prominent hyperchromasia, and they put it on the count of the strong rotation forces during the centrifugation. Also, the people look what happens if they scan the slides with different kind of scanners. They get slightly different results, but at the end they suggest that AI is still a way to enhance the diagnostic accuracy regardless the type of the scanner and the image used. What are the units of analysis for AI models in urinary cytology? There are the cell level that includes also the clusters, the patch level, and of course the slide level. At the cell level, everybody said it's only the NC ratio which is important. The other ones realized that the nuclear area is more important than the NC ratio for predicting the high-grade urothelial carcinoma, and also that the top 5 cells are more important than the average of the NC ratio of all the cells. The other ones regarded what the nuclear membrane and the capacity of the nuclei to be round or more round, and they studied the circularity. And you see that circularity, which is the property for nuclei to be quite round or less round, and the more the nuclei is round, the cellularity is bigger, and also the solidity, which is concerning the convexity of the membrane. Everybody studied different criteria, In this study, they considered the NC ratio, the nuclear size, the chromatin texture, and also the nuclear shape. A lot of criteria, each study with his own. Also on the cell level, they studied the clusters, the cellular clusters, and more precisely the cellular overlap and the cluster density. A lot of parameters which brings them to different performances. The general principle, everybody knows them. They go from the more simple ones, which have the output presenting like a vector or like a degree of malignancy. In this study, they presented each one in his manner, or the more complicated one, everybody knows them. What about the studies on non-gene cytology and which place the urinary cytology takes? You see that urinary cytology is just near the thyroid. We have a lot of studies on the AI in urinary cytology. No, of course, everybody is running after the performance. The performance which can be presented in different manner, of course, sensitivity, specificity, negative predicting value, but what about the gold standard? Because we know that everything depends on the gold standard. Do we take the histological result? Do we take the histological and endoscopical result? The cytologist result, or why not the patient outcome? Another study proved that they calculated the NC ratio, they classified the samples, suspicious, atypical, and they realized that we had a lot of overestimation of NC ratio by visual assessment. That's why I said that this threshold of 0.7 give us a lot of trouble. And thanks to the image analysis, they can tell us you have overestimated your NC ratio. That permitted to improve the recommendation, because our Paris system it's evolving, and between the 2060 and 2022 he's changing, and we have now the recommendation that for the high-grade urothelial carcinoma we can take in account not only the 0.7 NC ratio, but we can start to think about starting for 0.5. And for suspicion that he's more or less than 0.7. Image analysis also can improve the recommendation about the hyperchromasia, which is another criteria absolutely necessary for a high-grade carcinoma. And they realized that this chromacy can go from very hypochromatic to very hypochromatic, and now we can conclude to a urothelial carcinoma even if we have a cell which is not so hyperchromatic that we was used for. For the performance metrics, we have, of course, a lot of study, and this one I liked it a lot because they gave a lot of conclusion, the analysis by category, the high grade, the low grade, also by study, by bladder, also upper tract urinary cytology. They have very good sensibility, and also they talk about risk of recurrence, and they evaluated what does means for the patient. And they said that the recurrence detection can reduce the endoscopy use by 77.5%, which is, I think, very important for the urologist, because we know already that not only that the endoscopy is very expensive, but it can be risky for the patient. And we talk more often about this prediction. And after that, our friend Joseph Chong, that I say hi in this way, talk what if we came up with a unique solution, which is, I find, very clever. Instead of having a lot of algos which are evaluaing the same thing, they try to find an algo who can analyze different kind of samples, the gene, non-gene, and urine. You said he's in the evaluation, and we have a kind of industrial producers which are making the algos on urinary cytology. They have on urine a lot of patients, and the results are quite good because the accuracy goes until 81.25%. It's blocked. Okay. What are the commercially available AI models? And the first one that I present, because I participated on it, it's the Visiosit bladder, which is a French solution, and also the AIX Euro, which is an American one. In Visiosit bladder, it's the algo is quite simple one, as I can say. They analyze the cells' cytomorphologic characteristic, but also the cellular clusters, and the results they presented like a score of between 0 and 1. And more the score is near 0, the test is negative, and the more he is approaching 1, the test is positive. And they are not conclusive on the interval between 0.45 and 0.55. And in this interval, the algo is not quite precise. The report is it's presenting the result like a ATPA score that you can see it there. I don't know what it is saying. And also they are presenting their performances, because they are obliged to present their performances, and they present also the manner that they conclude the result. They inform also about the quality steps in the evaluation of the slide. And I invite the more younger ones. They have a link in which you can test the algo, and you can play with against the machine. And they are put a lot of slides in, and you can test your knowledge in urinary cytology. What about the reimbursement? And in France, they were very lucky because they succeed to have the reimbursement that we call it RHN 2.0, which is a temporary funding and evaluation pathway for the innovative medical biology and pathology procedures. And is only a temporary funding, as I said, and they get it only for 2,000 patients. And they collect data in prospective and comparative and multi-center manner, and they are supported by the non-muscle invasive bladder cancer registry of FHU, French Association of Urology, that probably you know my colleague urologist. And each patient is followed using conventional cystoscopy and also undergoes urinary tests, allowing the comparison between the two methods. And the test is reimbursed by 253 euro, and the hospital actually will get the money one year later. And then we'll see what happened after this study. Do they decide to reimburse the test or not? We all hope that we'll decide we. Yes. What are the conditions? The condition is the sufficiently precise clinical indication, and as I said, is the non-muscle invasive bladder cancer, a clear position on the care pathway, evidence of clinical and medico-economic benefits, and that is the economy on the cytoscopic intervention, a robust comparison with the reference standard, the data collection plan acceptable for the authorities, and the appropriate regulatory and clear billable medical procedure. What about AXMed cytology? They are different from the VisioCit algo because they presented a cell gallery, and they present the number of atypical cells, the NC ratio, and that they let the cytopathologist decide if it has enough of cells which permit him to conclude high grade, suspicious of other category of Paris system. They also present their results on excluding out of focus zones, which is quite new, and on excluding out of focus regions, they have more performance results, and the sensitivity is around 92.5. But what are the selection criteria for these algos? Is that ergonomics, versatility, interoperability, performance, results, methodology, publications, or unfortunately we know that more often is the cost. There are there are many publications which present the methodology for analyze what about each study. Is a study quite robust, and they give many criteria by which we can evaluate study and algo. And in Appraise AI, they give 24 items with a maximum overall score of 100 points for evaluation. And there are also Quadras AI and Probast Plus. There was a global survey initiated by American Society of Cytopathology, which tried to get the digital cytology and artificial intelligence in this moment. What about how many centers are digitized, how many centers use AI in their diagnostic, and the more interesting conclusion is that AI algorithms are not widely used but strongly suggested, especially in screening samples. Major barriers are like everywhere the same. And what about regulation? Because I wanted to talk about it. In Europe, we have AI Act, which says that the human oversight is mandatory. And also, they said this is the right text, and they say also that the the laboratory or the health professional which are using the medical device must inform the patient that their evaluation will be made by an AI device. And also he must inform the other health professionals. We must inform, for instance, the urologist. Which are the future perspectives? Of course, like the other studies and the other subjects, large-scale validation of existing tools, collaboration and external validation, especially on different kind of population, integration into AI cytology of the other data, MRI, CT scan, cytoscopy. We are waiting for the prognostic and predictive algorithm, and I think that also the urologists are waiting for, which can say which will be the outcome of the patient, identifying specific genetic profilers to tailor the treatments, for instance, FGFR3, Nectin-4, predict molecular subtypes of cancer, drug response prediction. It was already done in ovarian cancer. And of course, future research should also explore the integration with electronic health records. And why not? I saw the article, but probably Andre, we will talk about it. They just published in Nature, and they have image system of acquisition of the image, which is so great, I find. And probably why not using the same system on the urinary cytology. And they also evaluated, I was interested about on different kind of types of samples, SurePath, different techniques, SurePath of SynPrep. We are still crossing the CHEMS, of course, in urinary cytology also. We need infrastructure, but what about cost and financing, interoperability, interconnection, regulatory constraints? We like to have more balanced for this subject. Collaboration, we wait for the registration in the nomenclature and reimbursement by quotation. But don't forget, everything is speeding up quickly. And of course, we don't must be so confident, and we don't have to lose our critical point of view, because a fool with a tool is still a fool, isn't it? But don't forget that the existence of the black holes was demonstrated before they were visible. And video game again. And that was all for me, and thank you.
Thank you very much, Dr. Camelia, for this excellent presentation. In fact, this optimized performance of the urine cytology is really great news for the patients and the clinicians. And as you know, we will have a better accuracy, better predictive negative value. And so we may also reduce the use of the endoscopy, which is time consuming. Yeah. It has risk and the cost, and probably it may lead to better observance by the patients for the follow-up, and which is requiring a follow-up during the whole life of this patient. So yeah, really,
I think that AI can help a lot the patient. It can help us first, and to give a better treatment also.
Not only for the bladder, also for the upper tract
but
urinary.
I think that for bladder it's so visible if we think about endoscopy sparing, and it permits also to make the economies for the health system and give money for other things.
Yes, and not to delay the surgery, especially when we have radical nephroureterectomy for the
Of
upper
course.
localization.
Of
So
course.
it's very interesting. Are there any questions in the floor? Okay, thank you very much, Dr. Camelia. Excellent presentation.
C'est qui, c'est Bischkopf? Ok, ok. Ouais, c'est bien écrit. C'est qui? Vas-y. Last one. Our next speaker is Dr. Andrew Bischkopf, a specialist of digital pathology, and is an overview of AA and digital pathology and of cervical cancer screening. Thank you very much.
Thank you for the kind introduction, and I would like to thank the African Society of Digital Pathology for the invitation. I'm honored to be here again, and it's fantastic to see the progress of society, community, and witness it. So all the best to the African Society. I'm going to talk about the AI and digital cytology for cervical cancer screening. I hope the mic is located proper way. So this is a topic we worked with my colleague and brilliant mind in digital cytology from Korea, Dr. Joseph Chon, for the last couple of years, and produced several review papers and book chapters, and I'm happy to summarize what we have found from the literature and from the experience. And I think this is a very nice topic to wrap up the digital cytology, use of AI in cytology section of this Congress, because this is definitely the most high volume test which is used nowadays. So I will repeat again, because it's been mentioned yesterday by Dr. Norman, what is the current status of AI, let's say in 2025 or 2026. We have a bunch, I would say even a lot of in-house, or as Dr. Julian mentioned yesterday, prefer to use the term homebrew, AI tools and commercial tools as well. And for the latter category, computational pathology market has more than 50 vendors, definitely, which are able to sell more than 100 AI algorithms. It's good to know that many of them, they are cleared by IVD. Of course, there are very few which are cleared by FDA, but nevertheless, it is a certain regulatory process. Of course, just as a reminder to you, radiology, digital radiology, it's not the right term, because this is the essence of radiology nowadays. The market of AI in radiology is 10 times more. And in pathology field, those AI tools, they are dealing with, most commonly, with such tasks as cancer detection and immunohistochemistry scoring. And the main organs are breast, prostate, and cervix. And actually, the last one is very relevant to cytology. And the stains are HC, immunohistochemistry, for example, Ki67, and pap staining in the case of cytology. Our lab at Kameda in Japan were the first fully digital, who made a full digital transition in Asia in 2018. And we still continued the same pace and continue to do 100% scanning, and most of the cases are signed out digitally, if not all of them. And of course, it's no-brainer that we are using commercial AI tools, and one of them is shown here. It's been mentioned already several times during the Congress for the prostate cancer detection, which is very well accepted by our doctors, and especially juniors who may not feel very much comfortable with this field of pathology. Some years ago, with our colleagues, and one of them, I hope, here at the conference, Dr. Daniel Pinto, we did a study, we did a survey among the European and the Asian laboratories, especially those who are pioneers of digital pathology. And it was not surprising to see that while there is a progress, but the level of digitization in the field of cytology is very limited, which being reflected by the numbers shown here on the slide. At the same time, we know, and we see that in Asia, based on our survey, which was conducted a couple of years ago, that the staffing or equipment of laboratories by scanners, even in our continent, which is much delayed compared to Europe and North America, it's not negligible. And these percents, they are growing continuously. Let's make a jump forward for several years ahead. I had an opportunity to participate in another survey that was quite widely recognized and well cited, where experts in computational pathology from key institutions across the world, they shared their opinions and ran through the Delphi method study to predict what are the changes due to AI implementation in pathology in very different domains, from regulatory to the financial, and of course one of the topics which actually practicing pathologists are most interested about. What are the tasks which could be potentially replaced by AI within a decade, so which means by the time by 2030. And this table, which is shown on the slide, there are multiple tasks which are summarized, which were considered, and which were ranked by the certain priority and so on. And you see this list is pretty huge. They were predicted that multiple tasks in pathology lab would be fully outsourced to AI by 2030. Of course, there is important condition here if your lab is digitized. So it was interesting to see that years ago, I think it was already like 3, 4, 5 years ago when they study out, that the top of the list was taken by the cervical cytology screening, along with the screening of lymph nodes for metastasis, screening of colorectal polyps, and other tasks with less probability. AI in cytology has historically, well, cytology itself has been historically a target for the quantitative analysis, for the morphometry, and some simple example which I just realized that more than, well, it's about 50 years ago when several journals came on the stage and like analytical and quantitative cytology, they publish only about the morphometry and measurements of the nuclei, nuclear cytoplasmic ratio in cytology specimens. So there was a journal which is still on the stage with several iterations and changing the name, which was just about morphometry in cytology. And once again, this was dated 50 years back. Why AI for cervical cytology? When I made this question to myself, I subdivided the answer into several categories. And what is on top, there are market needs, because it's a high volume test which is driven by the large scale screening programs. Second category, there are definitely laboratory needs, because the screening, the manual screening, is a very time-consuming process. And as we mentioned several times yesterday during this Congress, there's definitely an obvious lack of the any profession in the laboratory. You know, we are speaking about the lack of pathologists, but even worse situation in the case of laboratory technicians, including cytoscreeners and ancillary personnel and so on. And I believe that technology readiness is there. Because from IT perspective, cytology, it's a nuclear morphology-based image analysis. It's not that like super complex like what we encounter in the case of histopathology and tissue structure and so on. From pathology laboratory perspective, we are dealing with, most commonly, with the standardized preparation by LBC, which is definitely one of the key to make things align in terms of the standardization. And also from the scanning perspective, since in the cervical cytology we are primarily dealing with the squamous epithelium, there are several solutions which are completely disregard 3D approach to the scanning, such as Z-stacking and so on. And based on result they produce, it worked pretty well. That's why it is not surprised that the market of the commercially available AI-based GYN screening software is quite extensive. So I summarize, let's say, 8, let's call it key company of the major vendors based on the certain criteria, which I would say presence on the international market. I mean, international footprint, so they have sales outside of the country of origin. They're able to deal with the interface basically in English language. They have a history, and they have a bunch of the validated studies which prove in this particular tool. What was shown by Dr. Kamele, I just show a quick example. This was recently kind of boom in the cytology field when the paper from cytology went into Nature journal, which is something fascinating, and probably that's the only paper about cytology and morphology in this high-rank journal. Of course, there is a fancy tool, and actually we had an opportunity. This is Japanese spin-off company, Cyber, from the university, and we had the opportunity even to test this tool on site. So it is just not that super much different from what other companies offering, but they are selling only in Japan. They don't have any service support outside of the country. So this is one of the reasons it is not featured in the list of the brands I mentioned on the previous slide. And this is just one example, because we know the company of the same scale from Korea, from Europe, from United States, from Taiwan, and so on. So I'm going back to here, and just information shown here is quite overwhelming to represent what is each tool about and how they are different. So first you see they are actually of different origin country-wise, including Europe, United States. It's great to see, being based in Asia, that quite a number of the companies are originated from Asia, and they are still keen to do international sales, sometimes successfully, sometimes less. What is important is the, once again, regulatory clearance. They have different certificates, sometimes just limited to research use only, but nevertheless, there are even like FDA-approved devices here. Some of these companies, some of these solutions, they are also offering own scanner or able to deal with supporting scanner from other vendors. And of course, it is important what type of supporting what type of LBC is supported by this specific solution. And I show you just as a simple example what I mentioned previously, like it will be not surprising to see that like several of these tools, they are quite sufficiently dealing with just 20x magnification for cytology, because this is cervical cytology. We can divide all these types of AI-based cervical screening system based on the level of compatibility in 3 categories. On the top, there is a closed or proprietary AI screening solution. In the middle, there is LBC agnostic AI screening solution, where there is a tool, software, which is usually paired with a specific brand of the scanner, which oftentimes is produced by the same company. But there is a certain flexibility that this particular solution is able to deal with different LBC preparation techniques. And I think what we prefer in most of the cases is LBC and scanner agnostic AI screening solution, where there is a full flexibility in terms of plugging in different models of the scanner and also ability to deal with different types of the LBC preparation. Functionality and user interface, I think, yeah, it was just shown some minutes ago by Kamele in the urinary cytopathology. I think it's pretty generic, and in cervical cytology we see the same. Like we plotted here just like 8 interfaces from the companies which were shown in the table, and they're looking quite similar. So we have the image gallery, or some call it library, displaying image tiles with individual cells or cell clusters that represent abnormal or suspicious finding. There is also a window of panoramic view with annotated regions of interest on LBC, and each snapshot in the image library may be labeled with diagnosis. This is actually where there is a huge diversity, because some company prefer just providing the binary classification. For example, normal versus abnormal, and that's it. Another option is to provide, and I think what would pathology love to have, is a classification by the Bethesda system, reporting cervical cytology. And this is accompanied by the percent of probability. And many of them, but not all, they also offer the opportunity to detect microorganisms. This is just a summary, a kind of hypothetic user interface, and this was exactly created by Dr. Josep Chon, where you can see what I just mentioned previously. So you have the main window, you have like a low power view window, and you have several tabs showing up quality control, showing up the baseline patient information, and then actually diagnostic items such as distribution of abnormal cell according to the Bethesda category. Another chart showing up here, also division of different cervical cytology AI screening tools by use cases. And it depends on the workflow integration level. So on the top, this is AI solution as the quality control. In simple words, I would just call it a second read. So all the review is done as usually by pathologists, and it's run manually, or you can even do it using whole slide images. And only after reporting, you run whatever number of cases or slides you need. Maybe it's for 10% FNR quality control, run through the AI analysis. At the bottom, this is the opposite situation, and once again, this is what we would love to use in the practice. It's a first read. So when there is involvement of the human is limited, is minimal, and all the things that are done through the digital mode, such as you run slides through the scanning first, then upload these whole slide images to the AI platform, and after AI analysis, only some positive cases, they require second review by the cytopathologist. And in the middle, this is what we call, but probably in a certain sense, it's some kind of confusing term, it's AI assisted screening diagnosis, which is a reasonable combination of these two approaches at the very extremes. Let's imagine that you have made your mind and you are ready. You have money, you have people, you have interest to venture into purchasing the tool. We created this pre-purchase checklist. Actually, it's shown on 2 slides. And I think these are items you need to go with your team to figure out like which device to purchase and how much you can invest, how you can plug into your existing workflow. Of course, starting with the very simple question, what is intended use case? Like once again, do you want to do like a second read only, or you want to do first read, or you want to do something in between? Compatibility, you need to verify compatibility with your lab adopted equipment, such as what kind of LBC platform do we use? I give you example, like in Japan, most of LBC preparation are done with the SurePad, which is different from other countries who are mainly dealing with the ThinPrep. And when we try to use some commercial solution just to do trial, and they were initially working only with ThinPrep, of course, they was not surprised that they could not produce the same good results with the SurePad. This is just an example. And what kind of staining do you use? Because let's say in Asia, I would be surprised that this is the case of Africa as well. There are many countries which are still using like Giemsa staining, or even in China, some laboratories still use for cytology hematoxylin and eosin. But that especially for FNA, but nevertheless. So Papa Nicolau, it's not the universally adopted across the world. Hardware integration. So you need to ensure the system compatibility with existing whole slide image scanner, if you have the scanner. So you need to ensure that it supports scanning mode, which AI is intended to deal with, such as some AI, they prefer dealing with the Z-stack, but some can deal easily with the single layer mode. magnification options, and scanning throughput, how many slides per hour. Total cost analysis depends on there are just like a couple of important items. Of course, this list could be longer. I would say case volume, because let's say if you have like 100 cases, 100 slides sent to you over the months, definitely the level of return of investment you will be approaching in decades or centuries, right? So as everywhere in commercial tools, the size, the scale, the volume will probably have certain positive effect on the potential return of investment. Then you don't need to forget about the required hardware. You may have a scanner, but this specific AI tool is not able to deal with the whole slide images produced by this scanner or work reliably with that. So, and then in addition to the just software, you need to invest much more to purchase a scanner. And basically, yeah, AI software licensing is the way how do you pay for the service itself. So, for example, it could be subscription-based, or case volume dependent, user-based pricing, and so on. So this depends on the company approach, usually. And the second slide is shorter. So you need to remember about infrastructure requirements, such as server capacity. Is this specific AI tool, which is sold by the vendor, is it dealing with the local storage only, or it is using cloud? And you may need some workstation upgrades. And imagine if you have like 10 or 20 people or 50 people in a network pathologists who are going to use this specific tool, then you can multiply the investment in this, which you could imagine quite small amount compared, let's say, to scanner. But if you purchase 50 new PC, it's going to be quite considerable price. And IT personal support would be ideal situation if you have in your settings. And the last one, I think it's one of the most important. It has been brought yesterday, it was brought yesterday by Dr. Jun Fukuoka, and I think this also came from our personal experience that we would strongly recommend on-site trial for whatever you purchase in your lab, especially if it is expensive equipment. Whether it's scanner, whether it's AI tool, what you see here, it's usually, at the expo, at the exhibition. It's usually the best case scenario, but whether it's going to work in your laboratory, it's a big question. So, and this on-site trial is recommended to evaluate actual performance versus manufacturer specification sheet, and it may be already not 90% detection and 50, and who is going to work with that? Of course, nobody. Image quality and diagnostic utility. As pathologists, we continue to be like very conservative and very picky about the image quality. And maybe if you are not happy with that, your people won't be able to work. User interface and integration capability, especially the latter one, is very important, and workflow compatibility with what is established in your laboratory. All right, moving on. I think it was also mentioned today about the validation basics. Let's imagine you have this tool finally installed in your lab. Of course, we need to go through the validation procedure. Until very recently, there was no kind of benchmark guidelines for the validation of digital cytology. And there was a pioneering efforts by the American Society of Cytopathology, which released in 2024 their recommendations, which are basically, they are getting all the key items from the College of American Pathology, validation protocols for the digital pathology, or let's say digital histopathology. But of course, with certain extension to the specific items which are in the field of cytology. So you see, and I think you are pretty well familiar with that. So your personnel must be sufficiently trained. There should be compatibility with AI vendor tailored setup, scanner preparation, and so on. Revalidation would be needed. There are a number of cases which in the field of cytology is different from the field of pathology, but this number of cases is just a suggestion. It's even not a recommendation by definition, because we have limited knowledge about the proper way to do that. Washout period, pass rate, and so on. If you look, this is just like kind of extract from the guidelines list. So if you check this carefully, this will be quite demanding, and I would say that the reasonable flexibility is allowed. Just a couple of slides to show you examples from the, let's say, real world, or I would say from the publications. They're a commercial tool with peer-reviewed publications. Here is Hologic. Everyone is familiar with that. I mean, with the name at least. I don't think you have Hologic device here at the exposition, but I believe you had the opportunity to see that at international conferences. So user interface is pretty familiar, as I just showed you previously. It's end-to-end type solution, which means that everything is sold by the manufacturer, starting from the LBC preparation method, scanner, and AI tool. So it's a closed system. It is AI-assisted screening, which is cleared by the FDA approval and also CE marking IVD. It is dealing, of course, by definition with thin prep only and with up to 40x. And this publication is showing quite a good accuracy and performance and time saving, which is nice, one of the nice validation studies. Another example is the company probably you rarely heard about. It's a Landin from China. So they have a very small scanner and definitely much less fancy compared to Hologic is doing. And interface is once again generic. It is also end-to-end type, dealing with AI assistant and AI-based screening. And basically they do all the scanning on 20x magnification, which is saving time. But nevertheless, the metrics, performance, accuracy, and speed is very good according to their publications. I want to bring your attention to one difference between these two things. So this validation study, it's a single institution, has been done on, I think, over the 500 patients, 500 specimens. This validation study was done on about 100,000 cases. And this is a publication coming from probably 7-8 years ago. As far as I know, they still continue doing this in their own laboratory, and the number of patients they tested so far, it's already hit more than 10 million. That's huge. And this is the essence of China and Chinese market. I would say just one word, China is a scale. And it's arguably the most advanced country in AI-assisted cervical cytology screening nowadays, with several years of large-scale implementation on the prefectural, provincial level, even countrywide. This is a video from one of Chinese laboratories, which are really serving as a factory. They're running several thousand slides per day, and everything is robotized, and they're dealing with a huge amount of data, which is very impressive. And this is something special on Chinese market, because there are national and provincial government programs for the cervical cancer screening. And there is an influx of money, which is supporting also AI things. Because there is a priority for integrating AI technologies to enhance the coverage and efficiency of cervical cancer screening. And it's very interesting. There is a vast domestic market. Just about, I could identify, I cannot read in Chinese, I can use translator, and of course, ask colleague from China. So we were able to identify about 20 vendors just of the cervical cytology AI in this country, with just a few companies represented internationally. And these are their logos, and definitely, well, I doubt that some of you ever heard about these companies. Nevertheless, they are doing this on a scale. A little bit more, just one more slide about Chinese market. There are many companies offering AI solutions. They are primarily LBC manufacturers with AI tools integrated as a part of the service. These platforms are paired with a proprietary cloud infrastructure developed by the local IT giants like Alibaba or Huawei while maintaining limited access from outside. This is what you need to keep in mind when you're purchasing some solution, let's say, from one of those companies, which could be not expensive compared to the international, but if it can deal only with Chinese cloud, are you happy with that or not? That's a good question. They are often sold as boxed solution, which is a Chinese synonym to end-to-end models, which may include an entire pipeline, ranging from branded sampling tubes, LBC devices, slide scanners, AI platforms, and even mobile applications that deliver diagnostic results directly to the patients. So here in the right lower corner is example of PDF. It's a screenshot of PDF, what patients receive on their smartphone after the test run by AI. All right, but of course, at the same time, we should acknowledge that there is a limited independent validation, which definitely leaves significant gaps in knowledge about the broader efficacy and reliability. This slide could be a matter of debate because, and could be actually a topic of the standalone presentation on the comparison of cost efficiency, molecular screening, cervical cancer screening versus AI cervical cancer screening. The message I want to bring here, so at least, once again, this is kind of a controversial topic with different opinions and definitely could be tailored in specific country locations. But at least there are some publications which are making cost efficiency analysis, but projecting that, which are showing up that AI with a certain periodicity of use on the population scale level could be more efficient than molecular testing for the cervical cancer. All right, we are approaching to the end, and probably this was also mentioned today about the challenges. There are technical limitations. Remember that all the tools, like 8 companies which I showed you, plus maybe 20 on top of that, all of them are dealing only with LBC. And there is a limited support for conventional pap smears. There is no any commercial solution for the cervical cytology, which is dealing with the manual smears. There is a need for advanced scanning systems, such as volumetric scanning, multi-camera focus fusion, and so on. But I think second category implementation and validation challenges is probably more important, if not the most important, because of the upfront costs for digital pathology hardware, limited interoperability due to the proprietary digital pathology system, box solutions, end-to-end solutions, they're all locked to one vendor. Rigorous regulatory pathways, which are hampering approvals and so on. And there is a lack of standardized solution and reference data publications for performance comparison. I'm happy to see that actually the number of these publications is growing, and probably in a period like 3-5 years, this will be more developed, and we can have some like institutional data, which will ultimately give the opportunity to make decision if you are going to venture in this direction. And data and validation challenges for developing of AI. So here we arrive to the conclusions, and I would like to say that AI tackles long-standing challenges in pathology, cytology routine, such as diagnostic yields, heavy caseload, observer variation. Cervical cytology screening is the most promising AI application in cytology. There is a growing number of commercial tools, and AI solutions, they streamline diagnostic workflow, reduce turnaround time, but still require rigorous validation, strategic integration, and adherence to regulatory and ethical guidelines. There is a huge potential to significantly reduce the burden of cervical cancer worldwide using AI cervical cytology screening tools, especially in low and low-middle income countries. And I just show up you again that if you miss some slides or you want to go in more details, most of this information and figures, I think they were borrowed from the publication, which we made once again with Dr. Josep Chon. I would like to acknowledge him. And it's massive, maybe like 20, 30 pages, but I'm happy to answer any additional questions if you have on items which are shown here on the right. With that, I would like to thank you again, and the African Society as well, and that's it.
Thank you very much. Is there any question? Welcome.
Wonderful talk. Thank you, Andre, for the overview. Actually, just a proposal. Last night we had a dinner conversation. Paul was there. And I'm really very struck by that curve in terms of quality of life years. I would suggest in the future if we can have a mini debate on cost-effective strategies, especially in Africa, comparing HPV, AI-assisted, and then visual strategies, you know, non-traditional but visual inspection type of strategies.
Yeah, I agree with that. That's why I mentioned that, like, it's definitely a controversial topic. And once again, those numbers, they are just projection, estimations. We don't have, like, real-world data on that from economic side.
I have a question. Do you think that the Chinese model, end-to-end model, is scalable internationally, or does lack independent validation?
Well, I think you could learn from those couple of slides. There is a certain driver which is a government of the country. So I think this is a key word here. So if there is a huge motivation and finances, there is a vision from the Ministry of Health or so on, definitely pathologists play probably just like not that significant role. There should be certain vision from the higher level and higher level stakeholders like administration and so on.
Other questions? Yes.
Especially with the closed system from Landing, for example, it's probably also true for others. They are that integrated into the Chinese ecosystem that they even use, for example, the IDs. So to like, as a starting process, you have to scan your ID. So if you don't have a Chinese ID, you are out of the system. So this is a problem of like translating it from purely national system to an international one. But that doesn't have to do anything with closed or non-closed. I think it's rather how this system was developed in China. You want to add?
Okay, thank you very much for this nice session. Very enriching, very exciting. So now let's close the session, and now it's time for the coffee break.
Coffee break. And we can continue the discussion about this interesting presentation in the coffee break. Thank you very much. We have to continue the session. Please take a seat. C'est vous? Vous allez faire quoi? Vous avez un symposium? Qu'est-ce que no, okay, just to see the program. No, it's Sabine Marie.
Oh, I'm sorry.
No problem. It's Sabine.
Oh, then
You're
I'm
here.
next. Okay.
Yeah. Okay. Sabine Mariale. No, not you are here. We're waiting just for the people. Okay, so we will continue with Sabine Mariale. She's an associate professor at the University of Bergen and a specialist on nephropathology. I think she can correct me after. So she will talk about applying digital pathology in clinical practice and education. No neoplastic disease as a use case. Thank you.
Yeah, thank you for the invitation and to talk here at the Second African Congress of Digital Pathology about non-neoplastic disease as a use case. These are my disclosures and a little bit about my personal background. I'm originally from Germany, studied in South Germany, in Tübingen, did my residency in North Germany, in Kiel, and then moved in '97 to Norway, and I am since then working at Haukeland University Hospital in Bergen, also nearly 30 years. I will give you a short overview over Norway and then showing you what we are doing in terms of digital pathology, coming to my use case, non-neoplastic kidney disease, and in the end give some perspectives about the future. So why also non-neoplastic diseases? I think they are still underrated in context with digital pathology, and they are important. Look at chronic kidney disease is roughly as common as cancer, cardiovascular disease, respiratory diseases, and diabetes mellitus. It's the only condition among these where the mortality rate has risen rather than fallen over the last 20 years. It has a 5-year survival in the later stages, which is comparable to that of cancer. And of course, it's a huge economic burden due to treatment, which exceeds the costs for diabetes and cancer. So this is an important disease, man, still neglected, and we pathologists make the diagnosis which are deciding about treatment of these patients. So now to Norway. So it's a small country in terms of inhabitants, government-funded healthcare system for health regions, and 17 public pathology departments. Here is Bergen, it's the Western Norway health region. So here an image of my hospital in Bergen. This region has 4 pathology departments, 1 million inhabitants. We have 1 ICT department. Here you have the pathology departments. We have 1 common laboratory information system and 1 digital pathology system, which is Sectra. And here an overview over the number of cases, slides, and blocks in the 4 pathology departments. So this is what we have of the scanners just now. Here you can see them in our lab. We are scanning the whole production of histology slide at 40x. So this is a typical working place, still the microscope to the left, but not used. And then the digital pathology system is integrated with the LIS as a two-way synchronization. The workflow is directed by the LIS, also I am opening the digital slides from the LIS like this, but if I change the biopsy in the digital pathology system, it's again synchronized with the LIS, which also changes the case. So working with digital slides is nice, yeah. If you look at the upper left, you see the tracking feature, so I see accurately where I have been in a digital slide, and you see it's continuously updating. There are no delays, and the resolution is nice also for kidney biopsies. I have a full overview about the status. If you see here, I can see the number of sections scanned. I see the number of sections I haven't looked at yet, sections which are not scanned but ordered, and also rescanned sections. And also the working list, which is in the LIS, gives me a really good overview over where I am. It's quite detailed, yeah. For example, some columns, this is the days since distribution of the slide, my last activity, then the stains completed and comments, and I can go mouse over the comments and read the comments in the working list. Then the number of blocks and sections, the number of sections scanned, and in the end also an overview over immunohistochemistry and electron microscopy. And this list is configurable according to the user's needs. So these are the systems we are using in Norway. It's 4 different LIS systems, but every region has its own system. And we have 2 different digital pathology systems. So all labs in Norway are digitized, and in most of the labs, digital diagnostics is done already. How it looks worldwide, you can have a good overview about digitization in pathology labs in the world map of digital pathology, which you can find on the website of the European Society of Digital and Integrative Pathology. And you see, for example, there are recorded 2 labs in Africa, it's Cairo, and 1 lab in Morocco. But as we heard yesterday, there are other countries which have implemented some digital pathology, and it would be really nice to see it also in this map, and it's quite easy. If you go to the upper left, you will find a link where you can register your lab. So, kidney biopsies. How are we working with kidney biopsies? There are often really small lesions in only a few glomeruli. So what we are doing here, we use one representative slide and annotate all the glomeruli and other interesting lesions and structures. You can see how we do it. We are counting the glomeruli, and we are also documenting lesions. For example, glomerulus 2 has a global sclerosis, and glomerulus 5 has a mesangial proliferation, and we are also annotating results of our immunohistochemical stains. And this is a nice documentation of what we are finding, and we can also very, very fast go to the interesting lesions and also present these lesions to our clinical colleagues in the meetings we have with them. So really nice features to have in this kind of biopsies. So here we have been doing interdisciplinary meetings with nephrologists for many years. We are using Teams and Norwegian communication platform for health services because we not only have clinicians in Bergen, we get kidney biopsies from many places in Norway, and absolutely necessary to have such a functionality. So one word to how we report kidney biopsies. You know, for cancer cases, usually synoptic reporting is used. This has not been the case for non-neoplastic diseases, but it can be easily realized, for example, for kidney biopsies, and we are doing this as much as our LIS allows us to make structured reports. Also, we are reporting the key parameters in a kidney biopsy as structured machine-readable data, as you can see here. And a nice feature is also that every data unit has a so-called information icon where there is a description how to, for example, count glomeruli, or what is a crescent and what should be counted as a crescent. So the report for the clinician in terms of structured data looks like this, and this gives really a very fast and good overview what the biopsy shows of key parameters. Of course, there is also a descriptive report and a diagnosis and a comment, but these are the structured data. So then about education, how do we teach students non-neoplastic kidney pathology? And this is something which is quite challenging for students and difficult to understand. We are doing it in 3 steps. They get pre-class opportunity to get some information about what is coming afterwards. Then there is a lecture and a course, and in the end, an integrated reasoning. So how does the pre-class look like? There are short videos. I will show some examples later, and quizzes. Lecture and course. We have this lecture, and we have a course with 9 typical biopsy cases where we are using digital slides. And in the end, it's 4 hours team-based learning sessions, which is interdisciplinary with a nephrologist and a physiologist. And also here we are using digital slides. So the first step, pre-class, an example here. So you see to the right a video which explains in about a couple of minutes the essential glomerular lesions. The students have the opportunity to look on videos about the specific histology of the kidney, filtration barrier, then also chronic kidney lesions and the glomerular reaction patterns. So it helps to have done this, and there are also quizzes where they can test themselves when it comes then to the lecture and to the digital pathology course. And in the course, when looking at the cases with the digital slides, we want to get the students a bit more advanced, also not only detect lesions, maybe also be able to classify lesions, but to understand how the clinical picture and the lesions and the degree of the kidney disease, how advanced it is, how this is connected to each other. I just want to show you a short example. So this is a digital slide of a patient with a crescentic glomerulonephritis. So the students have to identify what is a crescent, but we are also asking them, there are 4 different glomeruli with different lesions. As you can see here, they click themselves these lesions, and then the question is, if you look at these 4 lesions, how can you order these lesions in terms of time course? Also, which lesions are acute, early in the disease, and which lesions are rather later. And as you can see here, of course, the global sclerosis is late, but then they have to identify this is a cellular crescent, and this is a smaller crescent with a still fibrinoid necrosis, and this is the earliest lesion where you only can see the fibrinoid necrosis. So this as an example. And then in the end, the TBL, you see here the nephrologist, myself as a pathologist, and the physiologist, and the students which are dealing with these more advanced cases and have to answer questions, and then we are always running in discussions. And it's really nice to have 3 disciplines which can explain questions for the students. So, yeah, really nice experience. This is an AI-generated image because I don't have image of our TBL session, but then I thought it's a serious case, so and they all are laughing, so maybe it should be rather like this. Okay, this was teaching. Then secondary use of digital nephropathology. How are we doing this after diagnosis is made? The cases are gone into the national registry, the Norwegian Renal Registry, which contains all patients with serious kidney disease, has been collecting cases since 1988, both clinical and pathology data. And when we got our first scanner, it's established a national digital slide archive. Also we have digital slides since 2012. The registry is for quality improvement, but also for research. An example for quality improvement, we are regularly presenting quality data. For example, here, the number of kidney biopsies with at least 10 glomeruli per nephrology unit, and the goal is that this is the case in more than 90% of biopsies, and as you can see here, only 4 nephrology units have reached this goal in 2024. These are the numbers from 2024. So this looks really very nice. So complete digitization, complete digital diagnostics, all labs in Norway digitized, doing education, doing research with this, but it's not how we started. This is the status now. If I look back how we started our digital pathology journey, so it was much more simple. So the first action we bought a first digital slide scanner and a database and a viewer in 2012, and the goal was to establish a digital archive for our non-neoplastic kidney biopsies to preserve the quality of the biopsy and the quality of the stainings. And this archive should be used for research and education. But soon after we have got this digital pathology system, we found out that it is nice to do digital diagnostics with kidney biopsies. We could do it remotely, which was a big advantage, and we could use it in MDT meetings. But at that time, we didn't have a LIS integration, but we still used it, and it helped us to become trust in this kind of devices and this kind of doing digital diagnostics, and it helped us very much in all our later projects about digital pathology. So we explored how to do this. For example, we had there the image scope system, so we developed our annotation praxis in this system, as you can see here, and we did it quite advanced. We had much more possibilities than in our Sectra system. Now we could do advanced tables about difficult renal cases, as you can see here. For example, it's a lupus case, which a lot of different lesions which you would like to document somehow. So, and such small digital pathology projects were in place, several places in Norway. So at that time,
we thought about doing a national project, digital pathology, to look at how to integrate services, how to improve collaboration between pathology units, and how to develop common solutions and services that promote quality and standardization. And this project became bigger and bigger, and there are also a couple of products. I just want to show you some. Also, we made a guideline what should be stored and how long when doing digital diagnostics, and we came out with a recommendation that digital slides should be stored for at least 20 years, and then it should be reconsidered. So this was quite courageous at that time. And we also said that glass slides could be discarded if the diagnosis was made on digital slides. Then other recommendations to store tissue blocks and about cytology specimens. What we also established in this project was a platform where we could communicate nationally, for example, for standardization activities. You see here the huge variability of conventional stains and immunohistochemical stains. And for this, we used the Cytomine application. We did, the labs cooperated, which it's also to standardize stainings. We also used this application to make cases with annotations for resident training. So Cytomine is no longer available. The company has going bankrupt. So what we are now trying to do is to use the Sectra educational platform. Another activity now when AI tools come up is we did also a national project about how to implement AI tools in pathology services to give pathology departments some kind of help what to consider when they want to buy AI tools and how to implement it. And this ended also in a national report last year. Some of the recommendations was to establish actually regional supporting units, and also doing this, there are also questions which could be solved much better also internationally. Yeah, why not also have international networks? So, if looking at my journey through digital pathology, if I would make some, what I learned or some recommendations, these are actually three. The one is it's possible to start small. If you cannot go for the big digital pathology project, it's also really of great use to start with smaller projects to be, to get to know the functionality of digital pathology. Starting small, choose simple solutions. I have shown you some of a bit more advanced solutions, for example, the annotations in ImageScope or the Cytomine system, but actually these were not used by very many pathologists because it takes so much time to get to know how to handle the application. So simple solutions are actually much better. And the third one is to communicate and collaborate widely. We did it extensively in Norway, and we still do it, and it's really a nice thing to have the colleagues around who can develop solutions and discuss things. In the end of my talk, I would like to look a little bit in the future. We got major funding in 2020 to develop AI tools for pathology services. And of course, we did a lot in my field, also not a lot, but we tried to develop some tools in non-neoplastic kidney pathology. One goal was to be able to classify glomerular lesions. We are not there yet, but what we already can do is, as you can see here, we can segment glomeruli, we can make bounding boxes around the glomeruli, take out the pictures, and then detect segmentation errors, correct the segmentation errors, process the pictures further, remove the background, and then cluster in 2 different groups, glomeruli with global sclerosis and glomeruli without. And all this happens unsupervised without any annotations from pathologists. And you can now use these pseudo-labels to train an AI model to discriminate between globally sclerosed and non-globally sclerosed glomeruli. This we can do per now. Our goal is, of course, to be able to classify more lesions. But still with this we can, and we are now trying to do this, to implement this as an LDT test. And this mock-up shows you how it should look like in clinical practice, as a segmenting glomeruli, then counting glomeruli, measuring areas. This has some significance for diagnosis. And in the end, classifying in these 2 types of lesions. What we also do is, what is an important prognostic factor and biomarker in kidney biopsy diagnosis is the amount of interstitial fibrosis, and you can stain for it. It's a red stain, but there is also some background staining. So how to quantify interstitial fibrosis, and the principle how we are doing it, we are removing the other structures, also detecting the other structures and removing it, and then quantifying. And this is how it looks like. Yeah, also detecting here tubules, detecting glomeruli, detecting vascular structures, removing them, as you can see here now, and then do the image analysis on the image patches. And also this we want to implement as an LDT, and again a mock-up how it looks like. Also the pathologist orders the analysis. Then the analysis is running on the digital slide. Yeah, gives a result, and the pathologist can control what the AI has done, and in the end approve or not approve the result. Yeah, so these are some simple tools which could help the pathologist when evaluating a kidney biopsy. So this is actually nearly the end of my talk, but in the end I want to raise one thing. It was a year ago I accidentally detected that there was a call from the Norwegian Research Council for cooperation, international cooperation with a focus on African countries. And at that time point, it was April, I asked Norman, would be nice, do you know somebody who would like to cooperate? But actually there was just not enough time. It was just before the first African Congress and we discussed it. So I think there will be coming up more calls like this. And also if you look into the EU, there are also European calls with a focus on Africa as a cooperation between European countries and Africa, and it would be really, really nice if we could establish some collaborative projects between Europe and Africa. So, and with this, thank you for the opportunity to talk here today, and I want to acknowledge my research group, and here's also some contact information. Thank you.
Thank you, Sabine Maria, for your excellent presentation and for your very beautiful slides. You have very nice coloration. The You speak about the education and about the collaboration, and we need collaboration in Africa, especially in Morocco, from my countries, and especially from my city, Agadir. I want to share just a small experience about me, why I'm here about digital pathology, because I was in medical school in Oujda, and we have a collaboration with the number faculty in Belgium, and they give us the opportunity to create a practical course in medical school in 208. So this is a very beautiful example for comparison between Europe or Asia and Morocco. And I start education with my students on digital pathology in Oujda, and there are small residents here who have had courses on PC on digital pathology in 290, and they continue. And now in Agadir we have, that's why I have the scanner, 3D stack, and we had the notation, and we began, like you in nephropathology, in dermatopathology. So we make a multidisciplinary stuff with dermatopathologists, with identification, and we try to make something small, you say it, exactly. Start small. We try to start small, and I think everyone here can start small, and perhaps after, if we can have more cooperation with you, with your expert like you, we can be bigger. So, yes, any question here in the, yes?
Thank you, Sabine, for this very nice talk. I would have one question based on the tools and the things that you showed that you can already do. There would be, for example, as far as I know, you have to have a certain amount of glomeruli in the biopsy to use it for the diagnosis. So based on this, what you showed, you could, for example, automatically detect, does the slide has enough, or the particle has enough of those glomeruli, and if not, you need a restain or a rescan, or maybe a recut even, right? And is that something that you also investigated? That's more like steering the workflow instead of only helping at the diagnosis?
No, definitely not yet, Norman. It's too early. But of course, it's a good idea to make some automatic rules, how you use the information you get from the tools, but we are not there yet.
But the tools you showed would actually enable all of this, right? You can detect, count per particle. So thanks.
We are happy if we work out to implement them as LDT tools. So this is the next big step we see for us. Yeah.
Thank you.
Yeah.
Any another question? Thank you. Thank you very much for excellent presentation.
Thank you very much. Our next speaker is Dr. Matthew Hanna from the University of Pittsburgh Medical Center, a recognized expert in pathology informatics, digital pathology, and AI. Today we'll present digital pathology and AI as tools against infectious diseases in Africa. Thank you very much.
Wonderful. Such an honor and pleasure to be here with you all today. I really appreciate the African Society of Digital Pathology, Dr. Hasham, everybody, for putting this together and inviting me to talk on this topic. So before we actually talk about the technology, I just want to ground us sort of in the reality of why this problem matters, and we'll talk about this sort of continuing in the non-neoplastic conversation. So. Particularly in the infectious diseases in Africa, Africa continues to carry a very disproportionate amount of global infectious diseases. So if we take malaria as an example, the majority of global cases and deaths actually occur on the continent. Tuberculosis remains very highly prevalent, often intersecting with HIV, which further complicates diagnosis and management. And beyond these, there's also a wide range of opportunistic, endemic infections that frequently require tissue-based or microscopy-based diagnoses. So at the same time, I think we've also heard there's a very profound gap in diagnostic gap, and in many regions, access to trained pathologists is very limited. And so that really means that the bottleneck is not just the disease burden itself, but access to expertise. So even when testing is available, there are practical challenges, right? Samples may need to travel long distances, turnaround times can be delayed, interpretation may vary depending on the training, the workload, or the available resources of the local site. So the key point here is that the diagnostics, not just the therapeutics, are a major limiting factor in improving the outcomes of patients with infectious diseases. So if we can't accurately and quickly identify the disease, we can't really effectively treat it, monitor it, or really control its spread. So this is where digital pathology and AI can really begin to start to solve that problem. So we can shift that paradigm. Instead of trying to scale people, which is often very hard, especially in limited settings, we can start to scale the expertise through digital pathology. So the challenge is not just more disease that's happening, it's that less access to diagnosis, and that's the gap where digital and computational pathology will try to solve. All right, so now that we've sort of framed the problem, the next question is what actually changes when we introduce digital pathology? Traditionally, pathology is inherently local to that lab. So a glass slide is created, the diagnosis happens really wherever that slide physically exists. So if the expertise is somewhere else, we would have to ship it. That introduces delays, risks, cost. And digital pathology fundamentally changes that model, right? So instead of a glass slide being tethered to a single location, we convert it into a high-resolution digital image. And once that happens, the slide is no longer just that physical asset, no longer just that physical object, it becomes data, and we can move data very quickly these days. So that means a case generated in a specific district hospital can be reviewed by a subspecialist in a regional center or even internationally. But I'd say that transformation also goes beyond just that remote viewing capability. So once the image is digital, it becomes computable, and that's where AI enters the picture. We've heard a lot about algorithms that can analyze the image for just detecting things, quantifying things, triaging, and essentially acting as sort of a first pass screening review or decision support layer. So I'd say the key here is that digital pathology doesn't just make the slides easier to view, but it transforms them into hopefully a more networked, shareable asset and sort of shifts the conversation. So where can AI help? So these infectious diseases are often a very repetitive, visual, high volume process that looks at rare event detection. You're trying to find some needle in a haystack or oftentimes many other needles in the haystack. So it can detect organisms, abnormal cells, suspicious areas. It can count them, looking at parasite load, bacillary burden, or cell counts. And one of the most transformational uses of AI that I've seen from other colleagues is just the ability to triage cases. Just by virtue of having a list of cases where you can filter or sort them by ones that were found to be suspicious versus not, really transforms how pathologists are able to work. We've also seen that it reduces some inter-observer variability, especially with challenging cases that where they're sort of borderline. And then because it's digital, again, we can sort of connect and feed these aggregate signals into more of a surveillance network. So we'll talk about a few different use cases. So number one, this figure really highlights how disproportionate malaria impacts Africa. So you see the highest mortality risk is actually concentrated in sub-Saharan Africa, and the rest of the world has very low or even no transmission at this point in time. Unfortunately, we actually see a large proportion of those deaths actually occur in children under 5. So this really emphasizes how critical and that timely and accurate diagnosis would be in these patients. So even a small improvement in diagnosis and access to expertise can, I would say, have a significant impact in this area. So this is where we really want to scale these sorts of tools like digital pathology and AI to really make these sort of public health interventions. So peripheral blood smears, these are high volume microscopy. They happen almost everywhere, traditional bright field microscopes, chemostains. There's variable levels of expertise, I'd say especially now, even in the Western US, where we don't have as many technicians going into this field and so we have lab shortages constantly. And we may have low density infections, so not every case will be positive. So we are really trying to find a needle in a haystack. So AI, digital pathology and AI has this role to be able to detect those parasites, flag likely species or stage, maybe estimate or quantify the parasitemia in that specimen, and then impacts sort of the workflow, right? So the technician can prepare the smear, scan it, AI can pre-screen it, and the human, of course, can confirm it. We still have sort of a human in the loop for a lot of these And then so we really transformed from a sort of manual smear reading to an AI-assisted workflow. So this is an example of sort of the technology we have today. So we have scanners that can digitize that level of resolution and be able to see this, right? So just from, are we there yet with a screening tool? Can we just scan the traditional peripheral blood smear and identify these parasites? Yes, the resolution exists, and we are able to do that at scale. But of course, this is just the manual review in a digital process. And digital pathology and AI is not just to replicate what we have with the microscope. We need to enhance that and make that better. So there are sort of all-in-one solutions, small desktop, tabletop type solutions where it's purely meant for peripheral blood screening. And so this can range from simple, small tabletop solutions to systems that are on an automated line, and that it can take those peripheral blood smears, use it, screen it for white blood cell classification, red blood cell classification, and also for infectious diseases. So this sort of has a similar gallery type review that I think we've seen in some similar products, where it screens the peripheral blood smear, it identifies all of the different either white blood cells, red blood cells, and can estimate that parasitemia, and it can also be used for digital or remote review. Other lower tech sort of solutions, at the end of the day, a lot of this is software. Of course, the hardware matters. We need optics. Thankfully, cameras are very ubiquitous today in pretty much all the devices in your pockets. So we see a lot of these lower cost solutions happening in lower resource settings where you can now, this smartphone, universal smartphone adapter is $5 on eBay or $6 US dollars on eBay. So it's something very manageable. I've seen even people 3D print these if those sorts of resources may be available. And you sort of attach these devices. We have very high resolution cameras on our smartphones or tablets. There's even one in the exhibit hall with sort of a computer on a tablet. And you have the application that's the AI software to load it. It looks through the lens of that camera and can ultimately do the same thing. It's looking for these sorts of cells in real time as the technician or pathologist is navigating around that slide. And we see that these, with the more modern machine learning techniques, we get very high accuracy sensitivities as these are screening tests. And then if all else fails, you can perhaps build your own. I think that there's so many public data sets out there. This was just one that I found that has almost 7 gigabytes of labeled data, annotated data. These are freely publicly available online. You can go and download them. And you can use free tools to develop your own, or you can work with hopefully somebody in the computer science division and develop these. There are so many different ways, free ways to actually build your own classifiers these days, even just with static images or whole slide images. So this is an example of the data set that I just pulled into QUPath. You're able to do those annotations, able to make that, and you can classify it right in that software. These are all local, run on your desktop. It can happen. You don't have to have a computer science background. This is another example in Peru, looking at malaria, so they published capturing those images with a mobile phone and looking at it and looking at developing a machine learning model, and they had very high performance across many different of these subspecies of malaria. All right, I'll just continue to show other examples. So this is sort of what it would look like. So you're looking through the ocular. Again, this is a smartphone attached to the microscope, and you see it with the bounding boxes around the potential gametocytes or schizonts, other forms of those parasites. And in real time, it can pull those up. And so you don't need super costly technical infrastructure to be able to deploy these sorts of things. All right, how about acid-fast bacilli, Mycobacterium tuberculosis? AFB can be very sparse and very easy to miss, I'd say especially in low burden cases. So on the right-hand side, you sort of see an AI overlay very similar to what you saw that will highlight potential bacilli. So again, this isn't replacing anybody. This is just showing how we can change from having a personal screening activity to more of a directed review process, which again is a very transformational part of that workflow. And I think a lot of the efficiency gains and improvement in screening accuracy can really help. So the key point is, again, that workflow triage. So negative cases can be pretty much deprioritized in some sense. Of course, they'll still be reviewed. Uncertain cases can be flagged. Maybe you can use those as a sort of a access that is, as long as you have a computer and some level of internet, you'd be able to build something locally. All right, I'll sort of continue into other areas of microbiology, and so with sort of any sort of cell counting, infectious disease counting, we could use telemicrobiology, which is a very booming area, actually, I would say, in the US. And so this was just a simple validation study looking across a lot of different sample preparations, a lot of sample types, a lot of different microorganisms, and anything that we can put on a slide, essentially, if we can scan it, digitize it, whether it's a static image or a whole slide image, we can, just similar to diagnosing anything else on an H&E or other slide. So that's just a simple example of if you can digitize it, you're able to, the quality of it works well. This is an example of plate reading. So we still have a lot of different plate readings that happen, and even if it's just capturing the plate at different times, these are much larger systems that can do it at sort of more regular intervals, but there's an opportunity just for capturing of this with you could use a sort of a gross workstation camera, a digital camera that's mounted and capture the images of these plates and see how the colonies are growing over time. So this was, again, just a simple example. This is from a commercial company and sort of a validation paper. The main goal here is that doing it digitally versus analog, you still had very high sensitivities and specificities compared to just being able to actually review that agar plate itself. And I think we're also moving to more of these sophisticated processes, even just with these microbiology plates, where there are now chromogenic agars that can also help the computer read it. So the species actually turn a specific color, whether it's a pink or a blue, or instead of looking at other features, we now, I guess more traditional features, we now have sort of chromogenic features that we can use to interpret. And then from a digital workflow, we can now actually very accurately measure the distance around certain treatments or drugs that are surrounding those, look at resistance, I guess much more accurately. And then if you are capturing those plate reads at specific intervals, you can quantify that colony growth, again, very accurately. So this is an example of something also that can count for you. So you put your plate into this device, again, tabletop device, relatively low cost, and you can draw a bounding box, and then it can start counting those colonies. And so again, if you're doing this at any regular interval, you can see that rate of growth and be able to look at that. So there are advantages of this. Of course, you could have increased productivity. There's decreased exposure to pathogens. You can build that image archive. I think a lot of us have used digital pathology or digital means for educational means, but then you could also share this with the clinician and show them the actual colony growth, compare between different cultures. Of course, there's potential cost depending on the scale of the implementation. All right, how about HIV? So I would say HIV, there are very many opportunistic infections that sort of go along with it, whether it's fungal diseases, CMV, of course TB. And so digital pathology, of course, continues to support this and being able to identify both things that can support HIV workflows, but then also from other opportunistic infections. And so there are fungal classification tools that are available. These can look at Candida, these can look at pneumocystis or other cryptococcus, other sorts of fungi that are sort of go along hand in hand. And again, they work very similar to the other tools that I showed you, so I won't sort of belabor that. But what about HIV testing at scale or at large? So these tools can be available not just for pathologists, right? This is maybe akin to trying to understand a pregnancy test, right? Is it negative or positive? And so out in the field, there are a lot of misguided interpretations for this. And so there's a very simple, so you see here it's just an iPad and they're taking a picture of it, and it's a very simple way for the public or just community health workers who may not have that level of expertise to be able to lower those false positive interpretations. And so comparing to the traditional visual interpretation, again, this is just looking at one line being negative, two lines being positive. Certain sort of at-home kits may have different intensities or slightly different colors in terms of those lines. This is a very simple tool that can be implemented, again, on a smartphone. And in using this system, they actually reduced, say, 11 false positives. So those are people who were told they had HIV. Who knows if they went on to have treatment and things like that, by just making sure that their interpretation is correct. And again, this isn't just for pathologists or experienced nurses. This would hopefully be for anybody, a community health worker or a patient themselves. All right, how about predicting patient outcomes? So there's actually been tools looking at just basic lab data and demographic data to try to actually predict how patients will predict virological failure among HIV patients. So virological failure means essentially, is that antiretroviral therapy working? Is it suppressing the virus? Will there be a persistent detectable viral load, under a certain amount of copies per milliliter? And so looking at these different features, they actually found correlative events, looking at the CD4 count, looking at the actual regimen used in a couple of different areas. So just looking at these features, they actually can start predicting whether patients may respond or eventually have virological failure in the future. And then furthermore, I think the predictive tool can also help identify factors that patients would have poor adherence, so looking at sort of the risk of treatment failure among patients and be able to hopefully enable early targeted interventions for those patients. All right, use case number 4, HPV-related infections. And so I think we saw a little bit about this. So these are scanners that will digitize in terms of, from cytology specimens, and in real time, sort of on an edge compute fashion, be able to create a gallery. And so looking at low-grade or high-grade HPV types of infections can very much be happening, and there are many different tools that do this today. They sort of put them in this sort of gallery-like view, and then it again supports the cytotech or supports the pathologist to be able to review those low-grade or high-grade lesions. All right, use case 5, schistosomiasis or bilharzia. So we see that this is also very common within Africa. Also, I think very historically, there was a famous musician in Egypt who actually, unfortunately, succumbed to this disease. He contracted it sort of within the Nile as a child, and then eventually died from liver cirrhosis. And there was a whole backstory between schistosomiasis and hepatitis C that happened in Egypt. But unfortunately, these can lead to chronic liver disease. I'm sorry, and be a problem. And so this doesn't just, of course, affect Egypt. We now see these sorts of classification tools, tabletop tools, to detect the sorts of eggs of the schistosoma, and be able to detect them. And so we see here just a 7% increase in sensitivity. It's actually interesting. These same researchers actually started as sort of an academic project in Nigeria, and they actually turned it into something called AIDX medical, sort of a commercial, professional grade solution. Again, tabletop type solution. You put in the slide, and there's an assistive workflow. And so those are sort of on urine wet mounts. But there are also, again, similar imaging technologies to identify these on FFPE tissues with very high accuracy. But there are a lot of different examples of these tabletop solutions. You can put in the wet mount, and not just for schistosomiasis. This is looking at the RBC, WC, bacteria counts. Just looking at it from an imaging perspective, that you can very rapidly get the same results that you would have to do with actually counting these sorts of things under the microscope. All right, so I think this we've sort of talked about a lot of different examples in infectious diseases. How could this actually happen? I think I'm a believer in the hub and spoke model. It's something we've done in Pittsburgh, and I think it would work well across many different areas, scaling digital pathology in Africa. And so the district labs act as those spokes, then feeding into sort of regional hubs where we can have more digital resources. AI expert review can sort of be centralized there. And in an ideal world, hopefully that data would be able to connect to sort of a national platform for reporting or surveillance. I think we have to, of course, smart small and scale up, but we see that the AI supports that triage, that quality control, the sort of detection and quantification across the system. And so the idea is really just moving from isolated labs to a connected network, right, to improve diagnostics and, hopefully, public health insight, honestly. So I think before we get there, AI performance obviously depends on many of these different pre-analytic factors, and so I'd sort of be remiss in thinking that all of these will work straight out of the box. There are many different upstream factors that will affect the performance of these sorts of tools and perhaps even delay care. So just having an understanding of what those are, how those infrastructural matters, specifically, I would say locally or within Africa, impact the success of any of these tools, because again, you can build the best tool, but if it can't work in your environment, it's effectively useless. So, of course, building a national model is not easy. I would say there's a lot of work to be done before that. So I just want to stress local validation, I think, remains very critical to ensure that these tools work in the local environment. There are many different governance, privacy considerations that would need to be figured out, but I'd say at least start locally with sort of individual institutions, start small, look at these focused use cases, ones that are important to your organization, do that local validation, show that sort of proof of value that will just continue the adoption cycle and show that success, and then hopefully expand into integrating the workflow, scaling across multiple sites, and then I would say sustaining that, use that data for continuous improvement, publish it, share it, and ultimately the goal is to get to a place where there's earlier diagnosis, stronger health systems, and better health outcomes across the population. So I'll sort of wrap up saying AI can be a powerful tool for infectious diseases across many different shapes and sizes. Context matters. Again, I really want to stress that local validation. Try to understand the entire pipeline from sample quality, all of those pre-analytic factors to the infrastructure to actually get these tools delivered, and then try to scale really ultimately across healthier communities in Africa. So don't let perfect be the enemy of good. There are a lot of tools available, and you know, I think there's a theme I've been hearing, sort of, if there's a will, there's a way. All these tools exist. Even if they're done at a small scale, they can really make a big patient impact. So thank you for your attention.
Thank you, Dr. Matthew Hanna, for your excellent presentation. And you proved again that pathologists with the eye is better than pathologists alone in infection disease, especially in Africa, and you show us our real problems. It's about infection disease, malaria, and in Morocco we have still the problems with tuberculosis. And this is a very health public problem here in Morocco. I hope there are questions for Matthew, because the presentation was very interesting. Here, any questions, please?
Do you think that smartphone-based AI tools may have a greater immediate impact in Africa than a conventional platform, digital platform?
Yeah, honestly, it's a question I would have, I guess, for all of for everybody here, honestly, because so I think the performance of them are very comparable to whole slide imaging, just from a sensitivity standpoint. I think a lot of the more modern AI tools that have been built into the applications would be, you know, the technology that's on the smartphones or tablets or, you know, small computers today can run and handle all of those and process those images very effectively. I think the main scalability is from the whole slide imaging is sort of that automation of the slide scanning and the detection, but depending on the volume of the sites, you know, it could have a big impact. I think it comes down to cost, you know, just general infrastructural questions that may depend on, you know, the different geographies even within Africa, but otherwise I do think they could make a much more immediate impact, especially given the cost considerations.
Okay. Thank you very much. Any other questions? Thank you very much. I think what we have to retain, it's the goal to build the connected between African systems, African health systems. I think it's our goals. So we can close this session and continue with the present section.
Our next speaker is Xavi. Okay, the chair. Okay, thank you.
Sorry. So we continue with the next session. Chair. You invite. So the session now is about computational pathology. How can we create an African movement? And I invite the session chairs. Professor Benhadda Hisham is come with us. He's head of Forensic.
Hi everybody. Okay. So I'm the head of Department of Forensic Medicine in Agadir.
Yes, thank you. Yes.
So good morning. So we are going to move now to another session about computational pathology. So focus about creating an African movement, and focus about ethical challenges and benchmarkings. And after we have symposium about implementation of digital pathology in Africa. So now welcoming Ms. Chavi Chuan from USA, who will present about ethics in digital pathology and AI research. Thank you, Ms. Chuan.
Thank you so much. I'm absolutely delighted to be back here in Morocco, and I could not commend Hicham and the AFSDP team enough on what's turning out to be yet another successful, tremendous Digital Pathology Congress, so congratulations to you all. I do have a personal disclaimer. I am in the business of supporting responsible AI. So 30 minutes is a small amount of time, so I won't be able to do a deep dive on several topics today, but I'll strive to make some connections with the evolving use of AI in digital pathology and clinical research that a lot of you have been talking about since yesterday. The pressing need for frameworks and standards for responsible and sustainable adoption of digital pathology, which was the focus of our discussion yesterday afternoon. I know in all the conversations I've had so far, everyone has been talking about the shifting AI landscape, which is so rapid that it's impossible to keep up with that. So I'll touch upon that. And something that's really near and dear to my heart, which is pathology education and how AI may potentially be impacting pathology education. Some of the things that I might say, some of you may find it to be bold, even provocative, but I'll try to ground everything in real truth by providing supporting evidence as much as possible. So if there's one thing I want you to take home from this talk today, is that ethics is not black or white. It's several shades of gray, especially depending on your vantage point, your personal intentions, your motives, and the values that you share yourself and with the others that you're collaborating with. So this is from Wikipedia, and this is Cognitive Bias Codex, which tells you there are over 180 different kinds of biases that humans face. And I would let you think about the permutations and combinations when your judgment is getting affected by more than one biases, what that may look like. Especially when our industry partners are motivated by revenue generation, profits, or some pressures of scaling fast, a lot of these biases can creep in, especially if you're not considering various different stakeholders in decision making and taking their perspectives and their insights under consideration as we are developing AI tools. So please keep that in the back of your mind. So I'm relatively new to the field of digital pathology. I was introduced to digital pathology in 2019. And being a strong proponent of responsible AI, I took it upon myself to start exploring what ethical frameworks existing within pathology. And this is an article published with another colleague in the fall of 2021, where we proposed an ethical framework for embracing AI in pathology so that we are keeping under consideration the motives and best intentions for patients, for pathologists, for institutions, as well as for AI researchers. And it made it to the cover of the journal, and it remained the most downloaded article for several months for this journal. So as I mentioned, in 2019, I was completely naive to digital pathology, and it seemed like it was a very siloed atmosphere even within the digital pathology community. It was fragmented. There were not many standards, and there were different things that were happening. Scanners were being talked about, viewers, storage, analytics, but there didn't seem to be, any coherence in the landscape. So this is a simplified digital pathology landscape in 2026. I know there are several different institutions in the US, in the UK, and from what we saw from Andre's talk in the morning, in China, that have very integrated digital pathology workflows where the environment is collaborative. We have different imaging and scanner platforms. Healthcare providers are also seamlessly integrated into the system. Pharma and biotech is a big player. Analytics are being analyzed, or data analytics being performed in real time to improve patient outcomes. And of course, I know from the DPA's perspective that we are focusing a lot on payer and government and public health policies. So it seems like a more integrated system. But what's sort of, and I promised to give you some facts to support what I'm saying. So there are several market research digital pathology adoption surveys that are continuously and consistently being conducted by our industry partners, and this is one of the recent ones that was conducted and shared publicly. I know over here it says confidential, but trust me, it was shared publicly, and it's in the public domain now, which talks about the different players within the digital pathology ecosystem. As you can see, within even the scanner space, there are several companies, and of course in image analysis and algorithmic space, there are several different companies that are leveraging AI to help with digital pathology. As you can, just going back, you can see there's a whole number of players in the market. And what we have learned so far, even for the most resourceful settings, and we're talking about resource-limited settings here, no one person can work in isolation. You have to partner up with other people who are providing responsible solutions, and partnerships are becoming more and more, difficult to navigate with a number of different service providers, and also with the regulatory landscape shifting. I'm just going to point one use case from digital pathology, which calls for us to think about responsible AI more proactively than what we have done in the past. There's several different use cases in the healthcare ecosystem, and I can spend a whole day giving you evidence. But here's an example from Tempus AI, which in the fall of last year acquired Page AI. And just last month in Illinois, there is a federal class action lawsuit against Tempus AI for data privacy breach. So I will let you read the press releases that are coming out, and also more on the source that's listed here. But what I want you to think about is you could have the best initiatives, you could have the best intentions, and you could put everything in place to make sure you're doing things responsibly. But what we need to start thinking ahead now is, who are we partnering with? What are their policies? What are their values? What are their responsible frameworks? And how the data that we have been acquiring and its usage policy may change or vary once a company gets acquired, or the interests of the stakeholders change over time. So one thing which is needed to ensure that are good standards in digital pathology. And I know Junia yesterday talked about it, Norman extensively talked about it, so I do not want to belabor on the point that we need to start building standards within the digital pathology community to make the most of what we can do responsibly. So I was part of this effort from the Digital Pathology Association. It encompassed over several years, and we have stakeholders from various different parts of the pathology value chain, as well as subject matter experts who could really comment on different standards within that are needed within digital pathology. And I think this is a foundational step, and I cannot emphasize the need of all the societies coming together to continue to build momentum, to further start building standards as we start embracing different kinds of AI tools within our workflows. And I commend Sabine for focusing on the community initiative earlier in her talk, and hopefully Nadia next will focus a little bit more to further impress upon you the fact that we need to do this collectively. And I know we talked about the field experiences yesterday and how everyone who's starting out now can benefit from that. So I think a collaborative approach will also help us move faster in the right direction sooner. So just shifting gears, and again inspired by what Junia was saying yesterday afternoon when he talked about AI agents, and he said, what's next? And I couldn't help thinking about it over and over again after his talk yesterday. What's next is AI governance. I feel like a lot of us are not thinking about AI governance yet, especially when we start integrating different parts of the AI tools from different parts of the country, from different parts of the world, from various providers. So this is, again, a very simplified view of a study that McKinsey conducted in 2026, where they surveyed over 10,000 leaders from 15 different countries and looked at the adoption of just AI in the healthcare setting. So this is not pathology, but clinical AI. And what they found from the survey results was that 86% of those are not ready yet with the governance mechanisms in place. And 1 in 6 cases, they don't even know who owns accountability. And so they came up with this framework, and I'll let you go to the study. This is just a very simplified AI-generated overview of the study. But there are different action layers depending on what kind of AI tools you're using, and sort of, thought questions for you to think about who should be the responsible party and how in your own organizational setting you could maybe leverage those contexts to identify those individuals or teams of individuals who should be held accountable. This is particularly in the healthcare AI governance scene, so it's not like there's nothing happening. There are a bunch of people who are focusing on it. We are really trying to advance the healthcare AI governance, and this is some data which was analyzed by Mo Johnson, an expert on LinkedIn that I follow. And this systematic review gave a snapshot of what's missing, where are the gaps. So you can see in this pyramid, there's steps listed, whether in data governance, and as you can see, there are definite, components like accuracy, completeness, privacy, robustness, safety, workflow integrity. So some of the aspects really that you should be thinking about in each one of these layers, and of course the gaps exist in between these layers, and that's, I think, is gonna be the next step that we have to start focusing on. And again, you don't have to do this alone. I'm more than happy to talk to you all. I myself follow a whole bunch of different experts, on LinkedIn and through the research to keep up with what's happening in the AI governance space, because everything's advancing too fast. Again, going back to, I know I'm naming you multiple times, Junior, but I was really, really thinking about agents when you were talking about agents, and we have started leveraging agentic AI in healthcare and even in digital pathology now. So this was a scoping review which recently came out, so earlier February of this month. And here's like a brief summary of what the review found out. So most healthcare leaders see clinical AI as one of the decisions. And here what I'm proposing is 6 layers of oversight and governance mechanisms to take care of how to incorporate agents within your setting. And this is again for healthcare broadly. And going back to what we were discussing yesterday, we don't have to reinvent the wheel. We have to begin with what's already available. We can start layering the layers in pathology setting, specifically using some framework like this. Again, going back to agents, I'm curious to know how many of you are familiar with Moltbook. Can you show raising hands? So really a handful of individuals, thank you. So Moltbook is a social media platform for agents. And as you can notice here, it says humans are welcome to observe. So on this social media platform, it's agents interacting with agents. As a human observer, you could see the kind of interaction that's happening. What has happened on the platform so far, the agents have come up with their own language that the humans don't understand. The agents have also come up with their own religion. So this is agentic AI, which can, which can react and respond to things in different ways, which can go beyond human supervision on occasions. Of course, you have to initially give ownership of your agent within the platform, so it's human approved, but once you approve, the agents have their own agency. And just to give you a perspective of how fast things are moving, and only a handful of people here are aware of it so far, and these are statistics from earlier this year, January and February, there were 2.3 million registered agents. We've heard about surge using Facebook, Instagram, ChatGPT, large language models. In 49 minutes, there was 160,000 agents that registered on the platform. And the daily activity spiked from 57,000, over 57,000 comments, over 7,000 posts. No humans can keep track of what's going on. And the agents can also create sub-moles, and there are over 13,000 moles. At that time, there were approximately over 3% agents that were, active, and all this was happening from only 17,000 human owners. And at least at that time, there were over 2.5% prompt injections, and if you are familiar with prompt injections, they can skew the results of an output. If you have a query and in your system, you put in a prompt injection, the input can be skewed to generate very sort of polarized output. So this is sort of something that's happening. We don't have latest statistics, like everything else messy and unresponsible. Meta, of course, acquired Moltbook earlier this year, and none of those statistics are formally and publicly available anymore. So we don't know how many more agents and what kind of agency they're running right now. I would be remiss if here in Africa, I didn't talk about equity and fairness. I was really deeply moved by Bushra's talk yesterday, and it made me pause when he talked about pathology under bombardment. And I want to reinstate some of the concerns that he registered yesterday. And I definitely, coming from a resource-limited country myself, I can relate to the unstable power or electricity, weak internet or limited internet bandwidth that could limit any one of you from, adopting digital pathology. And of course, the infrastructure supports hopefully will come sooner, than later, inshallah. But one thing that I wanted to also discuss was the representation in training data sets. So that's a whole laundry list of companies and AI tools and algorithms that I told earlier. I would urge my industry partners who are here to start collaborating with our African partners to start assimilating their data sets in the mixes as they're training these algorithms and as they start scaling and deploying their AI so it remains sustainable for our African colleagues. Switching gears to education, pathology education is near and dear to my heart, and of course there are several different studies that are constantly being conducted to see what would be the impact of AI on pathology in general and the skills of the trained pathologists or pathologists in training. So this was another systematic review which was published recently in ESMO. And this is again a simplified summary of the findings of that review, and I would invite you to go back to the review to take a look at it and see what all resonates with you. And of course, there's so many advantages of using AI in pathology education. It helps with improved accuracy and sensitivity that we have seen from so many different conversations and talks that we have that were on display today and yesterday. Faster workflows, there's no denying that. Reduced workloads, of course, after that initial adoption phase. Enhanced access to expertise because we can be doing things globally, remotely, virtually. And of course, it helps improve the patient outcomes. But from the data that was collected through these systematic reviews with one intention in mind, exploring AI competencies in education over time, there were several, and it's all quantitative evidence in the article, and you should go back and see it, but there could be drops in performance after routine use of AI, especially if those pathologists are not routinely trained, in looking at the slides, analyzing them, and looking more critically about the features that are being expressed within, or that are demonstrated on the slides. There could be an automation bias. We start relying on the machine so much that over time, that human in the loop component is gone or the human oversight is gone, and we just start relying extensively with machines, especially with heuristic learning if they tend to skew, their output. Over-reliance and can also lose clinical expert independence for some of the people, some of the folks, and I think that's also documented evidence on several occasions. And especially when we talk about the trainees, it could erode the future workforce capacity if they only rely on AI tools, not keeping under consideration what all can go wrong with their usage. And of course, it's still debatable yet, but people are starting to talk about cognitive and moral de-skilling when we rely heavily on AI-related apps for any aspects of our lives. So we've been thinking about responsible pathology education for a while, and also equitable pathology education for a while. And I'm very proudly, I would say that I'm a founding board member of this not-for-profit organization called Open Pathology Education Network. I'm the current executive director. And the mission of our organization is to provide free pathology education globally, especially to our colleagues who are in under-resourced or resource-limited settings. So I invite you to check out the website to see what's going on. And very briefly stating, we have over 1,000 users from 65 different countries. We have 10 specialty modules available online. We have over a dozen in the works, and we're really leveraging experts from all over the world to build these modules. The trainees can sign up for any of the modules, and it's self-paced virtual learning. A new component that we added earlier this year, which we're very proud of, is mentoring sessions. These are dedicated mentoring sessions. You're paired with an expert from a part of the world that, you know, the time zone works for you to be able to connect with them. And what we're really doing is building a network of pathologists that are resourceful and have high competency, no matter where they're located and what kind of settings. So I do have a poster downstairs towards the end on that side that talks about some of the latest achievements of Open, so I invite you all to come and talk to me. We have Andre, who's also on the board of Open, so please talk to him, and I'm very happy to share that Matthew is going to be an incoming board member of Open, so please come and talk to either one of us if you would like to know more about Open. And just to mention, we have some connections in Africa, Dr. Maureen Waithaka and also Dr. Orada, we've been in conversations with, so we have connections in Kenya and Nigeria, and we're also making some other connections through our industry partners currently, and hopefully we will be in talks with our new colleagues and new friends in Senegal. So I had thought that I would end at this point and invite you all to start engaging in conversation. No matter where you are in your digital pathology adoption journey, no matter where you are in your governance framework, I would be delighted to talk to you and help explore possibilities and help you identify any weaknesses in your AI journey that can help bridge any of the gaps, so you can continue to leverage AI responsibly, ethically, in a sustainable and scalable way. But I was also very piqued by something that I think Joshua mentioned yesterday about a practical example. And I thought maybe I'll do a thought, sort of a thought experiment myself. So I was going to end at this slide, and this is a book that I published on artificial intelligence in pathology, edited by myself and Dr. Stanley Cohen, which has become sort of a textbook for a lot of different facilities teaching pathology. And I thought, you know what, let me take it a step further. So I added some slides. I could go beyond just talking about this book. Of course, all my colleagues here who are like friends and well-wishers, and I can see them smiling and nodding already, would approve me showing this because they know they have read the book, they like the material, and don't know it's relevant to the talk today because I'm talking about responsible AI, strong AI foundations, and there's a chapter on AI ethics. I could go a step further and urge you to buy the book now. That could be a little bit of a personal promotion because I'm gonna benefit from that. Or I could highlight another fact from Elsevier, that the book is on 50% discount right now, both for your virtual and for the bound session, kinds. And of course, if you buy a package, it's a better deal. So I still hear you all smiling. I still hear you all, laughing and see the smiles. But if I had to look at this from an AI ethicist perspective, I would say this is despite the fact it's relevant to the conversation we are having, despite the good intentions of providing or extending, access to the book to our colleagues here in Africa, what is lacking here is a representation of other very compelling books, some of them written and edited by colleagues who are sitting here, to give you an unbiased picture of what are your options out there. So I would say, depending on a person's own intentions and motives, and depending on others' vantage point, where in the value chain they are sitting and what their experiences have been, there could be various ways of interpreting the same concept. So yet again, ethics to me is not black and white, and I hope I was able to convey this to you today, that ethics is several shades of gray, and until and unless we start incorporating the voices, the insights, the perspectives of AI researchers, pathologists who are sitting here in this setting, and all the personnel really who are involved in the digital pathology value chain, to take their perspectives under consideration, we may not be able to build responsible AI. It's only when we start bringing in all these diverse perspectives together can we start building, testing, deploying, and scaling AI tools and algorithms that would hopefully remain responsible and scalable and sustainable in the long run. Thank you so much for indulging me today. Shukran.
Thank you, Dr. Chauhan, for this interesting presentation, and also for your offer. So, is there any question or comments? Okay. So okay. Okay.
One comment. Question? Is there a question? Yes. Super Japanese man. Thank you.
Great talk. I love it. So, yeah, I feel my own, direct descaling or by using the AI very much, actually. After looking at, the pathology, the models, sometimes I feel like I say, oh, I didn't know that how to make a judgment for this disease, right? We are just, too much trusting about the AI judgment. Well, that is, quite scary for us. But I was talking with, the other guy is that, okay, in terms of the educations, especially for the students, of course, fellows, who has very, very limited knowledge, but they're still already using those, the tool to reach to the good answers. What is going to be the good training, the plan by using those AI models and stuff? They are not gonna, stop using them. But what is going to be the good, protocol or the lessons to how to educate young people?
That is an excellent question, June, and you're always forward thinking about the next generation of workflows. In my very unbiased approach, open pathology education network. No, so I think we have to go back to materials that have been generated with rigor to ensure we are delivering and teaching those core competencies that set a good pathologist apart from a trainee. So I think relying on all those educational materials that are available, making these AI tools more open in the sense, we always talk about black boxes when we talk about AI, because what happens internally with the algorithms, oftentimes we fail to understand. And I think what Andre was mentioning earlier this morning with end-to-end solutions, but really these closed systems that are really black boxes, we have to start opening those up. So start attaching frameworks, quantitative metrics to what's happening. If there's a level of sensitivity or specificity, what that is, and what that gap in sensitivity means, and maybe even having explainable AI, where the AI actually gives you the reasoning. This is what I think based on these many data sets that I have seen, and this is the margin of error. And to train our future generation of pathologists to understand those nuances and to question themselves, question the AI, and go back to experts like yourself who have trained traditionally and are now moving towards digital to make sure that they're delivering the same amount of, qualitative and quantitative practice that anybody else would. Yes, Aaron.
Wonderful presentation. Thank you very much. One observation on the pedagogy side you'll be very interested now, because this comes from the Stritch experience.
Yes.
We had an educational session. There was a first-year student that says, we don't attend your classes, we take your PowerPoint, the AI gives us the top 4 questions, we study the questions, we score 83%. So now we have to flip the pedagogy. So you start with the AI and you ask the students, you have to vet the evidence. And so they have to compare the AI, make sure it's not hallucinating. The question is, in terms of the governance, can that be turned into maybe a roadmap with also outcomes or maybe even financial impact? And I think to give us tools, especially when we start interacting with either regulators or payers, they want to know what the business case looks like as well.
That's an excellent question, Aaron, like any other question you ever ask. So I think that should be the next step, having a roadmap and using that as, a leverage to reach the payers and sponsors as well. And I think, I don't think I see Norman here, but I think he'll be all over this concept too. But I think that is a collaborative opportunity between different communities, between different digital pathology organizations globally, because then we pool our efforts together to analyze, the governance mechanisms, those frameworks, what are the regional gaps, and what are some of the critical concerns we should be focusing on, and start collecting that regional and global data for comparisons, and then make a business case for that. Excellent question, Aaron. Thank you.
Okay. Thank you, first of all, for your enlightening presentation. I have just a quick side note, because we are late for this session schedule. As you said, it's a very critical topic. You said that it's not, it's several shades of gray, that's true. We deal with critical or sensitive issues like data governance, AI patient consent, and bias in AI models. So as I'm working with alongside with Professor Abawi and our colleague on ethics and medical responsibility, we still don't have in Morocco a specific law supporting this transformation. And we need, my colleague could confirm that, we need this clear, well-established legal framework to, as you said, to define good standards and protocols in terms of scanning, validation, and archiving data, etc. So it's very important, because the problem finally is how we could define the professional responsibility, especially for pathologists dealing with digital pathology. So it's very critical, I think, in our context. So,
yeah, and it's always good to have a strong foundation. So you're starting out strong when you're thinking about it responsibly from the get-go.
Yes. Okay, thank you very much, Xavi. So we move to the next presentation. Okay. Let me invite Nadia Khalile, joining us from the Netherlands. And we welcome her. She leads her research in multimodal AI at Radboud University Medical Center. and she will discuss with us computational pathology, benchmarks, and community initiatives. So the floor is yours.
Thank you so much for introduction. And it's been an honor to be here to give a talk about computational pathology benchmark and community initiative. I would like to convey the message that how we can create the community with benchmarking and how we can actually push the community for relevant clinical questions. In 2004, there is a very famous benchmark called DARPA. It's actually funded by Research Institute of Defensive in US for autonomous driving. The first time that it organized is actually none of the car could finish the course of the driving, and just a year after, in 2005, 5 cars could finish the course. And this is actually a very great example showing that if the problem is out there, if the target is introduced to the community and the metric is defined, the research and the community is pushing this way faster than one group is working on that. So if you know our group, you know also our team for the benchmarking and the challenges that we are organizing. I'm wondering how many of you actually know or know challenge, what is the benchmark, and how many have you participated in one? And how many of you actually organize one? Okay, so perhaps if you, I'm not sure if you heard of these challenges, but PICAI is one of the very successful challenges in radiology especially, and these are all started from radiology obviously, where it is for the prostate cancer detection. The result of this was also published, and it shows that these models are doing better than radiologists. And later we also organized another challenge which is for the biopsy, for Gleason grading, which had a very large data set publicly available, and a lot of participants who also submitted their model. It's still running. If you happen to submit your solution, is also still possible. And then very recent, we also organized Leopards, which was in the prostatectomy for a prediction of biochemical recurrence. With me starting in the multimodal field and the field which is leading to the precision medicine, these are the papers about PANDA and also for PICAI. If you're interested to know and dive into this, feel free. I organized last year a challenge called Chimera. Our challenges normally has an animal name, so if it is the multimodal, it should be a chimera, which is a couple of the animals together. So the first task was prediction of prostate cancer biochemical recurrence, and we collected a large amount of data sets, per data sets. When I'm saying about the per data set, large amount, a couple of hundred data is already the biggest per data set out there. And we had many participants from different countries, and eventually we had about 10 models. We had an MRI, which we put it publicly available, prostatectomy whole slide images, and we have extracted many different clinical value as we wanted to make it truly multimodal. From the age, Gleason grading, ISAP, etc., we have corrected from the EPIC. And we asked the participant to design a model for predicting biochemical recurrence. From the 6th submission, perhaps you would expect also to hear that those submissions who use all the modality who are available from pathology to radiology to clinical could win this challenge. But it was actually surprising that the first three winners only used the tabular data. And the last three winners were those that who used the multimodality. So it seems for us that there is some confusion. We didn't expect this result. So we went back to the data set and we look into that, okay, if we are having this tabular data that is highly curated, is in the Excel sheet-like format, that is extracted hours of our team. If we are extracting, for instance, if we are excluding some of these variables that are image interpreted, like a Gleason grading, what would happen to the result? And as you can see, those that only use the clinical data suddenly drop the performance dramatically. And those who have the multimodal, that they use the image as well, obviously more stable. And this challenge had also two other tasks for the bladder cancer, where we were, in non-invasive bladder cancer, the regular routine treatment is to receive BCG, but BCG is also not very, the response rate is firstly very low. It's somewhere between 40 to 50% of response, and is also scarce in the world. There is a shortage of BCG. Therefore, together with the Erasmus Center, we have developed a biomarker called BRS, which is interpreted from RNA sequencing. We correlate this with the survival, and we find out those patients who has a BRS3 that they often respond less to BCG. As Joe in morning also mentioned, this is just another test, perhaps adding to the pathology, but is not actually coming to the routine because acquiring RNA sequencing is costly and not any soon is gonna be part of the routine. So we wanted to use AI to be able to detect BRS3 directly from whole slide images. And my PhD student spent his PhD, and perhaps this slide is the summary of his 4 years of work to develop a model to detect BRS, which is a BCG response directly from whole slide images. The model that we have trained could achieve a result of AUC curve of 72, and we have validated also for the single-cell transcriptomics. We have also collected some clinical variables from age, sex, smoking, staging, etc. And you can imagine where we are going. We also put this as a public data available, and we call the community to design a model for it. It takes maybe 2 months to achieve better result than what we have achieved during years of work, with the AUC curve of more than what we had. And we also take it to next step. We put also RNA sequencing publicly available for together with the whole slide images, and we ask them to participate to design a model combining two different modalities for prediction of the recurrence for the non-invasive bladder cancer. And you can see the C-index that is in the, compared to the state of the art, are somehow acceptable and is actually higher than the state of the art. However, again, the first and fourth winner, they only use the clinical model. It doesn't mean that they didn't develop multimodal, they did, but during the validation, they find out that their clinical model outperformed. So I had a, confusing feeling that this is far from the reality. If I'm going to the EPIC every day, I see that how messy this data set is. It's very far from the clinical data that we have curated completely, especially if you're stepping to the multimodal. Yesterday, Henry also mentioned that between the two different departments, pairing this data is impossible. Sometimes very simple problem like a pseudo-anonymization, pairing from one department to other department, we started from maybe a couple of thousand of patient data and we ended up in a couple of hundreds. So the reality is very messy. There is sometimes, for instance, a fax from another lab that is sending the PSA value of the patients, and we have to really deal with all this messiness. As an AI scientist, if I train my model in very clean data, I'm not sure if it is really close to the clinical reality. And yet, if I'm giving the clinician another value, that is the AUC curve is 0.70, 80, or C-index is this value, does it actually add much value, or is it also bring another confusion? What does it mean for them? Where does it come from, actually? So we look back at the Chimera, and we are now organizing the second version, which is the Chimera Agent Challenge, with the three aims. Firstly, we would like to develop a challenge that closely reflects real clinical decision-making, including the messy data, clinical data, incomplete information, and sometimes the conflicting information. From one modality, you may interpret an information that is not in the other one, and it might be, for instance, more important to have BRCA mutation than what is the pirate value. And to advance explainability, as previous speaker talked about, that we would like to be able to have agents or LLM that is explain a reason about what is actually doing. So we would like that in the next Chimera, the participant design a model, but not just giving the final result, but the reasoning that why they make such a decision. And we are evaluating this reasoning. And lastly, to build up the clinician decision planning tool that support the clinician when they are making the decision. So we are focusing in Chimera Agent in only prostate cancer. As you may know, when the patient with a prostate cancer or suspicious prostate cancer step in the clinic, perhaps has a PSA value which is high, and then they are acquiring MRI, and the question is whether this patient should perform biopsy, yes or no, and then later is a PET-CT scan, and then if it is not active surveillance or definitive treatments, another decision would be that whether this patient have to have active treatment or definitive treatment. And this is very simplified explanation. The prostate cancer patient has, there is so many decision tree that as AI scientists, for me is confusing, and sometimes when I'm talking with the clinician is also more and more data that they are dealing with. But to make it achievable for the agentic AI, we made it 3 scenarios. The first scenario is that should you perform biopsies with a given the certain information. We actually created something similar to EPIC-like data. This is generated, but the information is itself, the clinical information are from the real patient. So we are giving this form to the urologist, and then we ask them to decide about it, whether we have to perform the biopsy, yes or no. And then the next page is to reason. Which field did you use? What is the most important information that you based on your decision on? And they have to also write what is the reasoning. And this is gonna be the base for us to evaluate the AI model where we are using the agentic model. As I mentioned earlier, we are lucky that we are having all these AI tools in our department, so we are going to use that as a tool for the agent too, whether it is coming from the MRI, from Gleason grading, or from the prostatectomy. So this is also shown to the LLM model and also to the urologist. The second question that we are also introducing is active surveillance or definitive treatment. So we are also showing the urologists the pathology report together with the radiology report and the PSA trends, and then we ask them to make the decision based on the information that they are seeing. And then they have to also choose which field was the most important and also write down the reasoning that they made this decision. And the last one is mostly about the explainability, where we are having the biochemical recurrence with the 3 different modalities, with the whole slide images from biopsy, from prostatectomy, and MRI. And the solution that they are submitting, they have to explain why they decided this patient is high risk, medium risk, or low risk. And then this is perhaps going to be our baseline that we also put it for the participants, where we are having different tools, but they can also bring their own tools. And the agents, they can also design it differently. And any LLM model, but it should be openly accessible LLM, open source, because we don't want data to go to any API. And they can also use as a knowledge, like a guideline, like a European guideline or any other guideline that is relevant. So I would like to invite anyone who would like to participate in the challenge, but also, like, if I heard many of people here are urologists, or you know someone that who would like to contribute to the challenge that we are organizing, since now that we are in the process of that, is also many possibility to collaborate together in there. And I would like to share the lesson that we actually learned from Chimera. Firstly, paired data is very scarce and it's very difficult to collect the data that are fully paired for the patient. And if we are stepping toward the precision medicine and multimodal AI, this is a real challenge. And without collaborating and open data, it's very impossible to achieve there, to have a good model that is actually possible to apply in the clinic. And the second lesson that I personally learned is that the benchmark winners doesn't necessarily mean that it can also win in the clinical setting. The top submission used the clinical data alone, while it is not the reality of the actual clinical need, perhaps. And as much as we are pushing the clinic to be more and more standardized, I think as an AI scientist, we have to also think that the mess that is in the data set should be very flexible to what we are designing. And we have to actually have a different approach in compared to a standardization, in my opinion. I would like to invite you for the Open Data at MICAI 2026. I'm in a board of Open Data MICAI, and I think it's actually very relevant to what we are talking here, as it is promoting to submit any paper with the open data and any annotation, etc. And the deadline is in June, so I think it would be a great opportunity if you are having a data and you would like to write some paper about it. Like many people that already invited you to the AFSDP 2026, I would like to also take the opportunity to invite you for AFSDP 2026. And I'm very thankful for the time and opportunity to talk. If you have any question, the floor is open. Yes. Okay, sure.
Okay, thank you. We are late for this session schedule, so we, yes. Okay, thank you very much. It was excellent.
Thank you, Dr. Nadia Khalil, for this interesting presentation. Now we move to to our symposium, named Industry Symposium about Digipathics project, about 5 million slides and artificial intelligence in a network of 8 hospitals, presented by by Jordi Champrana Salvador. Thank you. So the talk is for you.
Hello, thank you for inviting me to this deck and the organization for this event. I'm going to try and summarize a bit our project, our experience in this Catalan project, where we have a fully digitized network of 8 hospitals, and at the moment more than 5 million slides totally digital. So to begin with, who are we? This project was led by me as a pathologist, and Pau Lopez, the guy you have here in the picture, who's an engineer. The thing is that we have to go together. The first message that I want to give always to anyone who's starting with digital pathology, it's very important that we need to keep engineers working with us, because they need to understand. We need to tell them as pathologists, we need to tell them what we need, and they need to understand perfectly how a pathology department works to be able to do the right adaptations. So what are we? I mean, the Catalan Health Institute is the largest provider for the Catalan health service. It's the insurer of universal health in Catalonia. We are over 53,000 professionals, 8 hospitals, over 300 primary care teams, and that many surgical interventions. So that's who we are or where we are. That's the hospitals that belong to this network. And we have 24 scanners at the moment from 3D Tech. We are giving a service to 168 pathologists, almost 170 people working with this solution. And at the moment we have over 5 million digital slides, all of them coming from primary diagnosis. We're producing more or less 1 million slides per year. And we also have AI built into our workflow, AI that we developed in our own in collaboration with a local university. So the thing here is we have this clinical ambition to increase the patient safety and the diagnostic quality. We wanted to reduce delays to improve the turnaround time. We wanted to have second opinions, subspecialization, and diagnosis. And we wanted to give this comparable access regardless of the hospital size. All hospitals had to be digital. This, of course, has a technical ambition, meaning we need scanners, we need an LIS, we need the viewer, we need storage, we need infrastructure, and we also, this is very important, we wanted to have the same LIS and same image management system for the whole network, for all the hospitals. And also we wanted to have this project managed with a clear, as a service, with a clear service levels for downtime, for incidents, because shit happens. I mean, in a big project, you're gonna get things that go wrong, so you need this to be fixed. So we're gonna discuss the need and the vision, the architecture, how the procurement was done, how it was implemented, and the AI and the future. The key question here is not which scanner are we buying, but which model can we sustain in our project. So why did we start? Why did we want to transform pathology? In this case, you all know, I mean, pathology is based on microscopic observation, but it's getting more complex with molecular pathology, with prognostic factors, and they demand us to give this rapid, reproducible, and subspecialized diagnosis. So traceability matters, digital matters, because it gives us traceability and fewer identification errors, so security for our patients. We have access to current and previous slides without interrupting the workflow. We just have all the information available while you're doing your diagnosis. We have the opportunity to have collaboration for 2 more boards, second opinion, and teaching. And we have this image data sets that we can use to train our own computational models. So this was the challenge. We started with 1 million slides per year with this expected annual growth of 10–15%, 168 pathologists and 8 hospitals. In the first version of this tender, which this was in 2019, we excluded routine cytology because of the scanning time and the cost, because cytology would mean increasing 500,000 slides for this project, extra 500,000 slides, which is something we could not afford. But still, we can scan relevant cases for consultation or teaching. And now we're doing the second round of this project, where we're scaling this to a CISCAT project, which is, we're adding 12 more hospitals to this network, 24 extra scanners, so we're gonna get around 50 scanners, and almost another 1 million slides per year to be produced. So we're still starting that one, so at the moment it's just the digipathics one, but we're gonna get it rolling this year. So what's the purpose of the digipathics project? We wanted to improve the safety, traceability, and quality of the diagnosis. We wanted to reduce the material losses when you transfer slides, you have identification errors, missing physical slides or blocks, right? We wanted to support also this quantification and morphometry using AI and computational tools. We also wanted to build this network with sharing cases and second opinions instantly. We wanted to coordinate referrals without moving glass slides, and we wanted to promote this equity across hospitals, no matter of the size or the geography, all the patients have the same opportunity. And also we wanted to have this long-term repository. I'm going to talk about this afterwards, but we understood that this repository for images was the good data set to teach, to train our own algorithms, and also to deploy our AI in the loop, right? We're having the AI working with our pathologists straight ahead. So what did we build? So we started with the scanners. We got the scanners from 3DSTech. We got the server and the storage architecture for short-term and long-term access. We have the integration with the LIS and the workflow. The LIS is built in-house. It's not a commercial one. And it's fully adapted to the digital workflow. And all the system is LIS-centric. The LIS is what really governates the whole project. We're using the diagnostic viewer from 3DSTech, and we have this ergonomic workstation. I'm going to show it afterwards also. And we wanted to have this governance for image quality and for traceability and downtime, meaning we don't want to go back to the microscope. And since November 21, I haven't used a microscope for biopsies, which is good, right? And now we have the first residents that are finishing residency, and they haven't used microscopes for biopsy, just for cytology. So what questions do we need to solve before procurement? We wanted to define the clinical scope. We want to use digital pathology for bright field, for primary diagnosis, but also for fluorescence, meaning FISH and direct fluorescence. Because we understand that if a pathologist is working from home, you need to have all the information there. You need, if you want to share a case, you want to share the whole thing, not just the bright field, right? We also included the macroscopic images, which are not as complex to manage as microscopic because they are smaller in size, just JPEGs, so that should be easy, but you need to ask for that because otherwise it gets forgotten. And as I said, cytology was not in the scope initially. As for the technical part, we needed to have this new LIS, a DICOM storage for this Syndicate long-term repository, and this local storage for fast diagnosis. And as a service, what we wanted is to have a teleconsultation service, a teaching service, and the support and AI tools for our daily work. Okay. Also, we needed to define all the service level agreements, the maintenance kind of solution, and the risk sharing, because this contract had a shared risk. I'm going to also develop afterwards. So here you have the scanner. This is the P1000 from 3DSTech. It's a high throughput bright field scanner for the routine cytology and double slides. This is how you load it with the Sakura racks. And here you have the objectives. It's a 20x, a 40x, 40x with immersion. The camera is up there. And the standard resolution we use for everything, it's a 40x, 0.24 micron pixels, but we are able to scan at larger magnification if the case is needed. We also wanted to have the fluorescence-capable scanners for fish and direct fluorescence. We wanted to have this, as I said, resolution beyond the 40x just for when it's clinically needed. And we also wanted to have this redundancy planned. So if a scanner breaks, because again, stuff happens, the hospital doesn't stop. And we don't have to go back to the microscope. This is the deployment of the scanners in the region. We also had to include these large, high-quality medical-grade displays, monitors, for fidelity and comfort. We're using the LG monitors, which are medical devices. We had to add the LIS and the viewer, and we had those input devices you can see here at the bottom. We offered pathologists the option to select which one did they prefer. The microscope thingy, the slide driver from 3D Stack, helps because if you're giving a pathologist the same feeling in digital than with a microscope, they tend to complain less, or at least that's what we thought. But some pathologists prefer just the vertical mouse or the Kensington trackball thingy. There are plenty of options around, and well, it's to select what works best for you. We also included webcams and microphones, so it was 2019, 2020, and there were not that many video calls at the moment, but with the COVID experience, we thought this is gonna be good to have it, and if we wanna work as a network, we're gonna have calls, right? So we included all this also. And this is how we work. 2 LG 32-inch monitors, one with the LIS. The LIS is ready for the big monitor. The other one, we have the viewer where you navigate. If you change the case, you go to the list and switch to another case. The list is similar to what Sabine explained with a number of blogs and everything there available. If you change the case blocks. So you cannot diagnose the colon adenocarcinoma in the wrong polyp, which of course is a safety measure that you cannot have in the microscope. Here we could have it, so we implemented that. And also we have here the viewer with, this is for me the best quality assurance you can have, which is having the picture of the glass slide and then the reconstruction of the tissue that was scanned. This is breast. You can see that, I don't know if the laser worked, yeah? No, that doesn't work. Here at the bottom of the slide, there's some tissue missing. Is that dramatic? No, because it's fat. You can see, you can tell from the other image. So you don't need to resection or rescan that image. Also, the image is touching the border here, maybe in the side, right? It's not dramatic. Maybe this was in the beginning. We need to tell the technicians to make sure that they center the tissue properly, but you have this quality assurance in your case for every slide that you're looking at in your microscope, okay? And here the idea was to get one viewer, as you can see the one ring up there, one viewer for everything. Okay, we're using the 3D Stack viewer, and it covers bright field. You can have multiple slides at the same time. You can align them automatically and move them together, so that's good to compare immunohistochemistry. We had the fish, direct fluorescence, and the results for the AI algorithms that we're developing. Everything is on the 3D Stack viewer, so it's just one software that we need to manage, one software that the pathologists need to learn how to use and to maintain. So it's easier for the project itself. And also we have the macro photographies integrated there. I do head and neck and cytology, so here you have a mandible there, and well, that's good because you can always check, no, what did you do with that resection. So how did we plan the storage? The storage, this was planned again in 2020, 2019, so not ideal according to today's standards. Today I would ask for full DICOM everywhere, but for us we went for an hybrid model where the scanner sends the image both in MRXS, which is the 3D Stack format, and DICOM at the same time. So we are using MRXS in the hot storage in the hospital, on-prem, which ensures maximum speed and no latency when working with that image. And then at the same time, we're storing this DICOM format in the central repository. Now the fun part. The central repository was provided by the government for us. It is free forever, and we can store whatever we want. So we have over 4 million slides at the moment and growing, and nobody's asking us to delete anything, which is amazing, and I don't think anyone else has had that much luck, but this was a good opportunity. So also we're using the repository, the hot repository, to deploy the AI algorithms, so pathologists can see the results, and the cold one to train the AI models. So images never leave our ecosystem for safety reasons. The main idea here is to keep primary diagnosis fast, but making the long-term storage interoperable with ICOM standards. So about infrastructure requirements. We need to update all the networks, all the cables, everything, because you're a pathologist, you know that there's a microscope, you have the sample there, you have your ICER, and the light travels, light speed, this is really fast, so that's 1 nanosecond latency. So this is really, really fast, what we're used to as pathologists in the microscope. Computers cannot be that fast. Computers use milliseconds latency, so they are slower. So we need to make the network, the infrastructure, everything as fast as possible to try to reach, it's impossible, but to try to reach the speed that we get with a microscope. So this was also a good effort, a good economic effort to plan for a good network and servers to be able to manage this system. So how was it funded? In this case, we decided to go for a 4-year implementation service-oriented tender plus a 4-year of maintenance. So it's 8 years, but as a service. We didn't buy scanners. It's not about buying scanners, even though the equipment will belong to us after the contract. And one of the important parts, we went for a risk-sharing model with the supplier, meaning if the solution is not working in production, those guys are not getting paid. Okay, we have this service-oriented kind of invoicing. Okay, we're related to objectives and activity. The idea was not to save money. We actually paid 100% of what was planned, but to make sure that people who came to us were really, really certain that they could do it. Right? They were confident about the project. Also, we included a maintenance model with all inclusive kind of guarantee where everything is included. Because if a monitor breaks, the pathologist cannot diagnose. So you cannot be waiting for 3 months to get a new monitor or a new computer or a new piece for the scanner. I mean, you need to have everything back online in 24, 48 hours. So that's what we ask. This is contractual response and resolution times. Okay? And also, this is important because we are tired of seeing scanners in hospitals that are not being used, because they're not being integrated, because they break and nobody fixes them. So we really don't want to spend that much money and then be stuck with a machine that's not being used. Okay, so how did we award this tender? We had these automatic evaluation points, 51 points related to economic valuation and to an automatic points, okay? And also had this judgment-based technical criteria, 49 points. Out of those points, 17 were the scanners, 8 were the diagnostic viewer. And there were minimal thresholds for the scanner and architecture, meaning if you're not convincing us about the scanners, you're out, because without a good scanner, you cannot have a good digital pathology project. Right? And how did we assess those judgment-based technical criteria? We did these technical tests. We had 3 tests. Here at the top, you have me with longer hair organizing slides, because I went to the hospitals and tell them, okay, give me all your slides for the month of January. And we took all those slides, which are, of course, randomly organized in different proportions of breast, gynecological, whatever, skin, no, it's random, small and big samples, everything random, and we scanned those images, those slides, with our pre-analytics, which is bad, but still, we didn't trust the technical data sheets that the vendors offer. So we had all the scanners there running for 5 days, 24 hours. We scanned over 10,000 real slides, and we assessed just general kind of data like scanner speed, slides per hour, failures, rejected slides, and then image quality. It's mainly to ensure that the scanners are robust. So if a slide jammed, we went and tried it to the other scanners to compare which one was more robust. And then we had the group of pathologists, here you can see them on the bottom, all of them checking the images, different pathologies, different subspecializations, checking if they felt confident. And our question for them is, do you feel like you're gonna be able to diagnose with this image? And they would just went yes or no. Why? Because it's fast, because it's slow, because it's blurry, because whatever. Any reason. What matters if the pathologist feels safe or not. Okay? So, what in the financial kind of aspect, how does it go? I mean, it's very expensive. A project is expensive. You have scanner cost, you have maintenance cost, workstations cost, servers, LAN, everything, okay, and software. We valued that we were going to reduce physical slide logistics, that we're going to be faster, that we're going to have remote work, we're going to be able to work as a network, okay, and have those tools for research and teaching. And the thing here is that we did this study with Sir Matthias Gill in 2025 and other hospitals, evaluating the financial insights of the digital pathology, and it seems that you get to a break-even after 6 years. So actually, most of the benefits stay, because the safety, maybe it's difficult to evaluate, but you still get your money back in a few years. So how did we do? How did we implement? People was essential, of course. Lab technicians, you have to involve them, pathologists, and also the IT people. And what we did is we jumped into the pool. That's how our process was. I mean, there's no coexistence between the old, the microscope, and the new, the scanner workflow. Because we thought that if you started scanning just bright field or just breast or just whatever, this would make everything more complex inside our lab. So what we did is we jumped into the pool. Before we had to check that there was enough water, of course. And we told the pathologist, if you, from this Monday, you go digital. If you don't feel confident with that, because the image is not okay, or because you're not confident just for any reason, you just go and move from your chair, okay, like this cat, you have to move, stand up, okay, make an effort, go to the archive, and there's this guy in the archive just checking TikTok, doing nothing, waiting for pathologists to ask for a glass slide. So if you are mid-case and one slide is just a bit blurry or you're not confident, you go to the archive, you get that slide, you look at that microscope, and you sign the case the same day. You don't need to wait a few minutes, a few hours, no. But you still have to make this effort to move from the chair, which I think that forced people to actually use the screens, no? the digital option. And then, still, the most difficult point was not the digital part, was the LIS stabilization. The LIS was in-house, was new, so that was tricky, but well, we managed after a few months. And also, what's important to notice is that all the pre-analytical imperfections, like the folds or whatever, become a lot more apparent in the digital workflow. So we actually became more exigent, no, more exquisite with all the pre-analytics without technicians. And we never had, in the whole project, the whole 4 or 5 years, a total stop related to scanners. Okay, I was afraid that the scanners would be the problem. They are not. Actually, they're reliable enough. This is what the implementation went, how it went. It took us 1 year to implement the whole 8 hospitals, and that's it. More or less, people get used to it in 2 weeks. When you start, after 2 weeks, they start feeling confident, and maybe after 1 month, they are fine with digital pathology. The thing is that we had this guy, for instance, that he kept telling me, I'm not going to use digital pathology, I'm going to ask for all the glass slides, and I just ignored him. And 2 days after, yeah, that's my how do you say it? Management of change, no? I just ignored him. And after, I mean, it's 170 people. You cannot be catering to everyone's needs, right? After 2 days, he was like, okay, no, this is fine. I mean, it's fast, it works. So when you give them a solution that works, people feel good with it, and they just feel the advantages straightforward. Okay, those are a bit of the risks that you can have, no? And actually, the most problems we had are related to the network or to the software. And what about artificial intelligence? In our case, we have this collaboration with a local university, the Polytechnic University of Catalonia. We are developing our own AI tools, AI algorithms, which belong to the Catalan Health Institute, to my company, and we have the intellectual and industrial property of the algorithms. The inference is offline, so the pathologist opens the case and the image already has the results there, and well, that's more or less it. And well, the thing is, let's skip that one because teaching. Well, now we can share cases. We have telepathology. We have people working from home. We have the option to give a link to someone else to check a case, no, synchronous case sharing with another expert. We can share the cases simultaneously, working as a virtual multi-head microscope. I mean, the advantages are clear. We have already discussed them. And also for clinical boards, for the tumor boards, I like being able to show them the images because, for instance, in head and neck, to show the margins or the depth of invasion of the tumors. This is something that, of course, clinicians value, even though it might not be a revolution for them. It's a good tool for them to have. And take-home messages, mainly, is that this is an organizational, functional, and technological challenge. It's difficult. I've been told that when I explain this project, I make it sound too simple or too easy. It's a lot of work, but well, if you plan for everything properly, it works. And also, well, you have the network. Working as a network is, of course, an equity tool. It distributes expertise without moving glass slides. We had to take a lot of infrastructure decisions, which are very important. We had to plan a lot for this to work, because if it's not fast, the project just fails. Integration and interoperability are key. I mean, we want HL7, FEAR, DICOM for every single machine and aspect of this project. Sometimes it's not 100% doable, but you still need to ask for this and try to aim for that. And well, that's more or less it. I mean, my last message would be to get the right partnership. You need to get a partner that's flexible, that has high quality products, and has a long-term collaboration and commitment, who can adapt. Because in our case, our institution is very bureaucratic. It's a large public institution, so it's really difficult to adapt. We cannot adapt. So we need a partner that's flexible, that can cover if we are missing anything there. And just to finish, we have here the link for the map of digital pathology. We already talked about it, but please, guys, check it out and submit your hospitals if you have any digital experience. And again, the GRADS Congress in a few weeks. And that's it. Thank you very much. I don't know if there are any questions or people are hungry.
Any questions? The audience? Okay, thank you very much. Thank you very much. So now we are pleased to welcome Dr. Hafsa Akbli, a PhD student in computer science and artificial intelligence in Italy. She will present multimodal oncology agents for clinical decisions support. Thank you.
Thank you.
You have 25 minutes. Thank you.
So, hi everyone. I'm Hafsa Akbli from Morocco. I'm a third-year PhD student in the University of Udine in Italy. So today I will, sorry, I don't see the presentation.
enchaîner rapide. J'ai pas vu du tout. Ah, bah oui, je sais pas du tout. Vas-y, demande.
So we apologize for these technical issues. Thank you for your patience.
already did. Okay. Finally. So, hi everyone. I'm Hafsa Akebli. I'm a third-year PhD student in the University of Udine in Italy in computational pathology. So today I will talk to you about a quite recent topic, which is the multimodal oncology agent for clinical decision support. So I will start with a brief introduction, then I will introduce the main characteristics of the LLM agents. How do we use the LLM agents in healthcare? What are the main components of the LLM agents? And then I will talk about the evaluation and actually the dimensions of evaluation of the LLM agents. And I will show two examples from the literature about two papers that have introduced the multimodal agents. And finally, I will present our work about the multimodal oncology agents, MOA, for IDH1 mutation prediction in low-grade glioma. So the background, the dataset, the histology tool that we have built, the MOA architecture, demonstration, evaluation, and finally conclusion and ongoing work. So the nature of the data in healthcare is heterogeneous and multimodal. And each modality, such as radiology, genomics, clinical data, histology, captures a different aspect of the patients. And the recent studies have shown that these multiple data modalities provide complementary information for clinical decision support. So the multimodal LLM agents are based on the large language models as a central reasoning engine that processes the information coming from multiple data modalities. So what is special about them is that they go beyond the static prediction because they are interactive with the user and they reason based on a given task to support the clinical decision making, and they are quite useful, especially in the multimodal settings and in the complex settings. So this figure, I took it from a review paper quite recent about AI agents in healthcare. So these are the main characteristics of the LLM agents. So first, they can understand and generate the text. So they can make a dialogue with the human, and so they interact with the user, and they can generate content. Also, they can use external tools, so they can select and call the appropriate tools and collect the tool outputs from them. And also they can retrieve information from external knowledge sources, and they can be integrated with information systems and devices such as the laboratory information systems, and they are also applied to diverse clinical tasks. So they are like, how do you say, like switching from domain to another domain. So they are like cross-disciplinary. And also they can reason logically based on a given task, and they can decompose the task into multiple steps. And here actually the prompting strategies are very important. So the user must design a very well-designed prompt so that it helps the agent to reason like in the way that we want him to reason, or that we want it to reason, right? So, so to guide him, right? And finally, we have the learning and the adaptation capability. So the agent can learn over time based on the feedback that it receives from the user. So it can adapt and it can improve its performance. All these functions are performed autonomously. So how do we use these LLM agents in healthcare? So the LLM agent plays the role of an action planner and a results aggregator. So this is actually one of the first papers that have introduced a multimodal LLM agent. It's called the MMed agent. So as you see in the figure, first of all, it receives a medical input, which is like a medical content, right, for the patient, and a clinical question, which is the query. And based on this inputs, the agent decides what is the tool or what are the tools to use. And here they are named as experts because they are experts, they are specialized. So the agent calls the tools, and so it executes them. And then it collects the tool output, and based on this output, it makes, how do we say, like formulates the answer, synthesizing the tool output and elaborating. So it gives the response to the user. So this is an example. For example, the user asks the agent, is there a tumor in the brain scan? If so, detect and describe it. So the agent thinks, and it decides, I will use grounding Dino to help detect the tumor. So grounding Dino is the name that has been given to the tool that was constructed in this paper that does the object detection and specifically the tumor detection. So here, grounding Dino, there's the laser. No. The grounding Dino is executed, right? And the grounding Dino gives the output, which is the bounding box. Yeah, bounding box of the tumor. So the bounding box coordinates of the tumor. As you can see here, we have the coordinates in pink. And then the med agent uses these outputs coming from ground Dino and formulates the last response, saying that the tumor in the MRI brain image is located with bounding box coordinates, etc. And then it gives an interpretation. It says, this indicates that the tumor is situated in the central region of the brain, etc., etc. So the LLM agent components are first the core models, which are the LLM models. They can be either open weight or like you should pay for them, like GPT, Gemini, Llama, Qwen. Then we have the clinical environment. So we have the multimodality data. So the clinical data can be radiology images, radiology reports, pathology image, sensor data, genomic data. And then we have the external tools. So the external tools can be like database, right? APIs, calculators, or clinical guidelines. They can also be expert models, so which means that we can locally take a model and like train it, and we build a tool from this model, and then we take this tool and we integrate it in the agent's tool set, so that the agent can call this tool. So how can we evaluate the LLM agents? Evaluating an AI agent is not like evaluating a standard prediction model because the LLM agent has many dimensions and many components. So my supervisor told me evaluating the LLM agent is like evaluating a person, and I think this is very right. So for example, we can evaluate the quantitative performance of the agents. And for this, for example, we can evaluate the prediction tools that are integrated in the agents. And using, of course, the classical metrics like accuracy, F1 score, AUROC. And we can also evaluate the semantic correctness, which means that we can evaluate the answer that is generated by the agent and compare it to a reference answer that we know that it's correct, and we compare them, and here we can calculate metrics such as rouge, bleu, bear score, etc. Also, we can evaluate the agent's execution, and here we should answer the question: does the agent complete the task correctly? Does it use the correct tools that we wanted to use in the correct order? And is it done as we wanted? So here we can calculate the completion rate, the success rate, etc. Then we can calculate the operational efficiency, which means if the interaction with this user, with this agent is efficient. We can calculate the response time to see if the speed of responding is okay, right? Then we can calculate the number of interaction rounds, which means the number of back and forth exchanges with this agent until the agent completes the task that we want him to complete. Then we can evaluate the output quality, which means the answer of the agent. We generate the responses of the agent, and we can give it to a group of specialists and guide them through a list of questions so that they score the usefulness, coherence, readability, and safety. Then we can average these scores to report them as the qualitative performance of the agent. And then we can evaluate the humanistic care of the agent, which means if the agent addresses the patient's psychological and the healthcare service needs, and here it's more very subjective, it's the satisfaction of the user. So the LLM agents can be applied for clinical decision support, so diagnosis, question answering, treatment, clinical monitoring and health management, clinical documentation, report generation, and the training and education. So this is an example of a paper that have introduced a multimodal LLM agent. So what they did here is that first, they used MRIs to predict pathological markers, which are the microvascular invasion and tumor grade and other variables, pathological markers. And then they use these pathological markers, as you can see in the second part, second horizontal part. So they use these pathological markers plus the clinical data, and they make a text from this. So there's the text conversion. There's the text conversion. And then they feed this to 6 LLMs. They just want to compare the performances of these 6 LLMs to choose one in the end. They also use external knowledge access to add more evidence. And finally, they generate these answers, so these reports, which are the hepatocellular carcinoma personalized clinical decision making. And they give to 4 senior surgeons these reports so that they evaluate them in terms of clinical consistency, outcome alignment, feasibility, or practicality, personalization, and adaptation. Yeah, so this is they only did the qualitative evaluation of the agent. Another example is the multimodal AI agent for diagnosis question answering. So here, they use the radiology images, they use the laboratory examination and pathology examination, and also the clinical data. So first of all, the first part on the top concerns the diagnosis question answering data set. So they generated pairs of questions and answers to evaluate their agent. They used GPT-4 for that, and then they constructed their multimodal AI agent. They called it medical multi-agent, because this is like one whole agent, but it has 4 sub-agents. So one is the pathologist, one is the radiologist, one is the laboratory scientist, and the last one is the general practitioner. This last one is like he gives the last diagnosis based on the 3 other ones. So I mean, I think this is very nice because it's like the whole diagnosis based on many aspects. So so this MMA system is based on 4 GPT-4V based specialist agents. So they use the vision part of GPT because they feed directly the 2D images to the GPT. So here, for example, as you can see in the radiology, for example, it uses the MRI, the ultrasound, and the X-ray to make the radiology report as an output. And finally, they evaluated this MMA with, based on the diagnosis, question and answers that they have generated before. Okay, so now I move to our work. I need some water, sorry. So we presented this paper at the International Symposium on Biomedical Imaging that was held in London this month, the first week of this month. So it's about multimodal oncology agent for IDH1 mutation prediction in low-grade glioma. So yeah, we won the best paper award, and it was a very nice news. So I worked on this together with, co-supervised by my official supervisor, Vincenzo Della Mea, together with Adam Shifford and Nasir Rajput from the TIA Center in the University of Warwick in UK. So, so IDH1 mutations occur in approximately 50 to 81% of the WHO grade 2 to 3 low-grade gliomas, and they define clinically distinct subgroups in terms of prognostic and therapeutic implications. So the most existing IDH1 mutation status prediction methods are unimodal. In general, they use the histopathology images or the radiology images. So this motivates our multimodal oncology agent that we call MOA, that combines histology, clinical data, genomic data, so like a molecular summary, and the external biomedical knowledge for IDH1 prediction in low-grade glioma. This is the overall MOA workflow. So this is our really cute MOA on the middle, and it uses as input the clinical context, which consists of the patient's clinical history plus the molecular summary and the histological data and the query. So I will talk about the query later. So the MOA, based on this input, like it reasons, right, and decides what tools to call. But these are the tools that we made at his disposition. Based on the whole slide image path, it can call the histology tool, and the histology tool predicts the IDH1 status, the IDH1 mutation status. So is it mutant or wild type IDH1? And then, based on the input also, it formulates search queries to retrieve evidence from PubMed, from Google, from OncoKB for the genomic annotation, and also from a database that I will explain later, so that we construct it like a knowledge source. So these are the external knowledge sources, and this is the histology tool that we build like locally. So the MOA reasons and aggregates and calls the tools, and then aggregates all the retrieved evidence and the tool outputs into a structured MOA report. So for this work, we used the cohort of TCGA-LGG, which is low-grade glioma, which consists of 488 patients with confirmed IDH1 status. We have 374 mutants and 114 wild type. We also extracted diagnostic whole slide images from the TCGA. So we retained only the whole slide image having the biggest tumor area per patient. We used the somatic mutation profiles that we extracted from TCGA, the clinical records that consist of the demographic, diagnostic, and the treatment data. So then we built a histology tool for IDH1 prediction. So first of all, we took the whole slide images, we tiled them into patches of 512 by 512 pixels at 20 times magnification. We retained only the patches with more than 90% tissue content. Then we extracted the patches features with Conch foundation model, and we aggregated them with the Titon foundation model. So we got at the end 768 dimension feature vector per whole slide image. And we trained a 4-layer, multi-layer perceptron for IDH1 status prediction. So this is the MOA architecture. So first of all, we built structured patient cases, so the 488 structured patient cases with the clinical context, which is like a text that we made based on all the clinical data that we gathered, demographic, diagnostic, treatment data. Molecular summary contains the pairs of each Hugo symbol, each gene, with its alteration. And the histological data contains the path of the diagnostic whole slide image. So the tool set of this agent is PubMed for biomedical literature, Google search for web evidence, OncoKB for genomic alteration annotation, and the histology tool for IDH1 prediction. So we also constructed a retrieval knowledge base based on Meditron clinical guidelines corpus. So we filtered this data with glioma specific keywords and IDH1 specific keywords. We retained 187 relevant documents, and we embedded them with a large language model, and we stored these embeddings in a local Chroma database so that the MOA can retrieve information from this database when needed. And so the MOA reasoning. So the MOA is based on GPT-4, and it can do the autonomous multi-round, the tool calling and reasoning. So actually, when the MOA calls a tool, based on the output of the first tool, it decides what next tool to use. And this is very nice because it's an autonomous functioning. So as I said, the input is the patient case and the query, and the output will be the synthesized MOA report. So this is a demonstration of a patient case from our cohort. So as you can see here, we have the clinical context and the query, and the query was very generic. So we just asked the agent to evaluate the case comprehensively based on all the data that is available, and then to look for like treatment options and like disease outlook, and to summarize all the information that that he will find. So the GPT-4 assistant is our LLM core model that we use. So the MOA decides, formulates a solution strategy of all the tools that it will use, and then it selects the tool, defines the target of the mutation alteration to call from OncoKB, defines the queries for Google and PubMed, and calls the histology tool, and finally makes the report. So now, how did we evaluate these agents? So we wanted to know how informative are these reports for IDH1 mutation prediction. So we generated all the 488 MOA reports, and we disabled the histology tool because as you can see here, the histology tool already gives us output the IDH1 mutation, and we want to know, we want to avoid the bias, right? So we disabled the histology tool, and we generated the reports without using the histology tool. So then we encoded these reports based on a sentence transformer called GTE-based English version 1.5 with a context length of 8,000 tokens. And then we evaluated this MOA report embeddings for IDH1 mutation prediction. And the complete agent evaluation, we modeled this complete agent evaluation with a concatenation of the MOA reports without histology and the histology embeddings. So as you can see here on the figure, we did the concatenation. So the Titon slide embeddings were concatenated with the sentence transformer embeddings generated from the MOA reports without histology, and then they were fed to the 4-layer MLP, which is the same one that we used before, just here, because this is like an ablation study. Yeah, that's it for this slide. So these are the results that we got. So as you can see here in the table, we have the clinical text, the clinical variables that we want hot encoded. So these are clinical baselines. And then the MOA without histology, the histology tool concatenated with the clinical variables that are one hot encoded. And finally, the MOA with histology, which is the Titon plus the sentence transformer features. So what we found is that, first, the MOA without histology outperformed both clinical baselines. The histology tool was the strongest standalone component, and adding clinical variables to histology features gave only a small marginal improvement. And that the MOA with histology achieved the best overall performance. So we can say that the complete agent integrates external biomedical knowledge, right, with the histological representations, and this improves the IDH1 mutation prediction. So the conclusion is that the MOA reasoning grounded in PubMed, Google search, OncoKB, and also the dataset that we constructed, right, the Meditron dataset, captures mutation-relevant information beyond the structured clinical data, and that when we integrate the MOA reasoning with the histology tool, it further improves the performance through complementary morphological information. And a very important point is that the MOA, so our agent, it handles very easily the missing inputs. So even if, like in the real-world clinical use, the patients don't have all the data modalities available. So here, the agent, based on the data that we give him, he selects the tools to use. So even if, for example, a patient doesn't have the genomic data, it doesn't call the OncoKB. So yeah, this is an important point. So that's it for the ongoing work. We are now extending this work. And now we are using an open-weight local LLM so that it enables the reproducible deployments, but also respects the data privacy, because a local LLM doesn't remember the patient's data. And also we are now extending this MOA to support data modalities different than the ones that we used. So now we are integrating radiology and pathology reports, and also integrating another cohort, which is the glioblastoma multiform cohort. So thank you for your attention.
Bravo, Sababu. Thank you very much in the time, and sorry for this surprising issue. So yes, she's in time. She's in. Let me introduce in a bright mode the next guest is Heather Couture. She's founder of Owner Pixel Science Labs and a PhD writer, and she was not able to be with us, but she will present now. I don't know if you can launch the Zoom link, please.
Okay, are you able to hear me?
Yes, you hear me? Do you hear? It's okay?
Can you see
Yeah.
my slides?
Yes, it's okay. Go. The floor is yours. Thanks.
Okay, we're good to go. Well, thanks for the introduction and for the opportunity to speak. I'm sorry that I couldn't be with you in Morocco today. But my name is Heather Couture, and and these embeddings can be aggregated together, typically using some form of multiple instance learning, in order to predict the final class of the piece of tissue. So the scenario I talked about there uses a tile-based foundation model. Even though we're processing whole slide images, the foundation model itself operates on individual tiles. In most cases, these models are trained on images alone, so patches that have been drawn from whole slide images. So that's the single modality tile level model in this grid here. But if we move a bit over to the right, foundation models can also be trained on images with text or other data. So if we have aligned image patches with text descriptions, that's also a way to train a foundation model. Or if we move from the tile level up to the whole slide, even if we have a model that represents individual tiles, we can also train a foundation model based on those representations at the tile level, so at the slide level. So that there are now also slide level foundation that focus on a global representation to capture the spatial context of the tissue section. And then slide level models could also be trained in a multimodal fashion. So it could be images and text, or it could be histology images aligned with radiology, genomics, transcriptomics, or health records, or any other associated data. Today, we have quite a diverse set of foundation models. This plot here is focused on the tile-based foundation models and comes from a new website called Histobor that was put up by the Wave spinoff, by the Ocken spinoff called Wave. So this plots some of these foundation models according to how they perform on benchmarks. So given that there's so many foundation models for pathology today, how do we choose between them? And what do we need to watch out for in using them? The foundation models that you select and the way you use them should focus on 3 pillars to create a solution that is trustworthy, responsible, and actionable. So I'm going to talk about each of these pillars individually. Let's start with trustworthy. What I really mean here is robustness and reliability. I want to focus on distribution shifts and batch effects and make sure that models can handle these. Distribution shift occurs when the statistical distribution of data changes between the training and inference stages of a machine learning model. This phenomenon violates a fundamental assumption in machine learning that the training data and test data are drawn from the same distribution. The most widely known and frequently addressed cause of distribution shift is scanner variability. Each scanner produces a different color profile for the hematoxylin and eosin stains, but that's not the only source of variation. Pathology labs independently determine tissue section thickness, typically ranging from 2 to 5 microns, but additional variability arises from equipment maintenance, calibration, and technician skill. As section thickness increases, the tissue gets darker and there's more blurring. Thicker sections also have less defined nuclear and structure boundaries. And there are also artifacts caused by the slide preparation and image acquisition process. Some examples are out of focus regions, fading, tissue folds, foreign objects, and bubbles. The prevalence of these artifacts varies with the data set. So we've looked at scanner, tissue thickness, and artifacts. These are some of the tissue preparation factors that may lead to slide images from different labs having a different appearance. Next, let's look at how foundation models handle batch effects. The authors of this paper experimented with 9 different foundation models on 2 different data sets with and without stain normalization. They used the tile embeddings to try to predict the site that a sample came from. All models achieved 75 to 97% accuracy, with more recent models performing higher. Stain normalization lowered the accuracy slightly, but only slightly. This means that all foundation models encode site-specific features that a model could use for shortcut learning instead of focusing on biological features for solving a task. And stain normalization alone does not resolve this problem. So in further work by the same authors, they came up with a benchmark to assess robustness. They gathered data balanced across 3 different biological classes and 3 different centers, and evaluated 20 different foundation models on this data. They developed a measure called the robustness index. So if you think about the embedding that a foundation model creates in high-dimensional space, this might be more than 1,000 dimensions. If you reduce it down just to 2 dimensions, just for visualization purposes, you get a plot something like that on the left here. So the embedding for each image patch in a robust model, you wanted most of its nearest neighbors to represent the same biological class, regardless of the center that patch came from. So they formed the robustness index using a ratio of counting for these embeddings, the number of the nearest neighbors that belong to the same biological class, but the other confounding class, the confounding class being the center in this case, and nearest neighbors that have the other biological class but the same confounding class. So the scales from 0 to 1, with a larger robustness index of close to 1 being the best result. In plotting the results in this graph, we've got the robustness index on the horizontal axis and the classification accuracy for the biological task on the vertical axis. And you can see that different models perform differently in these two performance measures. So what makes a model more robust? So in this plot here, from the same paper, I've rearranged the axes a bit. On the vertical axis, we now have the robustness index. On the horizontal, we have the number of whole slide images that the model was trained on, so a measure of the size of the data set. You can see that for many of these models, the larger the training set, the more robust the model turned out to be. But these larger data sets could also have greater diversity, so it might not necessarily be at the size of the training set. It could be about its diversity and whether it captures some of the rare appearances in tissue. The other thing to note from this plot is most of the foundation models are represented with the blue points. 3 of them are yellow points, and these ones were trained not on cell images only, but images plus text, so with a multimodal objective. And these 3 models, although they were trained on smaller sets, all 3 of them achieved a relatively high robustness index. So the multimodal objective might be another factor here. We don't yet have a definitive answer on what makes a model more robust. We have some theories, but they still require more exploration. So key things to remember are to be aware of technical variations. Some foundation models are more robust than others, and all are susceptible to batch effects, at least to some degree. Moving on to the next piece. We want our models to be responsible. So in this is what I'm really referring to is fairness and transparency. This table is drawn again from the Histoboard website and shows the ranking of some of the foundation models across the numerous benchmarks data sets that are now available. You can see from this that no single model outperforms all the others consistently, although some models do perform better than others on these benchmarks. And if we dive into one specific benchmark, PathBench, this one consists of sets of tasks in 3 different categories: histological diagnosis, molecular diagnosis, and survival prognosis. So if we look within each of these categories, the top foundation model is different and the rankings are different. And if we were to go a step deeper into a specific task in one of these groups, you would probably find a different winner and a different ranking in the order of foundation models. So what really matters is how the model performs on your data. But it's also important to look beyond the global metrics on a data set. Here's an example from a paper that predicts biomarkers and mutation status. And in this case, they calculated their overall metric, AUC, for each of these tasks, but they also calculated it within different stratifications, so within individual biomarkers or mutations. And you can see that for some of these, the model performs fairly consistently across the different subgroups, and for others, performance drops off in some of them. And if we take it a step further, again, from the same paper, in this case, instead of stratifying by biomarker and mutation, they're stratifying by grade. So some of these models perform consistently across grade and some don't. And in particular, they looked at the correlation between the prevalence of the different grades with and how it correlated with the biomarker they were trying to predict. So if we look in particular at HER2, grade is highly correlated with HER2. And so is the model actually capturing the biological features of HER2, or is it capturing more of the features of grade? This is something we need to be very, very careful about these models and why it's important to stratify performance across different groups to check for confounders. So that was mostly about fairness and bias. What about the transparency piece? How are these models trained and on what type of data? So this table has just a selection of some of the more recent foundation models, by no means all of them. You can see that they're trained on different sizes of data sets. And some of these papers that talk about how the foundation model was trained give a fair bit of detail about the data set, and others, many of these columns that I've put in here, how many sites were they trained on, not just how many slides, but how many cases, what stains were used. For some of these foundation models, we know roughly what they were trained on, and others, there are a lot of gaps. When you don't know what data model was trained on, it's more difficult to infer its reliability on it. So what can we draw from this? Benchmarking helps, but what really matters is performance in your data. You need to validate thoroughly with stratified metrics and check for confounders. And ask questions about foundation model training data if you're going to use particularly some of the proprietary foundation models. And the last section is on actionability. So you want to ensure that your AI solution creates value and provides a sustainable solution. The embeddings that these foundation models compute aren't diagnosis directly. We take the image patch, we apply the foundation model, we compute a high dimensional vector. Then what? How do we use them? Well, foundation models can be used for many different downstream tasks, right? Tissue segmentation, cancer classification, precision diagnosis, outcome prediction, biomarker discovery, treatment response, report writing, decision support, and likely other tasks that aren't mentioned here or that we haven't quite thought of yet. Each of these use cases requires a different UI, a different validation, and different regulatory approval, even if they use the same foundation model backbone. Foundation models enable you to create a model for a new task quicker with less labeled data. But this is only helpful if the rest of the system is carefully considered. What value does the AI solution provide? Is it in maximizing the effectiveness of laboratory tests? Is it about optimizing resources? Is it improving patients' outcome? Is it minimizing unnecessary costs? Or is there's some other measurable value? That this value needs to be clearly defined. So that's kind of the value piece. The sustainability piece is more related to model size. Many of these foundation models have become very, very large. The plot on the left, you can see the size in terms of the number of parameters in the model. So some of them have more than 1 billion parameters at this point. And the more parameters the model has, likely the more compute it requires. So the plot on the right is measured in flops, so floating point operations. So the more operations that a model requires to compute, the more compute power it's going to require, or the longer it's going to take to run. So with models getting larger and larger, this is especially a concern. If we convert the floating point operations required into the throughput of slides for a particular type of hardware, whether it's a server class GPU or a device that's more likely to be used on the edge. These whole slide images have tens or hundreds of thousands of tiles, and so the hardware and the throughput need to be considered here. And keep in mind that whatever model you select for production use will be involved in processing every whole slide image your system receives. And that processing uses electricity, uses emissions that will vary depending on the power grid. So the key thing is to remember your whatever you develop using foundation models, your solution with AI needs to be integrated into the clinical workflow. It needs to have a clear value proposition for it to be used. And you need to increasingly be mindful of compute costs as these models are getting larger and larger and being trained on much larger data sets. And just a few final closing thoughts. Foundation models are the key components of future digital pathology tools. They must be built on the pillars of trust, responsibility, and accountability. Using more powerful and robust foundation models doesn't change the need for validation. Validation needs to be very thorough and perhaps increasingly so as these models get more and more complex. So whether you're developing foundation models, building products with them, or are simply an end user, I encourage you to ask questions about the models, how they were trained, how they were validated, and other questions. If you'd like to stay up to date in computer vision, especially for application in people and planetary health, you can sign up for my computer vision newsletter. The link and the QR code are at the top here. You can also reach me directly by email or on LinkedIn. And I would be happy to answer any questions if we're able to get through it virtually here.
Very much for your excellent talk and for sharing your experience with us. And we move now to the next presentation, to the symposium.
So we have to achieve with the next presentation, the symposium, about the evolving HER2 classification and reporting standard, but I think by the AstraZeneca team.
Thank you. Good afternoon, everyone. My name is Mehdi Al-Qarqouri. I am a pathologist, actually, and I am head of pathology in the Ibn Rushd University Hospital of Casablanca. I am not part of AstraZeneca team. But today I will talk about the evolving HER2 landscape, classification and reporting standards. I know that I am standing between you and your lunch, so I'll try to be as efficient as possible. So first of all, let's start with the basics of HER2. Of course, you know of that. Just a reminder, HER2 is a transmembrane tyrosine kinase receptor that is a member of the EGFR family. It is expressed actually in normal tissues throughout the body. And in healthy cells, HER2 helps to achieve normal cell growth and division. And once HER2 is linked with its ligand, we will have heterodimerization, thus activating the tyrosine kinase, and then a cascade of reactions will happen. I'm going fast. And those pathways that are activated initiate and control a large range of cellular processes, among them tumor cell cycle progression, proliferation, survival, invasion, and metastasis. And of course, the alterations that can happen there's a wide also range of alterations that we can have. Gene mutation, gene amplification, which is the more relevant for breast cancer that I will talk about in a few seconds. And gene amplification may result in HER2 overexpression. And just to close the basics section, HER2 gene alterations have been found in many other tumors in the human body. So HER2 and breast cancer. HER2 is one of the oldest biomarkers that have been discovered. It was discovered in the 80s, last century. And since it has been discovered, targeted therapy, according targeted therapy has been developed and approved for both metastatic and early breast cancer. You know that. Dramatically improving the survival of patients with breast cancer, and HER2 testing became mandatory for treatment selection through the assays that we have, immunohistochemistry and in situ hybridation. But in this testing, we can broadly distinguish between two periods. The first one, from the beginning until 2018, it's the period of standardization of testing. It's when we had all those publications about how to score and all the guidelines for scoring HER2, ASCO, CAP, but many other guidelines from all across the world. And the main goal was to improve accuracy and reproducibility. And in that period, we were very keen on establishing a very binary model. The tumors were either HER2 positive or HER2 negative. But turned out that this very rigid way of seeing things, this binary model, is not so accurate, and evidence showed that, or helped us to recognize that HER2 expression is more of a continuum, actually, not a binary. And recent clinical trials show that even when we have low expression of HER2, the patient can still benefit from targeted therapy, thus opening new therapeutic options for almost 50 to 60% of what we used to label as HER2 negative patients that now became targetable. So this timeline just show the evolution of the different guidelines up to the latest update of the ASCO-CAP HER2 guidelines that was released in 2023. And since we're in Morocco, I also mentioned the national guidelines that I have to say need to be updated. So we used in the 2018 ASCO-CAP guidelines, we used, as I mentioned, it's from the first period, we used to distinguish between HER2 positive. HER2 positive were all the cases scored 3+ complete membrane staining in more than 10% of the tumoral cells, and also those that would have been scored 2+, weak to moderate complete staining in more than 10% of tumoral cells, but with a positive FISH or any other technique. And the rest, all the rest would be labeled as HER2 negative. The 0, no staining at all, faint staining 1+, and complete faint membrane staining in less than 10% of the tumor cells, and all those 2+ cases that were found negative by in situ hybridation. And according to, as I mentioned, according to that binary system of classification that we used to adopt at that time, the most of the patients with breast cancer would be denied targeted therapy because they would have been classified as HER2 negative. Then all the scientific evidence piled up from all the trials, and we can specifically talk about the Destiny trials 04 and 06 that showed us that even patients with low expression of HER2 can benefit of targeted therapy. So now we are, as pathologists, required to not anymore use that binary system, but to further classify or more precisely classify the tumor to distinguish those who are null, zero, no staining at all, and those with staining, and I will show that in a few seconds. And we, about 1 year ago, we had an updated CAP reporting template urging pathologists to be more precise, more specific in their reports. So now we are asked to score our breast cancer cases. The 3+ score is still a 3+ score. The 2+ is still the 2+, the weak to moderate, complete or incomplete staining in more than 10% of the tumor cells. But now we are also, we need to specify the 1+, which is the faint, weak, incomplete membrane staining in more than 10%. The 0, the null, the no staining at all, and in between 0 and 1+, this less than 10% tumor cell staining that is faint and incomplete that we now label as ultra-low staining. So, of course, this change of habits will bring its amount of challenges, of course. We know clinical guidelines advise that all patients with primary and metastatic breast cancer undergo HER2 testing. And how do we test for HER2? We have two main assays: immunohistochemistry, of course, looking for the protein overexpression, and in situ hybridation, looking for the gene amplification, since it's gene amplification that we are looking for in breast cancer. So there are a lot of factors that will can interfere and can influence the result, and we saw how it is important to give accurate results, because the treatment depends on the pathology report. So of course depend on the sample that we are examining, core needle excision biopsy, fresh versus archival sample, tissue handling, of course. The pre-analytical variables are of paramount importance here. The sample preparation, the time between excision and fixation, called ischemic time. If we're testing on bones, sometimes we have metastatic bones, and that's all we have to perform the HER2 testing. The fixative that we are using, type of assays that we are using. I mean, it's all the usual suspects, but we have to make sure that our procedures and the way we handle the specimens before testing is flawless, because the result of the report and the prognosis of women with breast cancer is on the line. Those commercial IVDs or laboratory developed tests, quality control, of course, and we know we have also to use the clones, and sometimes we have kits with all the reagents that are ready to use, that are maybe more suitable for the less experienced and labs with low burden of with breast cancer. In situ hybridation interpretation is also important. Maybe I can skip to that. Also, it is important to keep in mind that sometimes the HER2 status can change due to the effect of treatment between primary and metastatic tumors. So we see that about 10% of HER2 negative cases can switch to positive cases. And also in the other way around is possible. So it is also important to test the metastasis, even if we have tested the primary tumor. And also, of course, the interpretation of sample is very important. As I mentioned earlier, it is now required that we don't give only answers as positive or negative, but to fully score the samples that we have to examine, and especially to distinguish what we used to call negative and to break it down into 0, 1 HER2 ultra low, HER2 low, 1 plus, 2 plus, and 3 plus. Maybe I will, of course, I'm not going to go into details because this is not the time nor the place for that, but now distinguishing between low and ultra low can be very challenging, and there, of course, ways, pathologists have their ways to help. They have tools to help them to make the difference between all those categories. And also it is required that in our reports we clearly mention the score. I put the template of the one we used in my department. It's in French, of course, because French is our working language, but there are a lot of templates in every language that are available. And of course, since we are in a Congress of Digital Pathology, I cannot finish without touching upon the tools that are already helping the pathologists to more accurately score their specimens. Digital pathology, of course, to support the pathologist and support the harmonization across pathologists, but also the AI that is enhancing diagnostic accuracy, and there are a number of tools that are already here, and I believe we had a workshop yesterday about one of the tools. And also very proud that Morocco was part of this multi-centric study. It's the team from Rabat, from the National Oncology Institute, that also participated in this assessment study that was multi-centric, and that showed that the use of AI can reduce reading time per case, which is something very valuable, especially in departments overburdened, and also can improve pathologist concordance and accuracy, especially in those challenging categories that are HER2 null, ultra low, and low ranges, which is something that is very appreciated by pathologists. So at the end, we can say that HER2 landscape in breast cancer is no longer binary, but exists along a continuous spectrum of expression. It is important to acknowledge that, and and that our reports reflect that. So the recognition of the HER2 low and HER2 ultra low categories represents a major paradigm shift. Accurate distinction between 0, 1 plus, and 2 plus is clinically critical more than ever, requiring rigorous interpretation and standardization. Pathologists, as usual, play a central role in identifying those subtle expression levels and ensuring high-quality, reproducible reporting, and ongoing advances, including Of course, digital pathology and AI will certainly help us improve reproducibility and diagnostic precision. And thank you very much.
Thank you very much, Professor Karkouri, for your insightful presentation, reminding us with the HER2 classification and reporting. And also I would like to thank all of our speakers for their excellent contributions and for this informative session. Also, special thanks to our attendees for their engagement and patience. And we are all invited now to a lunch break.
Yes,
yeah. Yes, you have 1 hour, and you can continue to ask our generous experts if you have any questions during this session. This break lunch. Thank you very much.
J'espère que ça...
and all the team. So I'm Professor Basma Khannousi. I'm the head of Department of Molecular Pathology and Digital Pathology because we changed the name of our lab last year. And I'm from Rabat. So my lecture will be in French, but my slides are in English. But if you are any questions, I'm here at the end of my presentation to take all your questions. So let's move to French. So je vais parler aujourd'hui de notre expérience en termes d'intelligence artificielle à l'Institut national d'oncologie de Rabat. Donc, l'Institut national d'oncologie de Rabat, c'est le premier centre d'oncologie, the first oncologist center in Morocco. It will be built in 1985, and I'm there with the medical oncologist, surgeon, etc. OK, donc, alors pour présenter le service, donc, nous, on fait partie du centre hospitalo-universitaire de Rabat. Notre laboratoire, on l'appelait auparavant le laboratoire d'anatomie pathologique, mais grâce au développement, bien sûr, technologique, on a changé le nom du laboratoire en laboratoire de pathologie moléculaire et digitale. Et vous voyez, on a encore nos enfants aussi qui viennent au laboratoire pour regarder au microscope, mais aussi pour découvrir la pathologie digitale. Donc, on n'est pas seulement dans la pratique, mais aussi on est un laboratoire de référence en termes de recherche, que ce soit en recherche translationnelle ou bien en recherche appliquée à la clinique médicale. Alors, pourquoi adopter la pathologie digitale au Maroc? Et cette slide, je remercie le professeur Hajar Gouri qui est avec nous et qui était la première à nous initier à cette pathologie digitale à l'Institut national d'oncologie. Donc, on sait très bien qu'on a peu de pathologistes, d'ailleurs, à travers le Maroc, mais aussi à travers le monde, on a peu de pathologistes. En termes d'un centre de cancérologie, on a une augmentation de nombre de cas de cancer. Et quand on voit au Maroc, il y a le cancer du sein, qui est le premier cancer du Maroc, et aussi le cancer du poumon. Et on sait très bien l'intérêt de cette digitalisation et de l'intelligence artificielle en termes de ce cancer du sein. Et nous aussi, nous sommes focalisés sur ce cancer du sein. Et bien sûr, ça on l'a dit depuis hier, on a besoin d'un diagnostic précis et on a aussi besoin de l'aide au diagnostic par l'intelligence artificielle. Alors finalement, pourquoi digitaliser? Moi je pense qu'il faut répondre à 3 questions. C'est gagner du temps, premièrement. Il y a deuxièmement une volonté des décideurs justement de digitaliser le secteur, notamment le secteur d'Anapat. Et bien sûr, tout cela est conditionné, et ça aussi on l'a vu depuis hier, par une qualité de la phase préanalytique particulière. Alors, on va parler de l'intelligence artificielle, ça c'est des choses que je vous rappelle rien. Donc la digital pathologie, c'est bien sûr, c'est un moyen d'arriver à l'intelligence artificielle, et on sait très bien qu'on ne peut pas faire de l'intelligence artificielle si on n'a pas digitalisé en amont, mais on connaît aussi les freins à cette digitalisation. Alors, dans notre expérience, je commencerai par la première des choses, c'est quand on a pensé à la pathologie digitale et éventuellement de l'IA, on s'est retrouvé qu'on est confronté avec des personnes qu'on ne connaît pas. Donc, c'est 2 mondes qui sont différents. Premièrement, le pathologiste qui nous sommes, on cherche à gagner du temps, on cherche à faire des biomarqueurs de bonne qualité, on cherche à établir des scores, à chercher des facteurs pronostiques, même sur un diagnostic HE, et bien sûr, on veut intégrer l'IA parce qu'elle semble qu'elle va nous aider. Alors, on est confronté à des personnes avec qui on n'a jamais travaillé jusqu'au-là, c'est les data scientists. Et ces data scientists comprennent des choses et ne comprennent pas d'autres. Donc on a besoin de communiquer parce que pour eux, c'est des lames scannées, c'est des couleurs, c'est des grossissements différents. Et bien sûr, nous, on leur demande de nous préparer des algorithmes d'IA et ils sont conditionnés par la phase pré-analytique et aussi par l'interprétabilité des résultats. Donc, on était confrontés dès le départ à deux modes de personnes, les médecins pathologistes qu'on est et les data scientists. Donc, pour la première fois, on travaille avec eux. Donc, on a finalement compris que la pathologie digitale ou bien de la pathologie de l'IA appliquée à la pathologie digitale nécessite une approche et je remercie le laboratoire Leica pour cette slide. Alors, cette approche, elle prend d'un côté le rôle de l'IT, workflow, et de l'autre côté, elle prend le médecin pathologiste qui veut digitaliser. Mais entre les deux, on a un workflow qui doit être bien tracé, bien ordonné et coordonné par des instruments, mais aussi par une maîtrise de la phase pré-analytique, comme on va le voir. Donc, dans ce workflow, donc, on a besoin de scanners de l'âme, on a besoin d'un stockage, et dans ce cas, la question va se poser, est-ce qu'on va tout digitaliser, partiellement digitaliser les zones d'intérêt ou pas? Et bien sûr, si on veut utiliser le partage, on veut utiliser du lien, on a besoin de software. Et donc, tout ça, c'est une composante de cette digitalisation. Pour ne pas prendre que le scanner ou le software, donc il faut penser à ces trois composantes. Donc, ça, c'est un modèle d'intégration qu'on a adopté dans notre laboratoire. Et donc, quand on veut utiliser du lien, on va se poser des questions. Quand est-ce qu'on va utiliser l'IA? Mais avant tout ça, on doit déjà penser à la digitalisation. Et quand on pense à la digitalisation, on doit penser au workflow, c'est-à-dire un système de digitalisation qui est adapté à notre système de gestion laboratoire, donc avec un système de gestion qui doit être parfaitement coordonné avec notre système de gestion laboratoire. Donc ensuite, on peut intégrer de l'IA dans le workflow. Vous le voyez ici, les avancées majeures ont été sur la biopsie de la prostate, mais aussi sur les cancers du sein. Et ensuite, ces algorithmes vont être de l'aide au diagnostic. On aura le retour de l'IA qu'on doit intégrer justement dans notre système de gestion laboratoire pour finalement donner un résultat. Donc, c'est une organisation qui vise à intégrer l'intelligence artificielle dans notre workflow. Alors, quand est-ce qu'on va utiliser ces algorithmes d'IA? On peut les utiliser en temps réel avec un choix, comme le cancer du sein, le cancer de prostate, comme ça peut être utilisé en second reading, c'est-à-dire pour le contrôle qualité, même pour un avis d'expert. Alors, maintenant, quel algorithme on va utiliser? Donc, on va prendre, bien sûr, la digitalisation. Il faut qu'elle réponde très bien à une phase pré-analytique. Mais quel est l'algorithme qu'on va utiliser? Donc, si on prend notre contexte, je pense le contexte marocain ou africain, on est mouvementé par des conditions. Déjà, on doit sélectionner la pathologie, on doit sélectionner l'algorithme, et dans ce cas, l'algorithme, est-ce que c'est un algorithme qui est validé? Est-ce que c'est un algorithme qui est fait maison? Est-ce qu'on a pu le valider par des essais cliniques? Ensuite, est-ce qu'on a fait des essais de comparaison des algorithmes quand on les choisit? Parce que finalement, c'est des algorithmes qui ont été développés sur des datasets peut-être que nous, on ne connaît pas, et il faut les adapter à notre contexte. domaine de la pathologie, comme on va le voir à la fin. Alors, donc, cette slide aussi, je l'ai empruntée de professeur Hajar Agouri, qui est avec nous et qui me modère, et c'est un plaisir pour moi aujourd'hui. Alors, nous, on était en période de Covid. On s'est dit, voilà, on n'a pas de scanner de l'âme. On a entendu parler de la digitale et on n'a pas de scanner, qu'est-ce qu'on peut en faire? On est en confinement, on s'est dit, on va prendre des lames qu'on va prendre en photo sur un microscope à photo, sans scanner de l'âme, et on va avoir un dataset, private dataset, un dataset privé marocain, purement de l'Institut national d'oncologie initialement, sur le diagnostic du cancer du sein. Donc l'objectif pour nous était d'entraîner 2 algorithmes sur des biopsies du sein et sur des pièces opératoires, et on a classé, comme toutes les études sur le cancer du sein, en bénin, carcinome in situ et malin. Alors, bien sûr, on a pu faire une validation avec l'équipe de l'hôpital militaire. Et sur ce travail, je remercie vraiment particulièrement mon ami Hicham Lattar et Data Pathologie qui ont été d'un grand soutien pour nous durant ce projet. Alors, ça a fait l'objet de plusieurs publications. Malheureusement, on n'a pas continué à développer notre algorithme et on était sur des prédictions qui étaient très intéressantes. On était jusqu'à 92% de prédictions en termes de diagnostic de cancer du sein, que ce soit sur les biopsies ou sur les pièces opératoires. Donc, à partir de cette année-là, c'est-à-dire à partir de l'année 2022, on a compris que ce n'est pas aussi facile. Donc, il y a un écosystème à la digitalisation en anapath. Et cet écosystème, il n'est pas seulement conditionné d'avoir des machines, d'avoir des softwares, mais il est conditionné par toutes les étapes qui vont se faire en amont, notamment la phase pré-analytique. Donc, ça, c'est des choses sur lesquelles on a travaillé de 2023 à 2025, notamment en termes d'organisation du workflow. Donc, on a essayé d'intégrer la digitalisation dans notre workflow, d'améliorer notre phase pré-analytique. Et cette année, on a essayé quand même de valider un algorithme d'IA en termes d'HER2 sur notre plateforme. Alors, qu'est-ce qu'on a fait? Et aussi, je remercie les laboratoires Leica de m'avoir emprunté ces slides qui sont finalement des machines avec lesquelles on travaille. Donc, on a essayé d'améliorer notre pré-analytique en référant à des machines, bien sûr, pour la déshydratation de haut niveau de qualité, la coloration avec une calibration du staining, de la coloration, bien sûr. Toutes les techniques spécialisées se font en automatisé pour un bon marquage. Et on a aussi acquis un scanner, le GT450, pour pouvoir numériser nos lames. Donc, au-delà, on a essayé aussi, et depuis l'année dernière, de commencer la démarche qualité pour la ISO 15189, qui est concomitante à l'accréditation canadienne dans l'Institut est entièrement inscrit. Alors, donc, qu'est-ce que nous avons fait en termes de digitalisation et d'IA jusqu'au jour d'aujourd'hui? Donc, on a amélioré le pré-analytique, on a intégré l'IA dans notre workflow et on a essayé de commencer à digitaliser avec ces nouvelles normes. Donc, notamment, on a pris comme slogan « Partager à tout moment et partout ». Donc, on a un accès sur nos smartphones, on a un accès sur nos ordinateurs et on peut réaliser des examens à distance, notamment des examens d'extemporanée. On a une très belle expérience sur les frozen sections à distance dans notre laboratoire. Donc, dans notre pratique quotidienne, on ne digitalise pas tout, on digitalise presque quotidiennement des lames d'immunohistochimie, immunohistochemistry staining, et on digitalise les frozen sections. Donc ça, c'est notre pratique actuelle en termes de pathologie digitale grâce au scanner Leica. Et bien sûr, ce scanner Leica ne fonctionne pas tout seul, Donc, il fonctionne avec un software, le Aperio e-Slide Manager, qui nous permet bien sûr de centraliser et de regarder ensemble des lames. Ça nous permet aussi d'annoter, d'archiver et bien sûr de discuter en temps réel entre nous en ce qui concerne cette façon nouvelle de travailler. Donc, ce qu'on a fait aussi, c'est qu'on a commencé par un seul centre, c'est-à-dire on a connecté only single sites, et ensuite on a essayé de connecter un deuxième site et un troisième site, et on est quand même satisfait en termes de communication entre les 2 ou les 3 sites. Alors, bon, qu'est-ce qu'on digitalise? Donc, on a des images très jolies d'examen extemporané, frozen sections pour des cancers de la thyroïde. On digitalise, comme j'ai dit, donc des lames d'immunohistochimie d'une façon assez quotidienne dans notre laboratoire. Alors, actuellement, et ça, je n'ai aucune expérience, ça a été représenté hier par le symposium Leica en ce qui concerne le Allo Clinical AI Solutions. C'est un nouveau software développé justement sur ces scanners Leica pour essayer d'intégrer de l'intelligence artificielle dans le workflow, notamment lorsqu'on adopte un scanner de ce genre-là. Alors nous, qu'est-ce qu'on a fait? On a adopté un autre algorithme, notamment dans l'expérience HER2, et on connaît actuellement l'évolution HER2 low, ultra low. On a eu une très belle présentation tout à l'heure de midi sur l'intérêt de faire cette dichotomie qui n'a plus de valeur en positive, négative, mais surtout il faut donner les scores low et ultra low. Donc c'est un projet qui a été initié par les laboratoires AstraZeneca, donc je remercie pour leur support. Et c'est une étude internationale qui a inclus 12 pays. Et comme pays africain, le Maroc était le seul pays représenté, alors avec un autre pays arabe qui est la Jordanie. Alors, c'est un projet qu'on a trouvé très intéressant parce que malgré le fait que l'algorithme, il est en CEIVD, ça nous a permis, cette étude, de le valider sur notre workflow avec notre scanner de lame. Donc, on a participé par 150 cas d'HER2 des 6 derniers mois avant cette étude-là. Le total des lames était aux alentours de 1200 lames, tous pays confondus. Alors, ce qu'on a demandé au laboratoire d'Anapat de l'INO, c'est de prendre 2 pathologistes. Alors, ces 2 pathologistes déjà expérimentés en pathologie mammaire, on leur a demandé dans un premier temps de regarder sur des lames digitalisées, donc déjà pour valider la lecture digitale. Ensuite, on leur a demandé d'être concordants et de trouver un consensus lorsqu'ils étaient discordants sur ces 150 cas. Et 14 jours après, on leur a demandé de faire la même chose, mais par l'algorithme d'intelligence artificielle. C'est un travail qui nous a pris pas beaucoup de temps, mais dont les résultats ont été présentés tout à l'heure, dont je vais revenir en détail. Alors, le design de l'étude était comme le suivant, à peu près 1200 lames digitalisées dans 12 pays différents. Donc, la question sur laquelle il fallait répondre, c'est est-ce que dans un laboratoire donné, le workflow mis en place va permettre de valider cet algorithme? C'était la première question sur laquelle on a répondu. La deuxième partie, c'est qu'il fallait répondre sur quel est l'intérêt justement de rajouter un algorithme pareil dans notre pratique. Donc, 2 experts en pathologie mammaire ont essayé de trouver le consensus avant justement de passer en intelligence artificielle. Donc voilà, donc on a utilisé dans cette étude notre scanner, donc notre plateforme, et les résultats, on va les voir. Alors ça, c'est des extraits d'images sur notre software Aperio e-Slide Manager, donc de la façon dont on fait la lecture digitales devant des scores. Ici, on a des scores 3+, des scores 2+. Et sur ces scores-là, on a essayé d'appliquer cet algorithme MindPeak. Alors, donc, une fois qu'on applique l'algorithme MindPeak, ça change un peu de mood, ça devient des codes couleurs. Et bien sûr, pour chaque code couleur, on aura des pourcentages. Et ces pourcentages vont nous permettre de donner un score. Là, vous avez par exemple des scores 3+, parce que le code couleur en marron, il est témoin du marquage fort et complet. Donc ça, c'est des détails techniques, je ne vais pas en revenir. Donc, la conclusion de cette étude, c'est qu'on a fait preuve du concept de practice changing. Finalement, l'intelligence artificielle permettra d'assister le pathologiste et aussi de changer sa façon de faire. Et donc, on est fiers de participer à cette validation en donnant les résultats suivants. Alors, on est sorti par 3 conclusions. Alors, la première conclusion, c'est que quand on utilise l'intelligence artificielle, on classe mieux la catégorie HER de low et ultra low du cancer du sein. Ça, c'était la première conclusion. La deuxième conclusion, c'est que la concordance et la variabilité interobservateur est les meilleure avec l'intelligence artificielle. On est passé de 64,3% à 80%. La troisième des choses, c'est quand même, on a donné la chance à des patientes qui n'étaient pas éligibles à un médicament qu'elles deviennent éligibles, et ça a été le cas dans 24% des cas. Donc, des résultats qui ont été véritablement concomitants dans les différents centres qui ont fait cette étude de validation. Donc, pour c'est-à-dire ne pas finir, alors c'est un travail qui a fait l'objet de présentations dans l'European Society of Medical Oncology also et l'European Society of Medical Oncology for Digital Oncology en novembre et en octobre 2025. Donc les conclusions générales, c'est finalement l'IA testée dans notre pratique avec notre workflow nous a permis d'améliorer le temps de réponse, nous a permis d'avoir une meilleure concordance et aussi elle nous a permis de donner la chance aux patientes pour qu'elles soient mieux traitées. Alors, néanmoins, on a eu cette expérience d'IA sur un algorithme déjà validé, mais qu'en est-il des algorithmes si on veut les valider ou bien les développer en interne? Il y a des challenges, des freins, notamment sur le pré-analytique. Donc ça, on le sait tous. Si on veut faire de l'IA, il faut des plateformes avec un pré-analytique qui est parfait. Et si on veut, bien sûr, valider des algorithmes, ça demande des validations de comparaison et des validations cliniques. Ensuite, l'IA, à mon sens, elle va être de l'aide à un pathologiste qui doit être déjà expérimenté. On ne peut pas se fier à l'IA à 100%. Elle ne va pas nous remplacer, mais elle va être d'une grande aide. La troisième des choses, c'est qu'on a besoin aussi d'avoir des recommandations nationales, des recommandations par pays en termes de validation et d'utilisation de l'IA. Et bien sûr, pratiquement pratique, on aura besoin de l'IA pour le diagnostic, pour la formation, pour le partage et bien sûr les guidelines nationales. Donc ça, il ne faut pas l'oublier. Donc voilà, donc moi je finirai par cette slide. Alors je vous invite tous au JTEX de la semaine prochaine où on aura la chance de présenter dans le stand du ministère de la Santé marocain, de Ministry of Health, on présentera notre expérience avec le scanner Leica et avec l'algorithme MindPeak. J'espère qu'on aura des visiteurs durant le stand. Donc, c'est un stand qui va être réservé à l'ANAPAT. C'est une première au Maroc pour le ministère de la Santé qui commence à s'intéresser à la pathologie digitale et de l'IA en ANAPAT. Donc, je vous invite tous à venir nous voir pour conclure en disant que c'est vrai qu'il y a de forts leviers pour évoluer, ça c'est certes, mais aussi dans l'intelligence artificielle appliquée au nanopath, il y a de forts challenges qu'il faut relever. Et ça ressemble un peu à l'équipe nationale du football. Et je vous remercie.
On a des questions? On peut faire des questions? Des questions pour...
So thank you, Professor Al-Khanousi, for your great talk, and thank you for your kind words. Surely I've learned many things by your side and side your team, and I think we'll do other things together with Professor here in Agadir, so with more collaborations. So I think if we have no question, we'll move to the first presentation of this session with Dr. Ekaterina. So about interoperability and the implementation of standardized structured report and pathology. It's about practice international approach. Thank you.
Hello, everyone. And I'm truly delighted to be for already the second time presenting at African Congress on Digital Pathology. And the fact that this Congress takes place and it's actually growing tells us that the digital pathology as well as structured data is the conversation, not just that is, we discuss that not only in Europe and in North America, but also worldwide. And the Africa also takes a big part in it. And yeah, that's just very important topic to address. So, and today I will talk about the interoperability and yeah, and why it is the missing piece if we're addressing the implementation of standardized structured reporting, especially if we consider using the templates, not at the local, but at the national or international scale. So, and before I start, some data that I will present today, they are not yet published and not peer-reviewed, so I would ask you to treat that as so. So the biggest problem in the interoperability is what I call the pathology data paradox. And so we have the pathologists worldwide, they produce the big reports, which are very, they have a lot of data, but unfortunately that is not computer readable. And with the colleagues, we, in 2024, we shared some insights that today pathologists are facing the challenge of translating a report with 1 million words into a reproducible and meaningful message, which is, although we have a lot of data in pathology, it's in most of the cases not computer readable. And for instance, in the in Belgium, we found out that although the 55% of the patients, only 55% received the biomarker data in their clinical narrative clinical notes, simply because that was not captured by the NLPs. And although there are about 90% of the NLP, which is being, let's say, structured with the with the help of the natural language processing, and that is actually quite reasonable results. But if we think at the how much data we lose at the scale of the cancer surveillance, that is. Yeah, that is inevitably big loss. And we also found out that about 31% of Belgian pathologists, they still report at level 1, which is narrative. And so here we have the situation where we have the reports and the data which are reached at the microscope but practically invisible at the registry. So to move on, what is standardized structured reporting? And there actually the big question is who do you ask? So if you ask the clinicians, and it would be the clinical documentation method, producing complete, consistent and accurate pathology reports using the standardized structure. So essentially these are the, let's say that improves the quality of the pathology reports if we talk about standardized, let's say, templates at the hospital. But interoperability definition, that's what I want to focus more during this presentation, is how pathology data is collected, transmitted, stored, retrieved, and shared between the clinical information system for primary and secondary use. And here, this key distinction here is that structured is not equal, like it's not standardized. So because the local templates can be well structured, but if it's just at one hospital and there is no terminology binding, these templates are essentially not interoperable. So, and on the left, on the right side, you would also see the reporting levels, which were created by Ellis and Shrigley, and we updated that to level 7, which is full semantic interoperability. So I really hope that a lot of people seen a little bit other way of this scheme. So we started at level 1, which is narrative with no defined content. Then we move on to level 2, which is standardized content. It's still narrative, but has some like drop-down menu, for instance. Then we have a synoptic format with a checklist and synoptic layout. Then level 4 is electronic tools. Here we have, let's say, drop-down menus, and from level 5, that is already where we have the discrete data, which is already standardized structured data set with the use of ICCR templates and CAP protocol. And then level 6, that is already terminology binding with ICDO, SNOMED, CT, and LOINC, and moving to full semantic interoperability, which is target, and that is SNOMED CT with FHIR, with AI-ready registries, and HDIS-ready tools. And so the big question is why in most of the situation SSR implementation fail, and that is here it's not the content problem because we have the ICCR templates and or the CAP protocols available, and for instance ICCR templates are free to use, and it is also not an attitude problem because a lot of pathologists have a favorable attitude toward implementation of SSR, and we proved that in our previous study in Belgium that about 83% of pathologists have favorable attitude. But it is a system level fail where governance, semantic, and coordination sometimes is a problem. So if we have no governance body, the templates exist, but no one maintains, funds, or mandates them. And then we have a temple drift, which results in obsolescence and then abandonment. We also have no semantic agreement, and for instance, 2 labs, they have same tumor, so the no common value sets, which, so also no coded terminology and no SNOMED CT binding, and the data is incompatible at the first, as soon as like it leaves one laboratory. What we also saw in Ireland, that LIS, and that was the very big showcase there, that LIS sometimes cannot or it just rejects to integrate. And forms designed and validated, and LIS just doesn't receive the structured output. And content readiness without application integration also results in failure. And also, no exchange standards, so structured data captured locally but cannot reach registry or MDT, as well as AI pipeline, so there is no fire care set and no automated flow. And here it's very important to talk about the NICTIS 6-layer model. NICTIS is a Dutch system for health national policy. Helping me right now. No, it's it's talking to the audience. So what they essentially did, they revised the e-interoperability framework, and we applied this analytical framework for our interviews. And what I want to you to see here is not that there are, it's not the phases that you have to take just one. It's not also a checklist that you have to go like, yeah, I did that, but it's 6 parallel prerequisites. And in fact, the failure in any of one of the layers is sufficient to prevent the durable implementation. So just absent of one single layer can stop everything. And here, so here are the 6 layers. So these are the laws and regulations. That's essentially mandate, MDR for European Union or FDA. It's also GDPR, and also for the European Union, it's EHDS. Then it's also policy and governance, all the decision makers and administration, so essentially custodian body, funding, and also liability and trust. Care process here is, in fact, how standardized structured reporting affects just the daily workflow of pathologists, but also patients and, in fact, all the healthcare professionals. And information and semantics, so pathologists, informaticians, so here is the minimal data set, SNO and CT, ICCR, CAP, as well as, here is also important to mention that is the reverse pipeline, where we have to understand what registry needs before building in fact, the whole process. And the layer 5 is application and software, it's IT stuff, the vendors, and here is about the LS integration, FHIR, questionnaire portability, template, and lifecycle, and as well as also defined AI and digital pathology connection. And the last one is IT infrastructure, so FHIR, care set, registry pipeline, federated architecture, and security. So this is, in fact, the unpublished data that is still not peer-reviewed. So you're kind of having the first glance at. So what we did, for the part 2 of a study we had in Belgium, we had interviews with 31 stakeholders, and we defined also the stakeholder type, which were pathologists, international experts, vendor representatives, IT informatics, policy health authority, then registry experts, the industry representatives, clinician, one biobank manager, and even one patient representative. And so as the standardized structured reporting implementation depends on all layers and also on all the actors in all these 6 layers, we had to talk about all the ideas and thoughts and also all the practices, not just from the perspective of pathologists, and that's what we did in part 1. But here is we expanded to every actor and to directly determine whether SSR becomes operationally possible. And yeah, idea was that missing a stakeholder type means missing the prerequisites. And some of the findings. So the finding number 1 was that the governance is one of the most important binding prerequisites. And without the designated governance body, the content working groups cannot be convened, because who will convene them? The templates cannot be maintained or funded, because who pays? Then LIS vendors receive no commercial signal, just because there is no mandate to create the supportive LIS to create to in fact integrate the SSR. And eHealth platform has no professional interlocutor, and registry also cannot lead without authorization, and as well as funding cannot be allocated, and so that every other layer stalls. And what governments must provide is independent body. That's the ultimate showcase is BALHA in the Netherlands, which is not profession-owned and not government-owned, as well as Guardian, not an owner, so the labs retain data ownership, so body stewards, standards, and exchange, and as well as dedicated staff, so editorial and operational, so it should be not reliant on volunteer pathologist time. And that a lot of people just say that, yeah, pathologists would create the templates, but they already have, let's say, their essential work of being a pathologist and not just create the templates. So, as well as sustainable funding, so registry compensation relocation, pharmaceutical and government, as well as laboratory opt-out rates, so voluntary participation preserves legitimacy and trust, and phased rollout. So just start with one tumor type, like from Big 5, and build evidence and then scale nationally. And here I also put the one quote from the interviews from one of the pathologists who said that the cancer registry needed support from someone with political power. They would only work if they were given permission. And so finding number 2 is that semantic interoperability is the primary bottleneck. So it's actually not the technical exchange, and as well as it's not a software performance, but it's just the semantic agreement that has to be well thought. And here is the quote from one of the health and policy authority. So the challenge isn't the technical interoperability, it is semantic. And without standardized value sets, the effectiveness is limited. And in fact, the Belgian eHealth platform is ready, and just within 3 months from content definition, it can just publish a fire care set, but it just has to be well defined what should be there. So the level 4 semantic interoperability requires first minimal data set, so where the ICCR or templates or CAP protocols as mandatory core, the national also non-core additions, which has to be defined by the working groups, and the reverse pipeline to define from registry need backwards. And as well as SNOMED-CT background coding. But here, important thing to note is that no physician should have to look at the SNOMED code, because it's all should be handled at the background. And pathology sees the text, and the system codes are needed for the computers. So there should be no physician burden in this case. And a FHIR questionnaire portability, so the central body authors template once in FHIR questionnaire format, and any LIS implementation runtime. So the template should be distributed plus updated centrally without vendor cooperation. And that the last point is practical for the Belgian situation because there are two languages, and so the multilingual structural equivalence, the Dutch and French templates share identical coded elements, so it's not word-for-word translation, but just structure parity, and the language is a rendering, not semantics. And finding number 3, so that's the LS integration is the primary technical barrier. And that we saw in Ireland when there was template they were created, but it was not ready to deploy. And so in fact, the FIRE questionnaire is the architectural solution, and so the FIRE questionnaire portability model could be the governance body. In case of the Belgium, it's the Belgian Society of Pathologists. They would offer the template in FIRE questionnaire format just once. Then LAS vendors, they implement compatible runtimes, so they mandate creating a commercial signal. Then the hospital deployment, the template deploys without per vendor re-engineering and developing the wheel over and over again, and as well as the template update, so the central update distribution to all runtimes automatically, which is also will decouple content governance from runtime deployment. So here are the 3 robust cross-layer patterns, which were identified across all the interviews and also confirmed by the co-occurrence analysis. So the pattern 1, integration is a bottleneck, not the content alone, as I mentioned. So the main challenge isn't the content itself, but the primary hurdle lies in the technical platform. Pattern 2, the hybrid reporting adoption necessity and computational sufficiency. So a combination of both narrative and synoptic would be the best solution because still a lot of pathologists are reluctant to work in a standardized manner. And pattern 3 is a governance as an enabling prerequisite. So without governance, there is no content group, no funding, and no LS vendor obligation, no e-health engagement, and no registry pipeline. And the one condition no actor can substitute for. Yeah, here is the stakeholder position matrix, and what is, so we have here the supportive in green, conditional, pragmatic, skeptical, ambiguous, just mixed, and the one that decided not to share thoughts about certain layers. And what is important to see that the skeptical about the application we only can see in pathologist part, as a lot of pathologists were just, they wonder how that could be just implemented in the local LAS. So there is no categorical opposition, so all also identify level 2 as binding. You can see here so many conditional in yellow, and also all endorse level 4, which is the information. So they all endorse the ICCR templates and CAP protocols, and also all rejected that NLP as sufficient substitute for at source SSRs. And here is the 6-layer SSR readiness framework in Belgium. And here is fascinating to see that the dependency of government, so the layer 2, is prerequisite for all other layer. And also for layer 4, we see that the SNOMED city is more than 25% mindable, and in fact, SNOMED city covers all CAP protocols, and right now it's, I think, 95% mapped also to ICCR protocol, so which means that that is also a success indicator for information. And the application, just demonstrated that SSR should be, if it's, the success indicator is that if it's employed in 2 or more LIS system and also demonstrate portability, that is enough to say that it's successfully implemented. And here are the 6 conditions that must coexist and what happens if one of them is skipped. So here we define the 6 of them, which is governance body designated, minimum data sets agreed, LIS integration in daily workflow, fire exchange standard published, and pilot sites on national level, as well as regulatory clarity. And these should be all addressed concurrently. This is the keyword, the concurrency, as if it's just addressed just one, like one by one, the very important thing must be missed. And here also the table down below is here what actually happens if we skip a layer and how this failure was documented in our data set. So if we skip a layer 5, the forms, they are, although the templates were designed, LIS can't receive the output, so entire implementation abandoned in case of Ireland. So for instance, if we skip layer 2, the BSP template published, but as there is no governance, they only exist on the website, they are unmaintained and not implemented. If we skip again, the layer 2, which is governance, so the national module built, but if there is no dedicated stuff, as the voluntary dependency, that creates a sustainability risk. And if we skip the application, so if there is a e-health platform ready and operational, but platform waits and nothing to standardize, as well as if we skip layer 5, working SSR system, and we have a single developer, so developer, for instance, retired, and then system gets inaccessible. So progress on any single layer without the other creates just the failure modes above. I think that this slide, Paul will talk more in details. What I can just say that Palga is a beautiful representation of how the SSR actually work. And here it's fascinating to see the part where we see the FT time savings by program when completely automized. And in case of the basal and squamous cell carcinoma, it's about 1.9 to 2.4 FT savings, and bowel screening, it's 10.7 to 13.5. Cervical screening, it's even bigger with 12.6 to 15.9 FT, and all SSR at Palha, it's about like 2-4 FT. This we can discuss, as I don't have that much time. This we can discuss like already together, as I also saw that there will be synoptic another talk about synoptic reporting in Africa, and I'm very fascinated to hear about that. So, and that's the practical roadmap. So the governance decision is not technical, it is institutional will. So designate the governance body, so National Pathology Society or Ministry of Health agreement, and independent foundation as Palha, for instance, which is the program maximum, I would say, but that should be guardian but not an owner. And also laboratory opt-out. Then convene content working groups. Start with one tumor type, ICCR is mandatory, core, and revise pipeline. So define from registry what it needs and then backwards. And then build and deploy FHIR runtime, so FHIR questionnaire from working group, and browse-based where LIS absent, and a pilot in 1 to 3 sites. And then connect to a national cancer registry. So in case of Europe, it's eHealth and national HIS. And FHIR CareSet certification and automated structured data pipeline and mandate at scale. So policy anchor, accreditation and funding incentives, national rollout and additional tumor types. And take home message, so what SSR must include. So at the baseline, get these right first. So regional national governance, so designate custodian bodies, so before anything else. Then international minimal data set, which are CAP, ICCR, RCPath, RCPA as content foundation. Then, of course, cancer staging TNM, aligned with the SNOMED CT binding, which is very important. And of course, international coding as SNOMED CT allowing ICDO as the background, and it should be invisible. And data exchange standard HL7, FHIR or Open EHR. And the challenging to build toward this can be the molecular diagnostics, like standardization by ESP, and similar bodies, AI and digital annotation, and extended SSR templates, so just also beyond the ICCR and work in the international societies, and as well as AI drift governance, so SSR grounded retraining as WHO classification evolves. So the governance, so implementation is not the content problem if we talk about SSR implementation, it's the technology problem, and it is also the institutional decision waiting to be made. And so the pathology report is no longer just for pathologists and clinicians, it's also for patients, registries, and algorithm alike. And to move forward, we must structure what we know and connect what we share. And so I also left a couple of questions for the African Society of Digital Pathology. So who will be the first African country? Who will be the first? Yeah, which tumor type will anchor the first continental ICCR-based minimal data set, and what role will African Society of Digital Pathology play in coordinating Pan-African working group? And with that, yeah, this is my reference and acknowledgement. And yeah, with that, I will conclude my talk. Yeah, thank you very much.
Thank you. Thank you so much, Dr. Basileva. And before moving to the next speaker, maybe it's time to ask for some questions from the audience. If any questions. No questions. I think we move next to our next speaker from also the Netherlands, Dr. Paul Arnold Ziegers. I hope I'm pronouncing the name correct. Who will introduce us to the ICCR templates and SNOMED CT. You're welcome, Dr. Ziegers.
Well, thank you very much for inviting me also for the second time. Probably I did a good job the first time, otherwise I wouldn't be here. I'm here actually on the behalf of the ICCR. You already got in the beginning of this session a survey on paper. You will also see a barcode at the end, a QR code at the end of my presentation, so you can also fill it online. I think it's very important. We think it's very important that you fill in and see if you missed things or not before we will send this internationally. So Hisham and Basma already made comments and we already included them. So, but we really want to see what your thoughts about that. So that is the point where I'm here. So I'm very delighted to hear in previous talks words like interoperability, structured reporting, standard reporting, data sets. Many years ago, this was still not the case. So it's slightly coming in. And I think when we see digital pathology, when it's getting so granular, so accurate, we should do something with the data too, because we need to know what we're going to do with this data for research, for secondary use, for policy making, etc. We are now thinking, in my opinion, a little bit too much of using artificial intelligence and digital pathology to lower the burden in our laboratory. But what we forget, I think, or not everybody, but I think the general meaning is that we forget that we need this data also to enhance the digital pathology, to enhance the artificial intelligence with very high quality data and good defined. So for that, we need two things. So next to the artificial intelligence and the digital pathology, we need standard structured reporting. Well, my colleague Ekaterina already did some very basic work, and that is really what you need to address when you want to go in that path. But we also want to do to make it standardized reports and content. And one of the organizations is like the ECCR, where we're working with together. We're in the group where we can help low and middle income countries to set this up, but also even in Europe, our experts is really been asked to help us to set it up. Because when you start with this, you want to know which step to make and make sure that you don't halfway the process said, okay, we haven't thought about that. So for that is, next to that is the interoperability. But we saw in the term, well, what is interoperability? The synthetic interoperability and semantic. Synthetic is the carrier, that's the car, goes from one healthcare system to another, or think about your list system to the electronic health record or whatever, that is your car. And what does the car bring? The content, and the content that are SNOMED codes, because that other systems can understand. So we're going to take you a little bit on that road. Well, this is, of course, an open door. We see that we are going to change from traditional pathology to this new event that we're going to digitize very fast and new items are coming. But when I see a lot of those presentations, then you see at the end a sort of, yeah, what could it be? A sort of report, just a few lines, and say, okay, that's a report. But for us, there starts actually the interesting part. So what is standard structured reporting? For me, I made there a definition for that, is that it's also known as synoptic reporting, or nowadays also structured reporting. And it's a clinical documentation which is a method that standardized reporting structure helps to produce more complete, consistent, accurate, and value medical reports. And this you can also use for radiology, for instance. And standard structured reporting standardizes how the data is collected, transmitted, stored, retrieved, and shared between clinical information systems for primary and secondary use. Well, in Europe, this is very important in the case of now the European Health Data Space, for instance. So using structured reporting and SNOMED terminal bindings is for us wind in the back, we call it. Okay. Well, probably you have seen this before. This is one of the pictures from the first article from Ekaterina. She told about level 1. That is what we call actually a rain report nowadays. Hey, you just say something and that's it. But we see that that's very basic, and you can make your report more advanced, and there are a few steps where you can do it. When we try to say you have to start with structured reporting, you should start at level 3. And level 3 is when you're going to use, let's say, implement the ICCR templates, or CAP, or RCPA. But because I'm here presenting for the ICCR, I would say take the ICCR. We're coming back to that. When you are a little bit further, like in the Netherlands, we're on level 6 and even level 7, and that everything goes already automatic. And that means, for instance, for us is that To give you an example, more than 500,000 records are directly sent to registries, quality registry, cancer registry, public screen, without any people between them as data managers to interpret. So it's intrinsic data what you have directly from pathologists in the registries. And pathologists see that. They say, this is data I can recognize from my own practice. So this will help also financial, lowering the burden for financial administration. Okay, so why does it matter, of course, to use it? I will not say all of the things because it's already mentioned by Ekaterina, but it's also very important for the research and benchmark. In the Netherlands, we did already a few of those e-learning systems where you can use a national protocols before an e-learning and after, and then you can see the results that's getting better. So also pathology is getting be trained for that, but you have to have that good data. Okay, so of course there are coming now more and more articles about structured reporting or synoptic reporting because the terms are a little bit used differently in the articles, but we try to establish that standard structured reporting is the highest level and that's what you want to go to. But for instance, pathologists, but also clinicians like it because always everything is on the same place in the report. They can directly see if something is missing, but they can also see the data what they want. Sometimes they only want to read the conclusions and sometimes they want just the list with all the data. We did a nice study to see that it also improved registries. The quality of the registries goes up, and it means that if the quality of the registries goes up, that means that you can do more with the data, so that you can more make comments, conclusions for policymakers, for instance. And what we also see that is the improvement of cancer care. That is the one of the most important article from IRIS and one of the students at that time at Palga. We showed that when you're using structured reporting, it's better read. And when it's better read, you get better patient management after that. And I would really recommend, if you don't have seen this article, read it because this will show you that standard structured reporting really helps the patient. Extra. Okay, so for the ICCR, and probably you all heard of them, I hope. What are the objectives, what we do at the ICCR? Well, we develop common data sets. You probably have seen them, of course. We try to standardize reporting using the classification, the staging, and to support the best practice for the patient. And we improve, and this is very important, the report completeness. And that means that if you do that, that when you're having a multidisciplinary team talk about patient management, then you have all the elements what's there to do the most optimal strategy for the patient. And what we also try to do is to global implementation and make it as list ready if possible. Well, that is also something what you have to do with the vendors. But it is something what we try to achieve together from the ICCR. We have no commercial mark as an ICCR. This is just try to help everybody in this case. And to reduce, of course, the equity gaps. So, if you look at the structure of the organization, I just want to point out two organizations, the Structured Reporting Implementation Committee and the Dataset Authoring Committee. And you probably have seen those sheets, and we'll just give you an example in a minute. But maybe you want to know how this will be conducted. So you have the blue books. Everybody knows the blue books, of course. And from that, the dataset committee makes a selection. Okay, what is at this moment important as the highest level of evidence, of course, is important to have in the report as a mandatory question. It will be reviewed. There will be made a sort of data set, of course, and it is very important. There will be an international consultation. And the international consultation will be done through the people who are a member. And also, so we try also for the low and middle income countries, we have some special fees for them also, so that they also can talk with us about those data sets and see what for them can be very important. After that, then we publish them, and you can have them free as a non-commercial organization. If you want to use it as a commercial organization, you have to pay some fees for that. So, the other club, the other organization is a SHRIC, and we try to help people to implement, and you see here there is already a long list of people there, and I'm happy to say that Hisham also has joined this group, so we're getting already this connection with the African organization, and that was for me very important, so we can see that now we're getting more and more together. So these people here, they will help you to implement and to see if we can make those steps, and especially if you look at the previous presentation, that you do all those steps before you start. And that's very important. Those people can help you with that. If you look at the ICCR organization website, you see then here the different organs, of course. Well, this will be not, I think, very new for the most of the people of you, but if you click on one of them, then you see the templates coming, what is under that organ part. Here's a template, for instance, from the colon rectum cancer, and what you see that there are two kind of questions, bold and non-bold questions. The bold questions, they are mandatory, the core elements. That means that you have to fill those in. If you want to implement it in an application system or in your list system, make sure that it's mandatory to fill it in. That, these questions are, and that's very important, to give the most optimal patient treatment or a patient management. Next to that, you have the non-bold, and there are the non-core elements. So they have a less evidence level, but on the other hand, it is a minimal data set. And on the other hand, you want to make a complete report, so that sometimes you can have locally questions, what's important for your organization. So we have always a few of them, but you can extend it. To give you an example, and this is the really tricky thing when you start with this, is that when you finally start with standard structure reporting, you want to have everything in it. And I can give you, for example, our head neck protocol already knows 2,000 questions and answers. So that looks much, but it means also you have to maintain. But pathologists want to have everything structured because their data is so granular, you can use it. And the granularity also comes from the, of course, from the digital pathology part. Okay, so SNOMED CT, is there anybody who haven't heard from SNOMED International? Okay, so that's good to hear. Well, we have, of course, SNOMED CT of SNOMED International provides codes for the medical terms, but it is for whole healthcare, not only for pathology, but all for whole healthcare. When we had a talk in Oslo, we talked to the people from SNOMED International and said, look, pathology is such a small part in all healthcare, we can do it ourselves. And they were so glad. They said, Paul, if you can do it yourself, let's say with the group, that would be fine, because then you're in control for all the codes that you want to create. So we have a group every Monday. We come together with a lot of pathologists and experts, and we make constantly new concepts, because there is for pathologists very less. And those terms you can use, it's invisible, it's on the backside, nobody cares, but you can send the data from one healthcare system to another. That is really interoperability, but that's semantic, so the other system understands what you mean. A code doesn't say anything, it's just a string of numbers, but you can translate it in Spanish, in Moroccan, in Farsi, whatever you want, because that will be understood. So I just give you just an idea. if you look in the browser from SNOMED, and that is free for you to find out, and for instance, you type in mild dysplasia, and then you see in the right side the parents. So it's also a hierarchy on it. So you can find it under the growth alterations, under the lesions, and under dysplasia. And dysplasia, we call them morphological abnormalities. So everything what we see in pathology, we call it or a disorder, or a morphological abnormality, or a procedure. And you see there is a number on it. The CT ID number is just a string. It doesn't say anything. But if you have this on the backside as a result, as a mild dysplasia, every system can understand it. Okay, on the website you can also find the implementation guide we made with a few people. If you want to start and you want to do it on your own, I would not recommend it, but I would say please download this implementation guide we made and look at it from, okay, from its perspective, can you help us with it? Because we don't think that we have all the wisdom in us, so we need also help from you, because we're a community for this. So what is the objectives of this group where we're working in SNOMED? So that's the Pathology, Laboratory, Medicine, Clinical Reference Group. So we try to make the terminology governance. And that is for pathology, right? We are talking only for pathology here. We want to improve this semantic operability, of course, with this, and to standardize the report so that we do the connection with that. And at this moment, sadly, where is Sabine? Oh, sorry, Sabine. Yeah, it's still oncology data, but I know if you push enough, we're going to start with placenta and with functional diseases from the kidney, and I promise you. Okay. So, and it's also nice to know that the data sets are in the blue books. So I mean that there is already this connection with that. And I think this is all very important, that the work what we do is already internationally recognized. And here's an example, and what we called SNOMED terminal bindings. And SNOMED terminal bindings, that means in structural reporting, you have a question and an answer. So in this case, for instance, the operation procedure, so you have the colon colectomy, total colectomy. It's a procedure, a specimen collection procedure, and that's the procedure, and then you have the answer is just the total colectomy, and that is then the other code. So you have two codes, and that's the binding. And those two, that will be understood with other systems. Okay, just going to back one, because I had something that I wanted to show. I thought that I think it's gone. Oh, sorry, Andre, because I had one picture of a world picture, but not was created by you, and now it's out. So, but that on that picture was shown that a lot of countries already are a member of the SNOMED International, and they're also affiliated members. And affiliated members are, let's say, vendors or hospitals, etc. But when you are a member, that means that your country, they will maintain these national services from SNOMED, and you can make new concepts in your country. So, going for the last part, and that is for the survey. So it's very important for us that we really want to help everybody where we can, and to say, okay, fill in the survey. It's about you a little bit. It's about the laboratory function. What are the level for you, what you can use for synoptic or structural reporting, and why not? Because we also want to know what are your constraints in that. How is your access to information, education, and especially the cancer registry. So if you want to start with doing something like that, cancer registries, if that's available in your country or region, is always low-hanging fruit, because those people just want to have your data. And if they can save that by not setting people, data managers, and to interpret your data, then this is the first party where you have to talk to. Okay. And thank you for your attention. So first of all, please scan the code, and even if you didn't fill it in on paper, it saves me a little bit time if you do it also with the QR code as asked. So, and in the last question is final thoughts in that. Please give your final thought if there are things that you say, okay, nice that you have this
a standardized fashion, right? So film industry, telephones, audio media, banking, retail, everything has pretty much gone digital. So we are needing to move forward with that, and pathology is really undergoing that evolution here today. So I try to talk about this ecosystem where it's not just a scanner or a workstation, right? We talk about interoperability and making sure that everything works in tandem. So we have here the scanner, the workstation, the AI solution, ideally connected into the laboratory information system, and I also try to bucket these 3 other digital pathology segments where we have the hardware, that's the whole slide scanner manufacturers, the viewers, which are the image management systems, and of course the AI community and tools within that for the decision support. So at UPMC in Pittsburgh in the US, so we've had a long history of digital pathology. So in the late 1800s, the department was founded, but of course only until the late 1990s where we actually started any sort of digital pathology, starting with static images. I think a lot of folks who've been early adopters have had a similar trajectory. Then we went with a robotically controlled microscope for telepathology frozen sections. We offer frozen sections for many different departments, even outside of our own. And we deployed a scanner in 2006, again, mostly educational. Then we started actually an international telepathology consultation. I'll talk a little bit about that. And then I would say over the last 10 years have been focused on clinical deployments and AI development. And then about 2 years ago, we opened up our AI center as well as our digital pathology research center. And hopefully by next year, we'll have a new modern image management system with a full-fledged digital workflow. I'm very spoiled in that for the last several years, for the last 4 years, I've been able to sign out all of my cases digitally and with the use of AI. And so there's been a refreshing, I'd say, turn of events where now there are faculty asking me when are they getting their high-grade monitors, high-definition monitors, and when they'll be able to do that. How we got there is obviously took a little bit of prayers and luck, I guess, but some of the, I'd say, sticking points that I try to recall to tell people are, talking about cost and talking about safety. There's a cost to and somewhat of an inefficiency in applying barcodes to all of our pathology assets. But I would not go to any lab in the US that doesn't have a barcoding and tracking station. And so we sort of use this analogy where digital pathology AI can be akin to a barcode that's being adapted onto the slide or to the specimen. There is a quality assurance point to it, and it eventually will be standard of care. Getting institutional support was incredibly helpful. Actually, I would say going outside of the department, going to the radiology department, the surgery department, getting letters of support from them were incredibly helpful from moving along our agenda and getting funding for our deployment. Risk mitigation. In the US, there's a lot of medical legal issues where there was a hospital that lost one critical slide, and that was a multi-million-dollar payout that could have provided their entire digital pathology implementation. We talked about asset management, being able to move and track images much easier than it is to move people, and of course from a distributed network standpoint, the turnaround time. So UPMC is split into 6 different regions across 3 states, mostly Western Pennsylvania, a little bit of Western New York and Maryland. And so we have about 42 hospitals across these systems. So we are sort of a large distributed health network with a lot of the academic medical centers focused in the little bubble there in the blue region in the southwest of Pennsylvania. And the yellow dots here show a lab that has any digital pathology device there or usage. Again, mostly clustered within our sort of main academic medical centers. A lot of these are for our clinical scanning efforts, but then also we provide remote frozen section support for some of the other medium to larger hospital systems around the state. So, and even outside of the UPMC network. So It's not just an individual, right? This is, we thankfully have a lot of leadership support, which if you don't have that, you're going to face a lot of uphill battles. We got the pathologists involved. I truly believe you need a champion to move things forward. Trainees, as an academic medical center, we included them, of course, lab staff. Some hospitals choose to have a scan team. Some are able to lay that work onto the histotechs or other staff, and of course your informatics or IT divisions. We also took it as an opportunity to really look at our pre-analytic workflow and reassess how we produce our specimens, produce our slides. So making sure we go back and really look at the gross workflow, embedding tissues closer together, because embedding them further apart makes it longer scan times, larger files, sectioning the tissue in the middle of the slide so it's less, there's a less of a probability that it will be outside of a cover slip or not be scanned in focus. And of course, cover slipping, making sure that the cover slips aren't hanging off the edge so they don't break on the instrument. And we also looked at this from an interoperability standpoint, from a physical delivery mechanism of those slides. They're in their little cartridges as they pass along, and so we didn't want people re-racking slides and putting slides from one container to another. So we looked at compressing this into a stainer, cover slipper, and being able to leverage that right onto a whole slide scanner. I also want to put a plug in for quality control of this, because again, now that we have our digital assets, we're able to really check and evaluate the quality of the slides that could be coming out of the laboratory, especially if you're looking at an archive scanning process where you have maybe millions of slides sitting in a warehouse somewhere. These are an opportunity to really look at prospectively what is coming out of the lab. And so we have three main critical post-scan quality controls: making sure that all tissue that was on the glass slide is now imaged on the digital slide, that the barcode is properly decoded. Again, we have that barcode as the gateway into the laboratory information system. So if the barcode's not decoded, or it's smudged, or it's half printed on the slide, it's not going to link that image to that patient's record. And then, you know, there's probably variable remediation of digital scan artifacts, and we're still trying to figure out exactly what thresholds are clinically meaningful. You know, if 2% of the slide is out of focus, what meaning does that have? What impact? Maybe it depends on, was there a tumor under that area out of focus? But at least we have digital means to be able to do this. And so we've built, there are vendor solutions for this. We've built our own in terms of being able to actually look at what is the percentage of tissue that has stains, that's out of focus, that's has an air bubble, and then give feedback to the histotechs and folks that are much more upstream. And I saw a much better example of this in a previous talk, so I won't belabor it, but ultimately this is how most folks work. They'll have their laboratory information system on the left-hand side, and they'll be able to launch an image on the right-hand side and have sort of an integrated image management system as part of their workflow. With that patient context management, you switch to a different patient, it loads the new patient's images. And then in our current workflow, we don't have a great bi-directional workflow. It's really let's launch this image viewer out of the laboratory information system. It would be ideal to pass annotations, pass AI outputs back into the LIS, but currently that's really not a reality. So also in Pittsburgh, we started sort of a binary distinction between what image analysis or AI tools we use and who uses them. So we started a CLIA certified image analysis lab. So if a result from an image analysis tool or machine learning tool is going to result in a report, we've started to funnel those through the image analysis lab. So we have a prognostic test for CD8 immunohistochemistry quantification, Ki-67 quantification. We're hoping to do this for breast biomarkers, where we're going to move that, again, to a more centralized process, so then that way the pathologist in all of the rural settings ultimately won't have to do that work anymore. We're going to centralize it. It'll be added as an addendum, as a sort of a separate report, and that way it'll be standardized across every patient that comes into the hospital system. You've probably seen nuclear quantification tools, but this is sort of what it looks like. It can count cells with much better reproducibility and at scale. And this can, again, be done as soon as as soon as the slide is imaged. We pull that metadata to say, okay, it's this sort of a specimen. So we pull that from the laboratory information system to say it's you know, this specimen with this stain, go and run this rule-based system to run this image analysis tool. So we published on a couple of this. So this is sort of a laboratory-developed test where we have shown CD8 T-cell quantification to be a predictor of survival in response to chemotherapy in certain tumors, like head and neck squamous cells, colon cancer, melanoma patients, and being able to actually quantitate Ki-67 in breast cancers. We've also been able to support remote digital pathology, and our pathologists really appreciate this. It helps from a work-life balance. This is not a replacement for them to come in, but this is, you know, allows them to preview their cases in the morning or be able to review them afterwards if a clinician has a question. And so we have about 24 of these deployed out of about 150 faculty, and we've learned a lot through at least US regulation in terms of what sort of compliance we need to have and disclaimers. All right. We also have a long-standing history with digital pathology consultations, and so this was actually presented over a decade ago as a poster, and we had an online web portal. You could submit a static image, a whole slide image, and we'd be able to report something, send a report back in our sort of own developed portal. We've actually just since sunset that this year in hopes to hopefully have a much more modern approach with our new image management system, but I'll just put a plug in for the paper. It was mostly looking at international consultations with China, although we did have some presence in the UAE and in collaboration with Italy. For cytopathology, we have pretty much exclusively telepathology, rapid on-site procedures, rapid on-site evaluations for inadequacies. So they use sort of a camera mounted onto a microscope, streams over the internet. Pathologists can tap into this and then be able to see that, that cytology specimen. We're also looking at this from a frozen section standpoint, but currently we have, again, a robotically controlled frozen section. For cytology, we have, for GYN thin prep cytology, we have these scanners deployed where we've actually centralized all of our thin prep pap smears to be centrally located. They get scanned, imaged, and then have that AI embedded workflow. And so pathologists have given a lot of great feedback on that. I just want to call out the difference between the single plane versus multi-plane scanning as well as extended focal imaging. So I think I've heard a few folks mentioning about the Z-plane scanning, and I feel that a lot of the work and effort and cost effectiveness might be better served with the extended focal imaging, where it essentially looks at each region of the slide and stitches the most in focus or highest most sharp image across all of those planes. And so you still have a single, you know, a pseudo single plane image that you don't have to actually scroll through, but it has all of the regions of interest and cells of interest in focus. So it makes a big difference from a storage cost perspective, scanning speeds and file sizes, as well as just from a user experience. And so, oh, that video didn't work. Okay. So this is a video sort of showing what that would look like. I guess that one's not working, but here you can see an example. Extended focal imaging has sort of been extended outside of healthcare, and you can see in the above row, that's sort of just, you know, akin to a single plane scanning, and below you can see that it captures all of those areas, even though they're sort of three-dimensional or have some three-dimensional structure to them, that it keeps them all in focus. All right, so these are the 3 clinically validated AI tools that we use every day. So we have the prostate cancer detection, AFB screening that I had mentioned before, and the GYN thin prep. These unfortunately are also 3 very different architectures. So the prostate cancer detection is a cloud-based vendor, so we actually have to copy our images to the cloud for it to run compute and then send the results through their portal. The AFB screening is completely on-premise, and we've developed that ourselves and support that, versus the GYN thin prep example. It's, there's a GPU device essentially attached to the scanner, so it's running locally within sort of what they call as an edge compute or inline computing that is running locally, but you have sort of the hardware to manage that. It's not going to a cloud. And so this is an example of sort of what a, this is a prostate core needle biopsy, sort of what the interface might look like when reviewing these tissues. And with this specific vendor, they have different heat maps for every single one. So there's one for just tumor, there's one for Gleason scoring, so you have to sort of choose one at a time. This is the cancer heat map, so unfortunately you don't need sort of an AI to tell you how much tumor is on this slide, but it'll give you these outputs again right before before you even come to the hospital in the morning, and it gives you these outputs and also tumor measurements. All right, so I mentioned the sort of different deployment strategies. We have to remain flexible, I think, until we have better standards, until we have a better way to actually deploy these in a more standardized fashion. So we either buy vendor tools off the shelf, or we thankfully have resources to build them in-house. So I'll talk about CPACE. CPACE is our sort of internal AI research and development arm of the department. We have pathologists who want to bring their own AI. They build it in QUPath or i4, or some other platform they have access to, and they want to be able to bring that and plug it into our own system. And then I mentioned sort of the vendor-supported system. So CPACE stands for the Computational Pathology and AI Center of Excellence. Everything in Pittsburgh has its own Center of Excellence, so this is something that was just started about 2 years ago. This was sort of our kickoff meeting, and it was great to have the chairman's support. And so so far, even in just a short time, we've really outgrown ourselves, and we have about 10 patents filed. We have actually 13 products developed at the moment, and we've been able to really get a lot of interest from machine learning engineers, software developers, obviously faculty, PhD students, postdocs, et cetera, and have really grown this to help support a lot of the AI development in-house. We also started a Digital Pathology Research Center to be sort of a hardware, software playground, if you will. So new vendor has a new product, they want to bring it to market. It's very external facing as opposed to CPACE that's very internal facing. The Digital Pathology Research Center acts as sort of looking at academic industry partnerships. And it's sort of similar to, I'd say, what was made in Leeds with their AI Forge, although not just looking at scanners, also looking at all sorts of AI tools. So this is an example from the Leeds facility plan. And the goal here is really just to look at generalizability, which is sort of the main theme I'm going to talk about next. Being able to scan, say, the same data set across all of these different scanners, you would see that we have scanner variability, right? It's not just color, it could be image compression, it could be all sorts of things that we don't know how AI will be impacted because certain AI might be only trained on one of these that only has a JPEG compression algorithm versus some other color quality to it. So the goal is really academic, really research, but then also to help give feedback to industry as part of those partnerships. So we've done everything from FDA 510K submissions, a vendor's ready that they think they have a product they want to bring to market, so supporting clinical trials, to just usability studies, product feedback and evaluations. And so through that, we develop some intellectual property and also help, I guess, support commercialization. So we've done about 27 initiatives, and it's actually generated revenue for the department to help support. We are able to hire sort of a scan tech dedicated to these efforts. And it's really helped, I think, grow a lot of our partnerships within industry. And this is intentionally complex. The goal is not for you to read through this, but this is essentially a walkthrough of what it takes to bring some of these vendors through the door. So you have to actually have that discovery meeting, figure out a plan of what you actually want to do together, and then the onboarding process takes an incredible amount of time and paperwork and red tape. Then once many moons later, after you actually get all of these paperwork signed and cut through the red tape, you actually have to bring it in, test it, validate it, give feedback, and then that should hopefully give some recommendations towards whether you want to use this in practice or not. So we were hoping to cut all of that and streamline it, and so we started an Office of Collaborative Pathology by Dr. Deere, who's our head of anatomic pathology, and we were able to get our own legal counsel, our own regulatory personnel that work on all of the non-disclosure agreements, the memorandum of understandings, the scope of works, the budgets, et cetera, and streamline that all through this office so that we don't have things waiting on somebody else's desk. And so they sort of coordinate between CPACE, the Digital Pathology Research Center, and some of our other investigators at the hospital. So define the use case, have a plan. Finding space for things is of interest, and hopefully we're not alone in this. We hired our own staff to help support this effort. And then you get to actually contact the vendors, start with all the sort of documents and budgets and contracts. And once that's all done, I think that's sort of the fun part where you actually bring in the hardware and software and do the technology demo and then see if you can validate it if it's useful. So the main point of the talk is one of our first projects was building that AFB tool that I mentioned before. So we built it, worked fantastic in our own hospital. There was a hospital system in South Africa. Our chairman is from South Africa, in Johannesburg, and we said, okay, use this tool and see how it works for you. And it performed not that great. So we obviously hear about generalizability, but it was very tangible for us at that point because we thought we were going to be very altruistic and say, we're going to build all these AI models and pass them out. Unfortunately, that's not how it happened. And so we wanted to create something to minimize or to lower those barriers of enabling generalizability. So we know that we don't have access to great diverse data sets. Not everybody has the resources that we may have in terms of AI development and talent to help build some of these tools. There are all sorts of data privacy, governance barriers, specific government requirements, organizational silos, costs, of course, in infrastructure and GPUs or TPUs to actually even be able to build these sorts of things. So we started just this year, so what we're calling the AI Data Commons Alliance. And this is really a global effort to be able to create generalizable data collections at no cost to the data providers and be able to give permissions and roles to everybody's own data and be essentially an AI factory or co-collaborate with that group to then build some of these tools, again, to be generalizable, to be extensible so they can use that in their own environment or perhaps even provide that to another group. So this is all sort of de-identified patient data. The goal is really to build the generalizable models and be sort of an AI factory for anybody who's interested and co-collaborate. So we want to have diverse, high-quality labeled data. That's sort of the intent for it. And then sharing that data, we can build AI models or co-develop them, generate intellectual property, again, at no cost. If there is any licensing potential opportunities, there'll be some potential revenue sharing opportunities. But at the end of the day, this is really funded by Pittsburgh, the University of Pittsburgh, and we are sort of owning the cost of the infrastructure and the development aspect of it, because we're hoping that this will be something that will help sort of the greater good. There are probably a lot of technical details and other things where the data can stay local to your own government or can stay local to your own geography and be able to sort of develop those AI projects together. And there will be a steering committee that will sort of be able to discuss this at length. But at the end of the day, that's essentially the premise of being able to share and create generalizable data sets and be able to provide AI tools back to organizations who may not be able to do that. So we have sort of a platform to do this, and it essentially indexes the cases, the de-identified data. There is an annotation workflow and toolkit that's useful here to help build the annotated data and be able to scale that to build the models. So we can build cohorts, we can search them. Obviously, that data is protected and private to you or anybody you give access to it. And then we can couple data together, right? Because I fully believe that images alone are really not helpful, but that combining it with appropriate standardized structured data is very important. So being able to leverage that, obviously we do process reports if they are unstructured. If you have structured data, that's much better. And be able to build those AI models and then give them back to other groups. So really that's the main goal, and if anybody's interested in collaborating and discussing further, please feel free to talk to me, or I think I have a QR code on the last slide. But at the end of the day, the Digital Pathology Research Center is is happy to collaborate in any capacity. We want to provide a lot of this also as educational tools. There are existing free educational tools to those who have access to the DPA educational tool, the Open Pathology Network. We've also made our own PIT AI Academy that we're hoping to give out to others. And so we see this as sort of a global effort to both educate and then also provide clinical tools back to people. And so this is just an example of, this can work for static images or for whole slide images. Say you have folders of data, you put it into a training folder, putting into a test folder, and you can essentially choose a model that we have in our model zoo. We have a little bit of parameters here, and you can train a model completely code-free. You don't have to worry about rigorous coding schema and things like that. So we're able to essentially give some performance data and see how well it works on that specific data set you provided. Of course, we want to combine that with other data, but here you can sort of output some either binary or multi-class tools, and you could even just download the model right then and there, get a report for safekeeping. All right, so this is, I think, my second to last slide. I just always like to comment on, will AI replace anybody in pathology? Again, intentionally facetious here with looking at all the different staining types, all the different organ systems, all the different diagnostic categories. I think we probably only have touched on just a very few of these still in the world today, and so I think there's plenty of room for pathologists to still continue all the great work that they do. So with that, again, I appreciate all of your time and effort. If there is interest in collaborating, feel free to come find me. There's also a QR code here. It'll connect to your email, and happy to continue to talk. So thank you for your attention.
Thank you. Thank you for your presentation. And perhaps we move to see if there are any questions in the audience.
And I should mention there are two QR codes. The left one will take you to a form to fill out if you would like any of the CPACE or Digital Pathology Research Center discussions. On the right side will take you to an email. Sorry, thank you. Happy to chat with anybody after.
Thank you. So I think we move to the last scientific session, and in which we are going to turn to a Moroccan contribution. And for this, I'm glad to invite Dr. Amal Fadaili, who will be presenting the Moroccan experience in synaptic reporting in oncopathology. Dr. Fadaili, welcome.
Thank you. Well, thank you for being here. I'm very happy to be here. Thank you to Dr. Lattar. Well, after these three excellent presentations, I'm gonna take you, because we all don't work in big facilities, I'm gonna take you back to Marrakesh, to my private practice. So these are my disclosures. This is the outline of my talk. So I wanted to talk to you about the pathology landscape in Morocco. So in pathology, we have pathology departments mostly in university hospitals, some community hospitals. The private sectors is made of solo practices, so we're mainly one pathologist per practice. Some of us, very few of us, perhaps less than 10 practices have more than 2 pathologists. As far as electronic medical records, it's mainly the major academic centers. It is not widely adopted. As far as governance, we have professional associations, but they do not have regulatory authorities, and obviously we have a Moroccan Medical Council, but very limited standardization and compliance oversight. So the workforce, I didn't want to use the same map, so I use this instead. So we have 10 pathologists per 1 million. So for cancer data and registries, they're mainly established in the two big cities, Casablanca and Rabat. So we do not have a comprehensive national coverage. The pathology report workflow, not the lab workflow, but just the pathology report workflow. So this is the traditional workflow in university or private practice. So the pathologist would dictate or writes a diagnosis or conclusion. Then the secretary will insert a pre-written report, what we call here in French compte rendu type, and then the pathologist would review it, edit it, and validate it. So our patients bring their specimens by themselves most of the time. They will bring the bucket or the bottle or whatever. So that's a big problem. Some institutions will send the specimen with a courier, but mostly the patient will bring in the specimen, or the patient's family will bring in the specimen, and then the report also is, so it's a hard copy. We give the patient 2 hard copies to take to the clinician. So communication with the clinician. So WhatsApp is very, very popular in this country. Unfortunately, WhatsApp is encrypted, but still not suitable for medical communication. But our clinicians favor WhatsApp over email. So this is what a pathology report in Morocco will look like. So I came across this pathology report because I received blocks that I usually cut for a molecular lab. So when I receive a block, I receive the block with the report. So this is a hysterectomy with bilateral ovarian salpingectomy. And I'm going to invite you to look at the conclusion. So the final report is actually at the very bottom of the report. It's called a conclusion. That is the French way of a report. I don't know if we have pathology residents in the room. Pathology resident? Okay. I don't know if you can spot anything in the conclusion that's missing. It's the translation. This is a cystadenocarcinoma of the ovary. So what's missing is it serous? Is it mucinous, for example? Also, I don't have the capsule. Is the capsule intact? Is the capsule ruptured? I don't have the size of the tumor. If you could see, it says that in the bottom of microscopy, it says that the cytology, the liquid is positive, but in the conclusion, we do not mention that the cytology is positive, because a positive cytology would obviously upstage the patient. So this is a report that's actually followed a frozen section. So if you look back at the microscopy, you're going to see uterus, curage iliac, which stands for iliac dissection, appendix, epiplone, and cytology, but there is nowhere you see the ovaries. And the reason why you don't see the ovaries because it was given in a separate report. So the frozen section diagnosis was done in a separate report. So this is the only report I got. So this is a fragmentation of pathology. So, so I do not know anything about the microscopy of the ovaries. I only have a diagnosis of the ovaries. So I chose this example just to kind of illustrate the different problems that we have here. One more thing, when we have a serous carcinoma of the ovary, we usually have to submit the fallopian tubes entirely. This was not mentioned anywhere in the microscopy. And also, we do not have how much sampling was done. We do not know whether, it was sampled one section per centimeter, one section per 2 centimeters, etc. So as I was saying, so the report is in French, macroscopic examination, not standardized. There is usually a systematic microscopic description for every specimens, even hernia sacs, non-tumoral appendices, gallbladders, etc. The diagnostic statement is represented as a conclusion at the end of the report, and most of the time, the microscopic description is usually a canned template. So these are I wanted to list the advantages of narrative report because it does have advantages. So everyone is used to it. It conveys a certain level of certainty. It's also, some people like the art of pathology or the art of writing a personalized report, allows flexibility. I can write a long report, I can write a short report, and obviously it's inconsistent. The risk of missing key information is very high, not structured, and it reduces clarity for the care team. There is a huge body of the literature that talks about the superiority of synoptic reporting versus narrative. I like this one because I can, this is for lung specimens, lung cancer specimens. Usually the parenchymal margin is you would think the parenchymal margin is really, really important, but you do notice that here, obviously in the synoptic it's 100%, but it's in narrative, the parenchymal margin can be overlooked, and so is the direct invasion of adjacent structures, etc. So what is the characteristics of an ideal pathology report? So I highlighted the adjectives: obvious, easy, actionable, conveys level of certainty, concise, standard, and obviously it has to be able to be read by a machine. So it has to be automated. So we've already spoken about the stakeholders. These are only few stakeholders of the pathology reports. As far as my practice, so what I decided to do first was to switch the format of the report, meaning instead of having a conclusion at the very end, a conclusion is actually where the money is. That's the final diagnosis. So I decided to switch and to change the word conclusion, to call it diagnosis or final diagnosis, and to put it at the top. So I had few clinicians calling me. So I had clinicians calling me to say, where is the conclusion? I still have phone calls, and I still have people saying that your report is upside down. It has to be similar to radiology report. Where in a radiology report we have the conclusion at the very bottom. So I'm still struggling with this. But this is very important because in the US, you would never be able to put the final pathology diagnosis at the very end, because I think it's an interoperability thing. And correct me, Peter, if I'm wrong. I think the final diagnosis has to be at the very top for it to cross interfaces, things like that. Not sure. Okay. Okay, but it's the standard. Okay. So, so even this is the pre-synoptic phase. So even small formatting changes can disrupt the culture. So this is when I decided to adopt the synoptic reporting. So the reason why I decided to adopt them is because during residency back in 2008, residents were, it was mandated for us to follow the gross-in protocols. So our surgical pathology director, Dr. Otis, mandated for all the residents and the PAs to follow a surgical a gross-in synoptics, and then obviously a surgical reporting synoptics as well. And also, I have a focus on quality, and I'm actually a CAP product. I've been using the CAP protocols forever, so So this is a mindset shift. So implanting synaptic protocols is all about a mindset shift. So the pathologist in charge, or whoever is in charge, has to take a decision. So that was the first thing. The other thing, I had the opportunity to be exposed to Intuitive, which is a commercial software that I was using when I was moonlighting in the US. So I asked them whether I could use the password in Morocco, and they said yes. So if I could use the platform, and I started using the platform as a standalone solution in my practice. So obviously, resistance from the pathologists within my group, within my practice, not the clinicians. They all preferred the detailed microscopic descriptions they were used to. They were not very comfortable with the language. We're a French-speaking country, so most of the people trained in French. So it was a gradual adoption, and I maintained some flexibility. We were allowed to put description in the comments. I have my PA who's here. She was helping, she usually helps the pathologists who have a problem with the software. She walks them through the software. So let's go back a little bit. So this is, we have two case scenarios. The second case scenario is when you have access to the commercial platform. Let's say we do not have access to the commercial platform. So we do have free available resources. We have ICCR. We have cap.org. This is all free. So we could go to the website and print them or transcribe them into our LIS. So what are the cancer protocols? So I'm going to be talking about CAP since ICCR was addressed before. They're reporting tools. They're created for pathologists, by pathologists, and they are clinical tools. They're not designed for research. They could be used for research, but they're not designed for research. And their primary role is to help the pathologist sign out the case and submit all the important information such as the grade, the margin, and the stage. So the background, it was initially voluntary to use the cancer protocols back in the days. Nowadays, it is a requirement for CAP accreditation, and it is also a requirement for the American College of Surgeons Commission on Cancer. So the societies involved in creating cancer protocols are here. So in every cancer protocol, we'll have core data elements, we'll have conditional elements, and we'll have optional elements. So the core data elements are the mandatory elements that have to be within the report, like histologic type margins, TNM, etc. Conditional elements only required to be reported if applicable, such as lymph nodes, such as skin in a mastectomy. Optional data elements are optional, and such as the second or third dimension in a tumor. So these are the breast cancer protocols. There are over 100 protocols, CAP protocols, 2 types, cancer and biomarker protocols. What is a synoptic format? So the synoptic format was coined back in 1991, where the information is arranged in a vertical list. So we have a data element followed by its answer, like what we see on the right side of the screen. It allows a visual separation. Okay, so let's go back to the limitation of the paper version. Obviously, it's manual, time-consuming, requires self-maintenance and updates, and it cannot be read by a machine. Case scenario 2 is when you have access to a commercial platform, such as Intuitive or Beaker or whatever. So they have ready-to-use synaptic templates. You could integrate them directly in your daily workflow. They're structured and they improve efficiency, but they need licensing. Electric cancer protocols. are cancer protocols coded. So for every question, there is a code. We fill out the form electronically. They can be built into your LIS and powered by a commercial platform. So I am going to do a little demo for a clinical case. It's going to be a demo via the commercial platform, Intuitive. So it's a 62-year-old female with the left breast carcinoma, no special type, grade 3, ER/PR positive, HER2 positive. She had a neoadjuvant chemo with dual HER2 blockade. So I'm just gonna, yes? You can start the demo. What is it? Okay, there is a little glitch, so I'm going to continue and go back to the demo. So after the demo, we get a synoptic report. It goes, it gets copied, it gets translated, and this is the result of the translation in French of the synoptic report. So you have the synoptic format with the data and the question. And then we always, we have a conclusion or diagnostic that we extract from the synoptic report. So the main elements, so the clinician doesn't have to read the whole synoptic report if he decides to not to read it. So a high quality synoptic reporting starts with high quality gross examination. So we do have a website, a very helpful website, the American Association of Pathologist Assistants, that provides us with guidelines for cancer resection specimen. They're designed to be used by pathologists, residents, and PAs. So these guidelines are based on CAP cancer protocols, AJCC, WHO, etc. So it's very structured, and it serves as a companion tool, and it ensures completeness and consistency of macroscopic data. So this is one of the website's illustration. This is an illustration for a mastectomy, neoadjuvant mastectomy. And it also gives you the key for the cassettes to be submitted. I believe this is a very, very good tool. It's a free tool, and these, just like the CAP protocols, they could be downloaded and used in any practice. This is my take-home message, and I'm waiting for the demonstration, okay? Okay, this is a demonstration, and Peter, you know this, you could go to sleep if you want. You've seen this. Okay, so we could go to breast invasive carcinoma. So yeah, this is the interface or the dashboard. So we have a total mastectomy. Yeah, next, so left, choose the site. Histologic type, we have a invasive carcinoma, no special type. We could put in a histologic comment if you want. Okay, the grade. So it was a 3, there's a score 3, score 3. Mitosis was 2. So tumor size, can put it any tumor size. This is optional, you could skip. So it's one focus, present, Estimated size, okay. Comedo, whatever, okay. Next. Grade, okay. Number of blocks, 6. Okay, no in situ lobular. Okay. Not identified. So we're basically walking through the whole cancer protocol. Okay, just to show you the final result. Okay. Probable. Okay, this is the RCB, the residual cancer burden, and the software actually helps you calculate the score, so which is good. So we're gonna put the numbers for the tumor bed area. $20, $30, okay. Mm-hmm. 0. Okay, so that was calculated. We could always calculate it through the website, but this is easier. And if you notice, we have the CAP protocol linked in the bottom if you want to click on it for explanatory, for explanation. So, yeah, it's selected RCB2. Margin status. Can you go to the TNM directly, please? Can you skip this and go to TNM? Yep. Yep. So for the T, it's supposed to be pre-selected already. It's PT1C, so it already pre-selected. Yeah, just have to double check. Yeah, and we could see what the final report looks like. Download PDF. Yeah, you could choose tumor blocks. So it's easy next time to choose the block for molecular. No, next, yeah. So this is the synoptic. So I usually copy this and translate it and paste it. Okay, can we go back to the prostate? Prostate synoptic, please. So we have this pilot. This is a pilot prostate grossing template. So this is done between Intuitive and AAPA. So this is just a pilot one. I just wanted to show it to you. So, so first we have to choose what type of specimen, radical prostatectomy, and then this is, I find this very helpful, pre-analytical, so formalin 10%. Orientation, oriented by the surgeon, by whatever suture. Okay. Okay. Good, very good. Okay, specimen integrity intact, INKI, we could do the INKI, the weight. The size. You could skip a little if you want. The margins, usually in prostate, we don't really see the tumor, so we can't assess margins. So anyways, this is very comprehensive, very granular, and it's still work in progress. Okay, you could show us the final. Oh, I like this cold ischemia one. Yeah, we usually never get, here in Morocco, we never get cold ischemia time. So it's good to have it. Okay. Okay, thank you. Final. Let me just go back to my take-home points on the PowerPoint. Can you go back? So take-home message, as it's been already said, synoptic reporting enhances accuracy and efficiency, improves communication with the caregiver and clinical outcomes, improve patient safety, interoperability, that the data exchange through health information technology for accreditation purposes, and obviously Mtuitive is working on AI and voice recognition integration. It's going to come out very soon. And thank you very much.
Thank you so much, Dr. Fadaili. I would like to ask the audience for any questions. Okay, so I think we would move to the next and last session, the last element of the session. It's a panel discussion on the Digital Pathology Alliance, a model of worldwide collaboration. And for this, I will call the panelists, Dr. Norman, Dr. Junia, Dr. Isra, and Dr. Joshua. You're welcome.
We start? Okay. Okay. All right. Yes. So happy to have this, the final panel discussion, which is having a very important topics of the global collaboration of the societies. And so, yeah, we have several things to discuss, but I want to probably introduce each of you that where you are and what's the situation of your society in a very brief, like a minute or something. Okay, maybe you start.
So my name is Isra Lakluk. I'm practicing a pathologist in United States, assistant professor at University of California, Los Angeles. And I'm a member of the African Society of Digital Pathology. I'm originally from Libya, so I'm African.
Norman, please.
Yeah, Norman Serbe. I'm currently president of the European Society. We are having our 10-year anniversary this year, since we were officially founded. Roots go back to 1992. I think we are leading the field of digital pathology in Europe and have a strong network around the world. And I also have the pleasure to serve in most of the other societies also in some role, and but I think we introduce the others. So Junior, back to you.
Okay, so my society is an Asian society. I'm just on behalf of the Asian society. Asia is, as I said, yesterday is full of the diversity in terms of many things, culture, levels of the medicine, and language. And language barrier is very huge. Each country has a different language. it's not English, it's not French, it's not Portuguese, it's not, you know, Spanish. So it's really their own, you know, the country's language. So and we have quite a, you know, the difficulty having those the communication among the all, you know, covered country. But that's the situation. But we are now, you know, moving on to unite those, you know, each small countries, several large ones too, actually, you know, into the, you know, the same direction of the digital pathology. Okay.
Yep. I think on my side, I'm the only entrepreneur and person in the private sector on this panel. But so we have a health tech company that connects hospitals and doctors to remote labs, remote networks of labs and pathologists. So our company does do the networking, but it's not a digital pathology per se company, but digital pathology is a big component of the solution that brings everybody together. And we're operational in Kenya, so and bits of other parts of East Africa. We also have pathologists who collaborate with us in Spain, in Australia, and now, of course, myself in the UK. So that's kind of like our footprint.
Okay, so we are, of course, two big parts missing. One is North America, and the other one is Latin America, South America. Maybe, Norman, you can represent, you know, South America, Latin America?
Yeah, so in Latin America, we have the situation that we just recently, literally 2 weeks ago, officially founded the Latin American Society of Digital Pathology. It's based in Chile. And has also representatives like the African Society, like the Asian, like the European societies from several countries in the region, trying to develop an academic network with a scientific society as a backbone. Yeah, and as I just said, it's very new, just 2 weeks ago, but we are also a very active group there, and I have the chance to also support that group also in the board. So this also gives us the possibility to have a very strong network between those continental societies right now, because all the African, the Asian, the Latin American, and also the European are really covering the whole continent and are like relatively similar, aligned and structured, so it's easy to harmonize things. And with this, maybe back to you, Junia, for talking a little bit about the landscape in North America.
Right. Yes. So then that now I switch my, you know, the position to North America and the DPA, you know, head of my head for the DPA. And of course, North America is quite advanced in terms of those, you know, organization-wise, and also the several the research and academic, you know, the part. And the DPA is actually the huge. The numbers of the member is almost reaching to the 5,000. And it's a little different from the other societies because it's not the 100% academic, you know, the persons composed of the society. It is, you know, combined with the vendors, you know, head with the vendors, and also the academic people, almost the equal number in a board member. But that has a very strong benefit, and also, of course, some difficulty as well. But you know, basically, that the DPA is leading a lot of those activities, in a digital pathology world, and that, you know, also has a very strong, you know, point, as I introduced yesterday. Has some starting collaboration between the FDA and also talking very, you know, closely with the CAP. You know, those, you know, political part, you know, they have a very strong, you know, the points. So, okay, so now we have all of those, you know, the continental level societies are covered mostly, and now we got the question, okay, maybe it's a time to consider about how to collaborate, you know, and you know, how to really, you know, make this, you know, movement together. What's to share? And how to share, so those type of the things. You know, this is probably new to the African society people, but you know, DPA and the STIP and ASDP, those three society have kept this, the discussion for about a year or so. And then they're thinking about, now is probably the time to move forward to redo some, action, items, action point to move forward. So Norman, probably, you were already, we were already discussing a couple of years about this activity, and if you have some, like I say, topics you want to bring out, or, you want to add on to my, topic, comments, you can, start.
Yeah, I think what is interesting, coming back to the topic of the panel discussion, is like which topics are those that we can address globally, right? So with the introduction, you see that we have certain structures around the globe that we can use, that we have a strong network within the people. It's always about the people that are active in, and it's kind of a digital pathology family that really works together with really strong personal ties. I really like this, and it's also the reason of the success from my perspective. But then there's topics that we can address national, and there's topics that we can address regional, like continental, and then there's topics we can address globally. Just giving a few examples. So something, whenever it comes to reimbursement, we will probably not address this from a global perspective, and most likely also not from a continental one. The same is true probably for regulatory topics, which are also rather in the regulatory system. We have the advantage in Europe with the European Commission and having a harmonized regulatory environment. So, but that's very unique in Europe. In all other countries, it's really a national one. But then we have other topics, like we have heard today, around standardization, interoperability, structured reporting, and so on, that can and have to be solved once. And if you solve them twice, you have a problem, right? And those topics are definitely the ones to be identified. So which topics are those that you only want to solve once? Or which are projects that you rather want to carry out on a global structure, asking something from a global perspective? And then this is what we are currently trying to build, like a structure to answer those questions, to identify those projects, to identify those topics, and to make sure that we streamline the activities and the organs of the societies in a way that we don't invent the wheel twice. And like giving one concrete example is we have currently interoperability and standardization and regulatory working groups in the DPA and in AFSDP, and we are also have somewhat activities in this regard in the Asian Society. And so here is now the question, right? So it's interoperability, it's standardization, but there's 3 groups working on this. Of course, there are some connections between the groups on a personal basis, because some people are in all groups or in several. But here we have to differentiate now, because we started from the societies addressing all of the topics, and now we have to think, okay, what is this that really this society should take care in their region? And then this stays, and the other ones are rather combined on a global level to really address this with a global team, with delegates from the different societies, but not living the activity inside solely anymore. So this, on a very abstract basis, is the concept.
Wonderful. Yes. So this is a kind of a roughly the picture that we have keep discussing. Of course, he gave some of the example of those regulatory and also those the standardization. Of course, those are the very important things. But let's go back to the current situation, because we are having this panel discussion in Africa, right? And then those African society probably is so new to these activities. But I really want to know that what is going to be your take, your take that by listening to these type of activities, what do you really feel like? Let's say, what do you want from this activity? What do you want to contribute this activity? What do you want to bring this as a top topic? The priority topics you want to bring up. I want to listen to both of you. Yeah, maybe you can start.
Yeah, this is something of real interest to me. As I said, our company is connecting people and connecting players. So even though we are in the private space, we require our customers to behave in a certain way. So we want our hospitals and our doctors to package samples properly, to take biopsies properly, to have some kind of education. The partner labs as well, we want them to have the equipment. They need to have scanners, they need to understand how to handle tissues, and have the correct processes. And that the pathologists also are able to understand how to do synoptic reporting. And, so we stand in the middle, and if we give a promise to a doctor and say, Dr. So-and-so, if you order a sample on our software, this pathologist will report it in the right way. And the pathologist doesn't have that education, that causes a problem. So it's very important for us when we have initiatives like this, the African Society of Digital Pathology, if it creates those standards so that we can have our pathologists on the continent to have a guiding institution. So if I can give you an example of some of the problems and challenges that we've seen across the continent, because we have received applications. It's just that we've not taken them in because we didn't have an infrastructure to take them in, but we've had people wanting to join our company from Ethiopia, from Congo, from Cameroon, from Nigeria, from Ghana, and we just can't, like, even if they came in, how would they practice? What would we give them? So we haven't actually had them, join us. So, but with this kind of an environment, we can do that. So I feel like the things that we really need is documentation that's relevant for the continent. Some of the CAP protocols, which we haven't put into our software, they're great, but they're not relevant in all cases. So there's things that you can't fill in because nobody does them. And sometimes someone does, some sample types, some certain surgeries are not done here. So there's just a whole lot of customization of global data to the African realities that's important for us to move to the next stage, and so that everyone can practice in a way that they feel comfortable, but that is still standardized.
Okay, understand. So my take is you have two things. One is about mostly educational material that you really need to split inside into America and Africa. This coming from those international activities are great. But the other one is how you really want to focus on something more localized things, which was more like done in Africa. But how to really translate and contribute to our activity? There should be though. There are several things in common. So and we need to think about. But I just got two messages from you. Those two. If I'm wrong, to correct me. Am I correct? That, yeah.
Yes. No, you're absolutely right.
Okay.
Yeah.
All right.
Yeah.
Okay.
Let me leave it there.
And the next, yeah.
Yeah. So I agree with you with customizing the approach how to handle like the problem in pathology practice in Africa. So we starting with the bottom line, educating pathologists. We have very limited access just with, we have an experience to running a survey just to understand the accessible like to WHO book, which is the standard or like the Bible of making diagnosis among African countries. About 60% of participants does not have access to WHO book. Some of them, they are not aware actually about the online subscription of WHO book, which is very frustrated. So come up with a diagnosis and essential diagnostic criteria that we use in the CAP or our staging system, the AGCC or all the management protocol, which is Western-centered. It's customized to the Europe and United States or like North America. So this is not applicable in Africa. So I have been trained in Libya. And I know exactly what's the limitation before moving to United States. So I can see two different aspects of being trained in country with very limited resource, then moving to United States to see different way of practice. We use the WHO book because the European or the American who wrote those books, but those books does not applicable for African. The CAP protocol, it's not applicable for Africans. Also, the structure of healthcare in Africa is completely different from Europe or United States or Canada. So we need to customize our CAP protocol to serve our patient. Many of things like Ki-67 in many tumors, it's not applicable in many labs. Many essential diagnostics, IHC is not available in many countries in Africa. So I think we need to go down to address the bottom issues, the diagnosis first. So I think we need to have many teams, many committees, and working at different aspects. Some focus on education, accessibility for diagnostic and education material, and also speak to WHO to address this gap between the Western and limited resource countries.
Yeah, so I think let's say it's probably the same story, and which already discussed several years as well, is that those diversity exist in the other area like Asia, Latin America, same. Maybe North America is quite uniform. They are pretty advanced, but I think like I say, then that and one of the topics that we are discussing is about writing position paper, or guidelines, or those guidance, or those the basis that people can bring it to localize, and then like let's say guidelines. If we write the guidelines not by the only in a single country, if we have like let's say continental levels of the guidelines that written by the 5 societies, that will basically cover the basis, and then you bring it back to each the area to localize, to add some local issues onto it. That's probably the easiest way to standardize things, and also education was good. That was one of the topics that we had already, and things. Maybe you can also, the Norman, suggest something, that the topics we already discussed and which fit to their request.
So we saw already in some of the presentations here some things that were developed by the different societies already in the past. So, for example, Sabine showed this digital pathology map, right, that we developed in the European Society. It's there. It's literally some resource that everyone can use and that we are also spreading already. And this is true for other topics as well, right? We have a lot of educational content created in the European Society, of course in the DPA, and also lately in the Asian Society. So I think before Africa starts creating the 101 on going digital, you should better look at those possibilities and those content, if there is something, and then maybe create this what is missing, but not mimicking what is there already. Another topic that I see in this regard is that we have the possibility with supporting Africa also with this aspect that you mentioned, with access to the WHO Blue Books, for example, that we could make an alliance, and that would be maybe another topic that we might discuss, to reach out literally as the 5 or 6 societies, whatever, to the WHO, saying like, this is global digital pathology. We see that there is a problem, that there is a challenge that is not addressed yet. We are willing to support. Let's start a discussion, let's start a communication. And this could also be a nice opening for bringing computational pathology into the WHO, which is also something that probably will either be done by us, or there is an AI working group in the WHO already taking care about this also, but I think it's not driven by the digital pathology societies yet, and that's probably something that we could do as well. And then there's, maybe as the last point, and then there's other projects, and I don't want to go into the details which they are, but there is projects in all of the societies already developed where others can just join, don't have to invest that much, but benefit already from what was achieved. And I think this is a great opportunity that both African society, but also the Latin American as the latest founded ones have.
Yeah, so just like one comment going back to WHO, because after we get this survey, we approach for some foundations to help us to conduct a pilot to help certain institution. It's work in progress, and we will use this as a bridge to get more data, to get additional support to establish some digital collaboration within the African countries.
Go on, Noor. Yeah.
No, I wanted to pick up on your last half sentence.
Okay.
Working on research in Africa. I'm not saying you
No,
should
not
not.
research. Yeah, not
but
research,
it's probably
but
not,
just
it's
like
probably not the first thing you
yeah,
should.
yeah. It's not like the first thing, but just to try to solve the base thing. Then we as accumulate more work to show like a proof of concept about why we need the support from those foundations, so we can create a model after we train and we understand the problems with establishing customizing the issue, understanding the issue with implementing the diagnostic criteria and the protocols.
Absolutely, and I mean this is also what we saw here with, for example, what Jordi presented as a very huge network from Europe, and we also have presentations in our congresses and workshops about smaller and mid-sized labs, private labs, and so on. So we like look at the landscape in Europe and like look what are the different models that are existing there, and bring some champions that solved that problem or went through those challenges already and found a way to do that in this environment. And coming back to what was discussed initially, that of course Africa is very different from other regions, maybe best comparable with Latin America. So it's not easy to transport the concept from Europe or from Asia to there. But so that could probably one of the first tasks to look like, where is the success stories in Africa? Yeah, of the different, of like private, public, of different size, university hospitals, and so on and so forth, and learn how they solved it. Because again, you don't have to invent the wheel again, and probably we cannot help from Europe or from Africa to solve the financial part, right? A lot of other things we can support, but I think the financial and the logistics is something that you have to learn from your colleagues here in Africa.
Yes, there is a one in the hand from the Hijab. Yeah, you can comment.
Yes, the idea of this panel is how we can do a tech transfer, a knowledge transfer from the ASEAN, European, or DPA association, and how us, African society, can use as templates. But it's sure that we have to adapt it to our reality, because there is a lot of realities. And decide what is the first step, what's the education, standardization, and like we discussed, we need to know every experience in every continent. Maybe in Egypt, education, digitalization, using digital for education is a good experience. Telepathology, a solution in Kenya is a good experience. Doing research in some computational pathology also, and just to have the template and help us also to have this roadmap and check it with us to go to the threat of as a bypass like we discussed yesterday. But that is maybe the idea, the global idea that we have to write and to have to execute. Like the example of Jordi, what we said, is a good example for us in Morocco. Paul, yes.
Right.
It's very interesting what you said, that the CAP protocols doesn't completely comply. I can tell you a secret that in the group where we're working on for SNOMED, that we also run for Western countries in question that we say, how is this possible that this is in a template? It's ridiculous. Nobody uses this way. So we are now actually. So I think there is a huge difference between the people who are sitting behind the desk and looking at the articles that have a high level and they said, okay, this should be done as a mandatory core element, right? But even we see in Europe that it is not always applicable for us too. So Hisham is of course now in the group. We have also people from the IARC in our group. So I think there is a connection that we have to say, look, fine that the templates are there, nice to have. We even say at Palga that our protocols are based on, not even they are, because the differences are there and you have to make them customized to your organization. The only problem is, I think, when you want to do it in Africa, how are you going to do this per nation or in a bigger region? I think there should be first some work to be done to see. And next to that, for instance, we post our protocols with all the questions and answers and all the SNOMED code for free. So at least if you want to use something, don't reinvent the wheel. But
to get consensus first, that's the most important thing. And I think then that you have to look at what you say, if you have a network, first seek for those stakeholders, the people who are like the early adapters, and talk to them and say, where can we find at least some consensus, and then to see if it's possible that we can make the ICCR, for instance, aware, nice that you have this kind of protocols, but we have to make a sort of addendum for others. Because if we don't do that, then you lose the standardization, because there is no standardization that stops at the border.
Okay, thank you very much. So looks like we have the three things. One is how to standardize things, and there's a standardization like an ICCR and the old WHO and the CAP. Synoptic, but the issue is that's not really spread well. So I think, like I say, maybe this sort of alliance is making a base to spread and show the standard. What is the standard to make a report or a structured report or whatever? That's one thing we can probably do as a topics. Another one, the interesting point was like Norman just also mentioned, and we already talked about quite a bit, is creation of the alliance. We were starting talking from the joint membership and stuff, but I feel like say, okay, like an airplane company. If we are the one alliance, then that we can just say that okay, this is a project of the alliance, and then that we can just collaborate under the umbrella of the alliance to do to show the direction all together, and then that we can collaborate under those alliance to cover those diversity and getting knowledge, getting those the different the use cases and diversity. That's the things. And the third one is, after making this, some standardization, whatever, we have to think about the localization, customization to each country, each location. For that, of course, the local society has to work mainly, but we can also work together, especially in terms of the educational material to share, or reference center, or reference, knowledge like SDP is very advanced to show those the hospital map, which have what kind of structure, and then that some of the occasions are very close, maybe to some of the specific the country or institution of the inside Africa or Asia as well. So those knowledge and the information is probably useful. I think those are probably the three things that I come as one of the common things that we discuss now. Anything to on top of it, if we want to add something to discuss? Because we are reaching to the time.
If I
we
can,
have yes.
Yeah.
2 minutes. Yes.
Yes,
Yes,
I certainly can add something. One of the things I'd like to say is that it's a question. Digital pathology has existed for quite some time, even though it wasn't as widespread, but it's been there, right? These standards have been there for quite some time, like templates and synoptic reporting. Why have they not been adopted in countries with pathologists who have been trained? Because again, training of pathologists has been going on across Africa. It may be low volume, but it's there. So you can't say that they have not been trained in this. But when people go out there to practice, why don't they adopt it?
I can answer your question.
Oh, you can?
Yes.
Okay.
Okay.
Can I give my experience from
Yeah.
what I've observed working with all these 100 pathologists or so, and some of them then applying and joining our network. I found that people gravitate towards the easiest thing to do, and so they do what's easy, because there is no consequence. Why fill out a whole long template if you can fill out the shortest and go home and nothing will happen to you? So the reason why people comply in more advanced countries is because there is a consequence to not complying.
That is one of the interesting message that we probably have to make it to something realistical, the standardization, right? Yes, I completely understand. Like this gastritis, why we have to fill up all of those 20 questions, right? It's going to be just maybe the 1 minute diagnosis is going to reach into to the 5 minutes, something like that. So anyhow, but important thing is we need the education, right, and the standardization. So, and,
Yes,
of course,
we need
of
those.
course, it's very difficult to force people to do, the same thing.
You can't force, but you can create incentives.
Right. Okay. Any more last word?
Yeah, so my input, I think in Africa, or like based on my experience being in African country, I think the health system. So the report, the synoptic report, and the diagnosis is not for the pathologist, it's for the clinician to decide what's the next step, what is the next step to manage. When we don't have, if we cannot apply the staging or the grading, that will not, we don't have the utilization for those information, actually it doesn't matter for the clinician to have them. The clinician, they don't ask for those information. It's sad, but this is a reality.
100%.
Right. Sorry. Yes, I completely.
These are the real issues. Yeah.
That's true. The reality is, of course, we have a huge problem in several different, fields, and we can keep this, discussion for hours, but unfortunately, we're past the time. But one thing that is clear is that I think, like I said, this type of discussion can be done in a continental level society network, and each of them we feel like I said, what is important, what is most important, do the triage, and then the list of some project that we can do together. I think I say this is a very good start. We just know that we are looking to the direction of each collaboration of the 5 continental society levels of the thing. So alliance. Now it's the next time is we need your collaboration to give your voice to us, and then we'll think in collaboration to move forward to the next era. Yeah, any last word you want to?
Yeah, maybe just last word for like homework for the Africans and also the non-Europeans here in the room. We will have a chance at the European Congress in Graz to have all our allies, all the continental societies, also beyond the digital pathology societies, also a lot of national ones and European other federations and so on there with the presidents, and we are going to continue this discussion. So the homework is come with ideas, come with projects, come with proposals, and we are going to discuss them in Graz. Would love to see you there.
Seems that it's going to be very fun. Okay, thank you very much for joining.
Thank you.